Well, good morning, everyone. Welcome to the Gilbert W. Beebe Symposium. I'm Charles Ferguson. I'm the Senior Director for the National Academy's Nuclear Radiation Studies Board, which oversees the Beebe Symposium. This symposium is named in honor of the distinguished National Cancer Institute radiation epidemiologist, Dr. Gilbert Beebe. He passed away in 2003, soon after we started this symposium series. He was one of the designers and key implementers of the epidemiological studies of the Japanese atomic bombing survivors. These studies are still being carried out today by the Radiation Effects Research Foundation. Dr. Beebe was also the co-founder of the medical follow-up agency that performs long-term studies of veterans' health. The Beebe Symposium focuses on themes related to the radiation sciences and radiation health effects. It's great to see a number of our board members in the audience, or as our board members know, they were unanimous about a year and a half ago when we started planning this symposium, that the symposium should be on the topic of AI and ML applications in radiation therapy, medical diagnostics, and radiation occupational health and safety. Well, not a day goes by that we hear more and more about AI and ML. It's growing rapidly, exponentially growing. And for this symposium, we'll see that use is increasing across academies, industry, and government. While each of these three fields are distinct and have unique applications and needs for how they apply AI and ML, we found that the common theme of radiation sciences and health effects allowed us to weave these topics into a single symposium. Thus, we are excited to discuss both specific applications for each field and identify commonalities and themes among the fields. Each field is at a different stage in applying AI and ML models, and we hope this symposium can act as a platform to share ideas and methods between the fields. It took a village of sponsors to make this symposium happen. We have numerous sponsors, and no particular order here. I'm going to call out the Department of Energy from various offices, including the Environment, Health, Safety, and Security Office and the Office of Environmental Management, the U.S. Nuclear Regulatory Commission, the Gordon and Betty Moore Foundation, the Richard M. Lounsbury Foundation, the American College of Radiology, and the National Academy's Thomas Lincoln Casey Fund. On behalf of the National Academies and the Nuclear Radiation Studies Board, I also want to thank our sponsors for their support of this symposium, and thank DOE's Office of Science, in particular the Biological Environmental Research and Isotope Program, and the National Institute of Allergy and Infectious Diseases, and last but not least, the Food and Drug Administration's Office of Radiological Health for their ongoing discussions and support during the planning of the symposium. Now I want to turn to thanking the organizers and the staff organizers of the symposium. I want to recognize first the co-chairs, Dr. Leo Chang, National Academy of Engineering member, and from Dow Chemical Company, and Dr. Shaheen Dooji, who is the symposium co-chair from Georgia Institute of Technology. I want to mention that both Leo and Shaheen are also serving on two of our advisory boards. Leo on the Board on Chemical Sciences and Technology, and Shaheen on the Nuclear Radiation Studies Board Advisory Board. We also would like to thank Dr. Caroline Chung from the MD Anderson Cancer Center, Dr. Sylvain Coste from NASA, National Aeronautics Space Administration, Dr. Anyi Lee from Memorial Sloan Kettering Cancer Center, and Dr. Seferino Obisema from the National Cancer Institute. Biographical sketches for all the organizing committee and the presenters are available in the briefing book outside the auditorium and online. And I also like to especially thank Dr. Daniel Moreau, the program officer at the Nuclear Radiation Studies Board, who has done tremendous effort in so many ways, in fundraising, organizing, and intellectual input into this symposium, is serving as a staff director. And we have an incredible staff team in the back, and feel free to thank them during breaks for all their great work in organizing the logistics. We have more than 80 individuals registered for the symposium to attend in person. They're not quite all here yet. It's still early in the morning here in DC. Hopefully they'll be filtering in. And we have more than 200 registered to attend virtually. And as I think you'll know, that we'll also be uploading the webcast recording to our project website for future viewing. The National Academy of Sciences will also issue a National Academy's Proceedings report within a few months after the symposium concludes, and we expect that everyone registered for the symposium will receive a notice by email when the report is released. Now, I'm very pleased and happy to introduce our co-chairs, Dr. Leo Chang and Dr. Shaheen Dooji, who will moderate the opening session. Leo and Shaheen, please come up.
Good morning. Thank you, Charles. For a quick introduction, my name is Leo Chen, Senior R&D Fellow of the Dow Chemical Company. We are very happy to be co-chair of this year's symposium on the very timely topic of the AI and machine learning. Shaheen?
Hi, good morning. My name is Shaheen Dooji, Associate Professor in the Nuclear and Radiological Engineering and Medical Physics program at Georgia Institute of Technology. So for this opening session, we aim to bring a broader discussion to the AI community and to share insights from AI developers and researchers on balancing the benefits and risks of rapid AI innovation. The talks over these next 2 days will address key responsible AI principles in AI model development, human decision-making in AI, ethical considerations, uncertainty propagation, data trustworthiness, and the safe implementation and effective use in clinical care and beyond. Throughout the symposium, we hope to explore these themes and contextualize them through specific AI and ML applications on which the speakers will present, and with the following panel discussion, which we encourage your participation.
Additionally, we want to identify common themes throughout the symposium. One theme we hope to explore further together to hear from multiple angles is how AI and machine learning application will be able to help to reveal those, whether this is to a patient or to a member of the public. While this may not be the only reason for a speaker-specific use of a model, but it may be the end result that we are all hoping for. This is just one example of the potential themes that we hope to hear.
All right, so for some general housekeeping, our sessions will start with presentations from our invited speakers, followed by a moderated panel session. So we ask that both in-person and online participants use the virtual platform Slido to submit questions to panelists that the moderators may choose from during the panel discussion. So the Slido can be accessed via a link on the activity page on the website, just below the webinar for online participants, or by scanning a QR code embedded in your agenda and available for in-person attendees to also scan and take them to that platform. So staff will save your questions even if they're not immediately answered during the session for consideration in the proceedings following the workshop. And now, with that out of the way, we will get started with our program. To start off the session, we have David Rue, Microsoft's Global Chief Medical Officer and VP of Healthcare. He will then be followed by Mike Tilkin, Chief Information Officer and the Vice President for Technology at the American College of Radiology. Thank you. Come on up. So I think you should have your slides. Okay. And then we'll continue with the panel there. Very good.
Good morning, everyone. My name is David Rue. I'm the Global Chief Medical Officer for Microsoft. And one of the most common questions I get asked is, what does the Global Chief Medical Officer for Microsoft do? In fact, my parents would like to know the answer to that as well. I think the best way to think about it is I'm a bit of a translator, translating what we see on the clinical side, the challenges we have in healthcare, with all the amazing technology that has not only been developed, but also continues to evolve. And it's an ongoing challenge to stay on top of both, to really understand how this can be applied in the real world setting. So how did I get here? Well, maybe if we were to go back in time, in the 1980s, I was an undergraduate major in college, and my thesis, my studies were in computer science, and my thesis was AI in healthcare. So this is in 1988. There wasn't a whole lot of AI in healthcare going on at that time. But since then, there's been some dramatic improvements, and largely driven by the ability for us to have higher compute capacity, but just incredible innovation in this space. And what I wanted to share with you are some of those innovations that we're seeing, not only on the technology side, but on the application side. So I've got a bunch of slides here that I'm going to use as a guidepost for this discussion. If we go into the next slide here, I want to break the discussion into 4 components. And what I wanted to do is I wanted to organize this into something that may hopefully at some point be the final strategic plan, but this is what HHS has been suggesting as some of the top priorities. One around what are the innovations, how do we ensure trust, how do we democratize it, and how do we enable an entire workforce to be able to take advantage of it. So I'll touch on all 4 of those. So let's just jump right into it. Let's go into the next slide here and talk a bit about one of the innovations. And I think when we talk about AI, we generally speak about things that are right in front of us. I'd say the majority of use cases that have been presented to the healthcare industry are related to inefficiencies in care, ways that we can make our lives better, improve the overall experience through the use of these technologies. And I think that's an incredibly important starting point. But if we look at the opportunity that's in front of us, it may actually not be with the things that are in front of us directly, but are the things that we don't see. And it really gets to being much more proactive. We talk about this concept of proactive care very frequently, where we're talking about, if only we could have prevented this illness, or if only you would have done something earlier. And generally speaking, our approach has been limited by a very small set of tools. Education, teaching people about early signs and symptoms, giving people a better sense of what they need to do to stay healthy, perhaps some vaccination programs and some screening programs. And that is, by and large, most of what we do to be more proactive. But we actually have a new tool in that armamentarium, and that tool is AI. We have an ability to be able to potentially screen very large populations and identify individuals before they get sick, and allow us to be able to bring those individuals to care. So let's move on to the next slide here. I want to talk a bit about the current health system. And if you think about the way the system is designed, it's designed where an individual has to see a clinician, typically in a clinic or perhaps in a hospital. And once they're plugged into that system, there's a series of meetings or encounters that occur on a regular basis. And that's the world that we live in within healthcare. But there's another world, and that's the world of people that didn't come to the healthcare system. There are individuals that are at risk for disease. There are individuals that have a disease and they don't know about it. And there's individuals that have a disease and they don't realize it's progressed. And it's oftentimes that last group that are the ones who, by the time they come in, it is too late. They're coming in with a heart attack, a stroke, and that is the group that we wish we could have actually had an impact on. Now, we have an opportunity to be able to apply AI in a variety of different formats, and I'm going to share with you several examples of how AI could be applied to be able to address that group that traditionally we don't see. Let's move on to the next slide here. I'm going to start with a common procedure that every one of us undergoes at several points throughout our lives, and that is the routine eye exam. I think if you have glasses, if you need to get your driver's test, if you're an older individual, getting your eyes checked is very common. Traditionally, what we've done is we've taken that image, and that image stays on that machine, and nothing more else comes about it. But we actually have now an ability to take AI and apply it on these retinal images and be able to make a series of potential diagnoses everywhere from screening for diabetic retinopathy to potentially cardiovascular disease, hypertension, chronic kidney disease, ophthalmologic conditions, and even neurovascular conditions. And why is that? Because the machine, well, there's two different ways you can do it. One is through a fundoscope, which is sort of the ability to use this two-dimensional mechanism to capture the image. But the 3D image captured through an OCT machine allows us to be able to get to submicron levels of the image for identifying arterioles as well as the nerves and the surrounding structures. And it allows us to be able to apply AI on a much more robust set of data that it's almost like getting an MRI for pennies in a very highly accessible manner. So this has actually been done in the past. So this is not a new concept. Many people have said, oh, we've seen this done before. But what's happened very quietly is that there's been some innovations that have occurred beyond the AI. And it largely ties into an automation of the data acquisition process. Because the prior process required 2 images per eye, and when you would take the first image, the pupil would dilate or would constrict, and then you would have to wait 7 minutes before it would dilate again, and then you take the second image, and then you go to the next eye and you do this. And so it was anywhere between 18 to 20 minutes for a clinician to be able to do this, to be able to access this. So the issue at the time wasn't so much the technology, but it was really about the workflow. And on top of that, they didn't get paid for it. So this was sort of a challenge when you think about it. And those are oftentimes some of the biggest challenges we see when technology is trying to be adopted. Well, what's happened? Well, now it's completely automated. There's a machine that allows us to be able to do this in 2 minutes with no intervention, no clinician intervention. So we could envision a scenario where this could be applied in settings that are workflow compatible and allowing us to be able to take care of patients in a much more streamlined manner. So at Stanford, they've been doing this for a while. They have a bunch of satellite clinics where when a person comes in, they will actually get not only their vital signs, but they'll get their eyes checked. And as part of that routine eyes examination, they will get the screenings. And they've seen dramatic results. HEDIS scores are one area. HEDIS scores in some places have gone from 20%, 40% to well over 80, 90%. And the overall HEDIS scores for the system have increased dramatically. We've seen in some organizations, this has actually been something that they can not only break even, but potentially even generate some revenues because of the CPT code that is now available for this. And so it is actually one of those rare instances where not only do we have technology that could enable this, but we also have a capability for this to be applied in a workflow compatible manner in a way that aligns incentives. So let's move on to the next slide here. As I mentioned before, diabetic retinopathy is the starting point for this. And if we just did diabetic retinopathy, this would be a fantastic opportunity. But the real opportunity is actually thinking about this as a mechanism to be able to portal into the entire body. And we now have an ability to potentially apply AI on these images and identify multiple medical conditions. So I mentioned a few of them. Cardiovascular makes sense. You can look for atherosclerotic disease on the arterioles, hypertension. You can look for hypertensive retinopathy. But things like chronic kidney disease have always puzzled me. Like, how could you actually identify a kidney disease unless it's associated with diabetes or hypertension? And there was an interesting study in Nature that caught my attention and I think gave me some insight, as hopefully maybe you all as well, as to potentially how this could work. And what they did in this study is they looked at the choroidal and retinal membrane, and they found that as the renal function declined, the membrane thinned. Now, interestingly enough, when the patients were transplanted, the membrane returned back to normal. It was actually a dynamic indicator in the eye of what was going on in the glomerulus, which is interesting because you don't really think of the eye as being related to the kidney. But the vessels that we have in our system are not sort of specialized to just do one thing, but oftentimes they are representative throughout the entire body. So when you have systemic diseases, they impact every arterial, blood vessel, and membrane in similar ways. And we're starting to see that these type of associations are there for not only the cardiometabolic conditions, as well as ophthalmologic conditions, but also even potentially neurovascular conditions. There's a significant amount of research now being applied in the area of Alzheimer's MS, Parkinson's, and a variety of other conditions, so that it gives us greater insight that this could, in fact, be a one-stop shop, not only for screening, but potentially for monitoring conditions. Let's move on to the next slide here. I want to talk about another way that we have identified that we could identify individuals. And this is something that every one of us within a health system has access to, and that is the medical record. Now, if we were to have kind of thought of an ideal world would be every clinician practices evidence-based medicine and we have zero gaps in care. The reality is that's not the case. There's wide variability in care. And in fact, if you do an analysis on the medical record, you will find not only gaps in care, but you will find opportunities to identify individuals that have certain diseases that are in retrospect obvious, but in the time of seeing the patient, not as obvious. And here are just multiple examples of several conditions that have been identified and gaps in care. I'll give you an example in oncology. What we have seen is by running AI on medical records, we find a large number of individuals for whom biomarker testing is not performed. And then when it is performed, the results are not concordant with the treatments. So it's almost as if you ordered a test, but you didn't do anything about it. You would think that doesn't occur very frequently, but it's actually pretty shocking because organizations don't necessarily look for these type of things. We focus a lot on the quality measures, and if it's not a quality measure, these things kind of slip through the cracks. AI can help identify these individuals, and we are already seeing programs around the country where they're looking at AI just on medical records to be able to identify gaps in care in individuals that are eligible for certain treatments. Let's move on to the next slide. Obviously, that has a huge impact also on clinical trial enrollment and other ways that we can get patients to be seen and managed better, more effectively. This is just a continuation in terms of the workflow. Let's move on to the next slide here. I want to talk about another modality. So we've talked about imaging, specifically the eye imaging. We've talked about EHR. I'm going to talk about voice. Now, voice is becoming a very common way for clinicians to be able to start interacting with the medical record. In fact, we've had dictation for quite some time. Now, dictation has moved on to something called ambient, which is the ability for clinicians and patients to now have a conversation. That conversation is transcribed, but is also converted into a note. So at the moment that you're done with your encounter, the note's there. And there's been widespread adoption of this type of technology. It works very well. But where are we heading? We're heading to the ability for us to now take advantage of that encounter now being streamlined through a voice conversation and being facilitated by the fact that it saves clinicians 5 minutes per visit, it improves satisfaction, so that you're seeing widespread adoption. But through this modality, because the voice has been captured, we can run a series of AI on the voice and the medical record at the same time. That prior example I talked about, where we have an ability to look at the medical record, it is now, we have the capability to surface up at the visit clinical decision support that says, here are the gaps in care, here are the things that you should be considering. There's AI that can be applied on the voice and identify voice as a biometric to identify if an individual has certain characteristics in the way that they speak. And we're not talking about what they're saying, but how they're saying it to identify whether or not they're depressed, stressed, anxious. And it's been validated against known screening tools. And so why is this important? Because today we rely very much on an individual filling out a survey to ask whether or not they have certain feelings or symptoms. But we have now an ability to capture this behind the scenes through AI. So it gives us a brand new set of tools, but having it done seamlessly is extraordinary. Let's move on to the next slide here. I'm sharing with you here some results that were shared with us by Intermountain Healthcare, who's been doing this not only for their patients, but also for their clinicians with everyone's consent. So you actually have a mechanism to not only identify, but quantify the level of anxiety and stress for these individuals. And obviously this could be helpful in terms of monitoring burnout as well. Let's move on to the next slide, please. As I mentioned before, this is giving us a new opportunity to start thinking about if we have all this data collected, rather than having individuals, physicians in particular, identify if patients are eligible for clinical trials. The AI can do this, and we have already seen so many great opportunities for AI to be able to do this. The tools themselves are extremely good. If you think about generative AI, it does three things very well. It finds things from different data sets very quickly. It synthesizes it and matches it against existing criteria, and it presents it in the right format. And those things enable in more efficient clinical trials matching and allowing us to bring individuals potentially to better treatments. Let's move on to the next slide here. So what I've shared with you, I would say, is the first step of a broader population health strategy. Many times people think about the opportunity to identify a disease as being curative. Well, unfortunately, there are two other elements that we have to consider. And as we've been doing these initiatives with clients across the country and even throughout the world, we've come to realize that these second and third may be the biggest barriers, specifically in underserved and rural communities. Because if we identify a large number of individuals that have certain conditions, that have certain needs for treatments, in the underserved and rural communities where this may have the greatest impact, it's those communities that oftentimes have the least number of resources. So what you're doing is you're bringing a large number of individuals to an already packed system, and all it does is it increases wait times and decreases our ability to be able to deliver care on a timely manner. So what we actually have to do is we have to focus on the second one, the second category, which is about identifying who needs to be seen first. So risk stratification, appropriate triage, and then capacity building. And what we're finding is that the capacity building may be extremely important because, in fact, many of these specialists and even primary care have wait times that are already very long. When we started looking at the area of ophthalmology, ophthalmologists in general, 80%, we did a survey, an informal survey of ophthalmologists. We asked them, what percent of your patients are, we'll call low risk and could be seen by an optometrist? And it turns out that about 80% of the patients that an ophthalmologist sees on a daily basis are, quote, in that low risk category. Now, these are individuals that have, let's say, routine diabetic screening, things look fine, I'll see you back in a year. Now, if we were to be able to identify higher risk individuals and bring them into the work queue so the ophthalmologist could be practicing at a higher level of complexity before using the skills that they have, bring the lower risk group to optometry, which, by the way, is the fastest growing group in healthcare. We have now created a mechanism to optimize our efficiency across the broader population. And that's what we're doing right now. So there's an ongoing initiative. You're going to hear about it probably in the coming months. There'll be a publication coming out shortly also on this, on an initiative called the Alliance for Healthcare from the Eye. It involves several government agencies. It involves multiple healthcare systems, payers, and a bunch of other folks. And the goal is to screen the entire U.S. population for advanced stage chronic disease, leveraging this technology, simple, easy to access, highly affordable, easy to use, and allow us to be able to demonstrate that this works not only in academic medical centers like Stanford, but in rural America and other places throughout the country. And that is something that I look forward to sharing with you when those results are available. The goal then is to, once you've identified the capacity, you've brought them in, is to actually get the patients there. And we oftentimes think that by doing all of the first two, that the patients automatically get there. There's a variety of reasons they don't. First and foremost, they may have no idea as to why they need to come in. Education is very important, engagement, and then addressing social determinants. And all of those things are necessary if we want to be able to build a comprehensive population health program. And ultimately, this is what we're looking at with this initiative. Let's move on to the next slide here. So I want to talk a bit about, within this, it is unlikely that one organization can address all of these components. And this is part of what we find ourselves trying to do. Connect partners that work in each of these different categories. We have partners that I've shared that can identify individuals through imaging, blood, biomarker, patches, EHRs. We have organizations that can help risk stratify and build capacity that have some amazing capabilities. And we have folks that have built digital technologies that educate, nudge, and provide ongoing information through chatbots and other AI mechanisms. So AI being applied in all three of these categories, but hopefully in a coordinated manner allows us to be able to kind of solve these problems. So let's not think of AI as solving one problem, but AI solving multiple problems, but are all stitched together. A good example would be if we think about ambient clinical intelligence, I think many of us think that ambient clinical intelligence is generative AI because you're generating a note. But the reality is, if you broke that up into the sub-steps of an individual that, who's speaking, AI is identifying who's speaking. That's not generative AI. That's what we'll call traditional AI ML. The words that are spoken, converting them into things that are understandable within a medical informatics context, the SNOMED, ICD-10 codes, that's traditional AI ML as well. Creating the note, that is generative AI, and then integration into the medical record is traditional informatics. And so what we did for this type of offering is we stitched together a whole series of AI, different types of AI, to be able to create a seamless approach. This, what we're describing here, is at a macro level, stitching together programs that enable AI to be applied and the handoffs are more seamless. Okay, let's move on to the next topic. I want to talk a bit about trust. So if we go on to the next slide here. In March of 24, several organizations got together. It was about 16 health systems, and they were very focused on taking the key principles of responsible AI that have been talked about by many organizations. We're talking about trust related to transparency, explainability, validation, and bias assessment, you name it. The list goes on. But the question was, well, how do I actually do it within my own institution? What's the process, and how do I do it efficiently? Similarly, this conversation was had not just in the United States, but also outside of the United States. And several European hospitals then decided to get together to try to address that. And that's was the launch of something called the Trustworthy and Responsible AI Network. So what is TRAIN? Because I think there's many consortiums out there, and it's confusing to understand why we have so many. But if we go on to the next slide, I want to kind of delve deeper. Well, the goal for TRAIN wasn't just about identifying what we needed to do, but actually to show how we can do it in an efficient manner, time, resource, and cost. Because no matter how you slice it, it's going to require some effort to be able to implement responsible AI. And what we realize is that the only way we're going to be able to accomplish this is we're going to have to first leverage technology. So let's not just do it manually, as has been done with meetings, everyone reviewing the models individually, but let's see how technology can help us. Let's collaborate with other systems so that we can learn from them at the model level, and let's find ways that we don't leave other systems behind, because no matter what we do, we'll always have those that have less resources and may not be able to do as much. And so with those as the goals, we'll go on to the next slide. We began to focus on, I'll call 4 questions, but really there are 5. The first was we wanted to make sure that we were able to identify the AI that was running in your system today. It's not a simple answer, because the question is like, really, well, what do you mean by AI? And so I think we've been sort of narrowing in on, well, let's focus on the clinical AI. And even the definition of clinical is a little ambiguous, but we're getting to the point where we're saying we want to focus on things that, we can't improve what you can't measure, and you can't measure what you don't track. And so we want to track this. So this whole concept of registering these models in a standardized manner using something called model cards has come about, and this is really one of the first steps in that process. The second is really around testing, and this is something that we don't do a whole lot of. We sometimes assume that these models have been rigorously tested, and because of that, we can just let them run in the wild and it'll run fine. Well, that's maybe the old way of thinking. I think now with AI ML, we're realizing that for a variety of reasons, we have to test it on local data sets, and we have to continue to monitor. So I actually kind of break it up. Testing is really both pre-deployment and post-deployment. And when we monitor, it's not just monitoring the models, but it's also monitoring the outcomes. And some of the outcomes are expected and some are unexpected. So now we're kind of getting down into what is the impact of this particular intervention? When we look at monitoring for outcomes, now the question is are we monitoring it in the broader population, or are we also looking in subpopulations? And this gets into the whole issue of bias. So we're looking for, is there bias before we deployed it, and also in the impact, are we seeing bias? And lastly, how are we doing it in a way that we're governing this and overseeing this in a responsible way? So let's move on to the next slide here. I want to talk a bit about, there are technologies today that allow us to be able to do many of these things. There's several things here listed on here that I think could be very helpful, things that people may not even realize exist. technologies that allow us to identify hallucinations in large language models, could be useful for quality improvement, could be useful for providing a quality check before we deploy it. There are ways that allow us to be able to assess for bias. There's many things that we have, a lot of tools in our armamentarium. Let's move on to the next slide here. But what we also realize is that simply monitoring and applying these tools is not sufficient. And largely it's because we're moving away from just looking at the models to now looking at the outcomes. And when you look at, when you change the conversation from looking at models to outcomes, there's a new variable that gets inserted, and that's implementation. And why is that important? Well, it's because if we go back in history and think about like when the electronic health record was rolled out, we assumed that because of this amazing technology that we would reduce mortality, that we would improve overall outcomes. And when we did the results, we figured that the EHRs that had the best user interface, that had the best class scores, would perform the best in terms of outcomes. Well, the results actually didn't show that. When they did these studies, they found that the EHR, the performance outcomes, was generally speaking the same across all EHRs. But where they did see the greatest variability was within the EHR, the same EHR. And what they were finding, so if you look at this, this is actually, they were looking at medication errors and patient safety. Each one of these vendors here listed on the right-hand side is a different EHR. You can see wide variability within each of the different EHRs. And what they found was that this EHR was being implemented in different ways. So it actually is the same concept in AI. So I'll use an example, sepsis. We oftentimes think of sepsis as being sort of a general model. Well, there's really two questions to sepsis. One is diagnosing sepsis, and the other is predicting sepsis. And so the question is, what are you assessing? Are you diagnosing it or are you predicting it? And very often, what we found when we go to the prediction models, that the models that perform less well could potentially even have better outcomes. Seems like a paradox. How could you possibly have a model that performs less well in terms of your diagnostic test and have a better outcome? So let me give you an example. When you think about a sepsis model that, for instance, has the highest level of specificity and sensitivity, it may include variables such as a positive blood culture and positive serum lactate. So if you're a clinician, of course, if you're suspecting sepsis, you're going to have those variables in there. And what you're going to do is you're going to actually, it's probably a really good measure for identification of sepsis, but not necessarily for prediction of sepsis. So if this is incorporated into your prediction model, it looks good on paper, but the reality is it's not very useful because that's not the model that you care about. It's really how you implement it. And what we found is that when you implement it by interrupting the workflow and giving it to a clinician that's super busy, and if there's any false positive, they basically ignore it, to giving it to a nurse and a team that is overseeing overall sepsis patients, you see the better results with the nurse. And I think this is now giving us insights that the implementation may actually be one of the most important components to ensuring successful outcomes. And the AI and the technology would be important to validate, but it may not be the key driver. So let's move on to the next slide here. So when we think about implementations, as we think about capturing this information, one of the things that Train and several of these organizations are looking to do is not only capture what the outcomes are, but how are we implementing it? So we want to understand who's receiving the output, when did they receive it, how did they receive it, what happened next, and hopefully by looking at the results, the goal for our benchmarking of these outcomes is not necessarily to say that, hey, you're doing better or worse, but it's a quality improvement tool that allows organizations that are perhaps performing lower on the outcomes to be able to see, whoa, what is it that the better performing sites are doing so that we can maybe adjust our implementation and continue to raise the bar. And so let's think of this not so much as assessment, but more as quality improvement and performance improvement. That is one of the areas that we see happening with regards to responsible AI. It's now becoming less about certifications and assessments, and now becoming more about let's continue to learn from it. Let's go on to the next slide here. I want to talk a bit about democratization of AI. So if we go on the next slide, I want to share a little more details on this. Traditionally, what we've seen is that there are many organizations today that are trying to build their own models. They are doing a lot of effort that's sort of reinventing the wheel. And these models are oftentimes very difficult to build. It involves multiple different modalities. You can see here what we are finding is that EHR data is used very frequently, imaging data is used frequently, genomics data, but not the combination of those. And once we start thinking about the combinations, this ends up giving a much more holistic picture around what's going on. And by putting this together in a multimodal data set that's been well curated and allows us to be able to apply AI on these different modalities, it allows us to be able to do three things. And I think it's very important that we realize that the opportunity kind of falls into these three categories. The first is it allows us to be able to identify risk categories, low, medium, and high, and then visualize that so we can actually see that. That's the second thing, which is directly related to that, is we can then cohort patients that say that these patients are very similar to the ones that we've seen, that in this entire database. So if I wanted to actually ask the question, what is the outcome for this particular patient cohort that we've never had a clinical trial on, but we've got an extremely large database on, and I want to understand what the longitudinal outcomes are, then the opportunity to be able to understand that could be done through cohorting. And then that leads to the AI for predicting. I want to predict whether or not you're going to actually have a certain outcome. And those are the three things that we'll traditionally see that we need to continue to do. Let's move on to the next slide here. So what we're now starting to realize is that great opportunity to do this, a lot of reinventing the wheel. Can we help accelerate this and make this so this is accessible to a larger number of organizations? And this is now getting into the concept which I talked about before, which is creating what we'll call adapted multimodal AI models so that organizations can take advantage of this and not have to reinvent the wheel. When we look at these models today, there's a lot of reinventing the wheel by, and I'll use imaging as an example. The first AI task is identify the structures. Okay, so I want to find what is the structure, where's the heart, where's all the vessels, things of that sort. I want to know what are the boundaries. And being able to do that is, I'd say every single group has to do that. That is try to build a model, a foundation model. Then you want to be able to start taking that and apply it to your own data set, your unique data set, and really fine tune it to ask specific questions about maybe cancer subtypes or perhaps other types of things that you haven't really looked at. And this then gets into what we'll call fine tuning with regards to the specific components. And then the LLM is actually applied on top of this very unique data set as a general reasoner. It allows you to be able to ask questions of the foundation model, perform tasks, and generate results. This model of approaching this through this embedding model adapters and general reasoner is much more specific and less prone to hallucinations and other things that we have oftentimes associated when we apply one model across a broader data set. And for this reason, there's a large number of effort, if we go to the next slide here, to be able to apply this in ways that will allow us to be able to then enable further research. So this is just an example of some of the work that's already been done. Providence has an extraordinary large data set on this of pathology slides, 1.3 billion slides that cover 28 cancer centers, over 30,000 patients, 31 major tissue types. We helped them build a foundation model on this, allowed us to be able to do prediction of gene mutations, cancer subtyping, and it's been made open source. A lot of these are now being made open source to accelerate the development. If you go on to the next slide, there's a similar example. Actually, I didn't have this, but there's another example on other types of imaging modalities. As we start thinking about using these technologies, we need to think about how this can be applied, not only in academic medical centers and large health systems, but also in rural hospitals. As we've gone down the path of trying to help rural hospitals on the journey for AI, we've realized that we've actually had to take a few steps back. One of which is that there isn't exactly the same level of infrastructure that is necessary. So to do that, the first next step was access to affordable broadband. So there's been a significant nationwide effort around that. The second has been around enabling access to cloud and to ensure that the cloud access provides cybersecurity. So that was something that was rolled out last year. Rural hospitals now have access to free 1-year access to cloud and cybersecurity programs. On top of that, there's been a Rural Health AI consortium with something called the Rural Health AI Lab, where they're building out AI applications to focus on, we'll call financial health, so to help them stay afloat. And if you go on to the next slide, there's been significant amount of hospitals. Right now, we have about almost 550 rural hospitals that have participated in these efforts. And now we're getting to the point where we're starting to realize that the Trustworthy and Responsible AI Network and some of the other programs around the Alliance for Healthcare from the Eye could be beneficial. I want to close with the last, if we just go to the next slide here. To do this, it's not just going to be about technology. It's going to be about our ability to work in collaboration with others. I think many of us have heard of the hub and spoke model. It really is an opportunity for higher resource settings to be able to work in collaboration with lower resource settings. Resource cost sharing, technology sharing, best practice sharing, privacy preserving collaborations. These are all going to be essential components of this. So let's move on to the next slide here. In order to do this, obviously it takes two to tango. It's not just about data sharing. But it's also about ensuring that the model developers also feel confident that their models will not get exposed. So federated learning obviously enables the ability for us to feel confident that the data will not get exposed. But in some cases, you will find that the model developers will not want to do that because they have to expose their models, and it's highly sensitive IP. And so there has to be some mechanisms around confidential compute, which is a secure enclave where the models and the data can go in, allow for the analysis, and neither the AI or the models or the data get exposed. Something called data in use encryption, but we can talk about that later. Let's move on to the next slide here. I know I'm short on time, but let me just close with just a few final comments here. We know that AI is going to transform or has the ability to transform healthcare. It doesn't matter if people are resisting, they're afraid, they're going to lose their jobs, and we don't have jobs for them. So let's move on to the next slide. What we are realizing is that we're in a new transition state. It's similar to what we've seen before with other technologies, but this technology transition revolution is going to be impacting knowledge workers. Unlike people with manual jobs being impacted, this is going to impact folks like clinicians. It's going to impact lawyers, engineers, a whole bunch of other folks. And McKinsey believes that the next generation of jobs will be in this group called AI translators. This is the group that we actually have to start thinking about how do we build a job for. So in order to do that, there's a three-step program that we have now been working in collaboration with multiple sites across the country. First is education, just teaching people the basics about what AI is and the ethics and things, and keeping people on track. The second is around skilling, so people learn how to use tools like prompt engineering so that they can be more effective. And the third is something that requires us to think about what those new jobs will look like. We know AI can transform the job of a call center agent, of a legal clerk, of a variety of other folks. We need to specify what those new job requirements will be, and we have to build programs that allow for individuals to not only get a certificate, but also potentially get a job. And that's an effort that's going to require collaboration with academia and industry to be able to create those channels. Let's move on to the next slide here. And so this is something that we are now starting to realize it needs to be done rather urgently because many organizations today are only focused on the certifications. But if we can raise the bar and focus on job creation, it could potentially align so many incentives. This is just an example of the program that we're starting to realize that needs to be applied. Just given the short amount of time, I'm not going to have a chance to go through all of the details, but let's move on to the next slide here. So what I've shared with you are several categories of where AI is making an impact. It's making an impact in terms of amazing use cases. Think not just about what we see in front of us, but what we don't see in front of us. Has an opportunity for us to be able to better understand how we can apply AI to improve quality and safety, and largely that's going to be built on trust. Trust is something that it takes time to build, and hopefully by building in the processes that allow us to be able to understand that the models are working, that they continue to achieve the results we're looking for, and by putting in programs that support individuals so that they can feel confident that they're doing what's necessary and they have a job that's safe, will allow us to be able to thrive in this new world. Thank you very much.
Thank you. So we'll reserve our questions for the panel part of the program. So next, I'd like to ask Mike Tulkin to please join. from the American College of Radiology. So as we're getting you set up here, Mike, please feel free to use Slido to input your questions as questions come up. You don't need to wait until the panel session starts. I already see that questions are coming up here on our automated platform, so please feel free to do so as soon as that question is fresh in your mind before you forget it. And if you have a question specifically targeted to one of the speakers, please feel free to identify if you want to ask your question to the speaker as well. So don't be shy to provide that information. All right, so thank you very much. Mike, you want to take it away?
Yes, thank you. Can we get the slides? Perfect. Okay, well, thank you for having me. I'm thrilled to be here. I'm going to talk about some perspectives on the journey to safe and effective AI adoption, work we've been doing at the ACR, some of the things that we've seen kind of on the journey. I think you'll see some similar themes to what David talked about, so I think this actually complements quite a bit from kind of the radiology perspective and kind of what we've been working on. So I'm going to go through a few topic areas. I want to give you a little bit of background on what we've been doing, talk about some recent provider perspectives based on some survey work we've done, talk about kind of the evolution of the AI market and how we've been navigating that and what we kind of see happening, the process for safe and effective deployment into production, so what that kind of looks like as we start to get it into clinical practice, and then just some final notes on LLMs and VLMs. So just by way of background, the ACR is over a century now old. We have about 40,000 members. This is radiologists, radiation oncologists, this is medical physicists, and we touch about 40,000 or so facilities in terms of exchanging data digitally. So we kind of have a large kind of connected engagement, if you will, with the radiology community. And our primary mission is to serve patients and society by empowering our members to advance the practice, science, and professions of radiological care. And so that's really kind of our guidepost. So in 2017, the board decided to really lean into this emerging area of AI and data science, and really established as a basic tenet that we wanted to advance data science as core to clinically relevant, safe, and effective radiologic care. And that was really a recognition that this was going to be a core part of medicine and a core part of what radiologists do. And so we wanted to lean into it and really think about what we need to do to make this successful. And so this was an investment of time and people. We have full-time staff. We have medical professionals and volunteers, and really quite a bit of machinery of the ACR kind of engaged in thinking through and kind of working through that kind of AI evolution. So that's just a little background. Let me tell you about some recent data that we've put together. So we've really, one of the things we've tried to do over the last number of years is monitor, ask our members, talk to folks about kind of what we're kind of seeing in the marketplace. And what's interesting now is this was just completed recently. It was a survey of, it's usually about 1,000 people or so. This was a little under that. But what you see in 2024 is 86% of the folks we talked to were doing something in practice in AI. Now, it doesn't mean that all of their exams or it's not really a commentary on penetration in terms of volume, but it does give you a sense of the breadth that really most of the folks are doing something in production now with AI. And that's a pretty rapid increase. So a couple years ago, it was just over 50%. A few years before that, it was much less. And so you're definitely seeing penetration in the marketplace as folks are kind of seeing the need to engage. When you ask them why and what they're trying to kind of get out of this technology, as no surprise, right now there is a huge volume in imaging. There's a shortage of radiologists. And so people are looking for automation. How do you automate monotonous tasks? How do you get time savings? How do you improve accuracy and efficiency? So clearly there's an appetite in the radiology community for this technology. And it's interesting, we do a lot of, run a lot of conferences and forums and things of that sort. And if I had to wind back to 2017, a lot of the conversations are, what is this AI? What's it gonna do for me? I will tell you more recently, the tenor is, you guys have been talking about AI for several years now. Why isn't it helping me do my work better? So the appetite is absolutely there. And so it's a very interesting kind of evolution in just kind of the thought process from what is this stuff to we really need effective tooling to help us do our job. And you see that in the survey. Likewise, and this is probably not shocking as well, what are the big concerns? Well, accuracy, errors, medical legal liability issues. And so as we think about kind of the trustworthiness that David talked about and what we continue to kind of look at is how do you kind of remove the uncertainty and how do you create kind of really truly effective solutions, this is obviously top of mind. In terms of people's kind of trust of what they're seeing, you had about 80% or so for a number of questions that had somewhat or moderate or completely trusted what they saw for things like reducing acquisition time. There's a few different areas here. But if you look at kind of what's my payoff? What's the ROI? Is it really impacting decision making? It's not great. You got about 50% or so that basically say it fails to meet my expectations. Now remember, we're very early and we're looking at very early solutions. And I'd say moreover, a lot of the solutions tend to be more workflow driven than it is things like diagnosis and detection. But nevertheless, there's work to be done in terms of creating kind of effective solutions. And then finally, here's another question on the influence on clinical decision making. Really less than 20% agreed strongly or at all that it really impacted the clinical outcomes. So the good news and the bad news, there's obviously a lot of penetration, there's a lot of interest, still a lot of need to kind of really evolve the solutioning. So now I want to transition and talk a little bit about kind of the marketplace and what we kind of see in this kind of underlying kind of the responses you're seeing. And I want to just start with this is a model from the 60s actually. Rogers talks about adoption of technologies. And he kind of buckets the users, if you will, in the kind of innovators and early adopters that are your risk takers, right? These are the folks that are willing to kind of wade through problematic technology and try and kind of realize the benefit. You start moving into the early majority where you've got folks that have a strong appetite. I would say the risk attitudes aren't bad, but they're going to be data driven. They're going to want to see solutions. Vendors are going to have to work to really make sure that folks kind of understand what they're getting. And then you start getting into the late adopters and the laggards, and these are the folks that are skeptics or the low tolerance for failure. So really for these groups, you really need to have infrastructure. You need to have kind of a platform that's going to allow them to be successful because they're just not going to tolerate subpar solutions. And I kind of grafted that onto the supply side, if you will. So this is Gartner's hype cycle, if you're familiar with it. If you're not, they basically talk about the diffusion of new technology, starting with kind of the innovation and the early startups and the kind of the introduction of the technology, up into what they call the peak of inflated expectations, because people are so excited that, of course, the promise really outshines what's really possible. And then you immediately go through a trough after that, and then the market shakes out. And I bring this up because I think part of, as we think about kind of getting this into practice, it's really as we get into these frameworks and approaches and what we've kind of looked at as kind of safe and effective infrastructure, that's really going to be needed if you're going to penetrate the late early majority, the late adopters, the folks that are really going to be waiting for mature solutions to adopt. So just to take you back for a sec, so this is 2017 when the hype cycle was all about deep learning. Jeff Hinton famously said, stop training radiologists. Again, just typical peak of hype cycle kind of stuff. And if you look at where we are now, well, you see kind of the deep learning solutions, the CNNs, things of that sort, starting to kind of mature. You see certainly a good number of solutions in the market. And you see, things like foundation models and Gen AI now kind of at that peak. So I just want to give you kind of a feel for kind of what you were kind of seeing in terms of both the supply side and the demand side in terms of how we think about this diffusion challenge. So I now want to go back and talk a little bit about some of the things that we see in the early parts of this life cycle, both to just give you a sense of how we've kind of viewed kind of the early stages of the CNN models, and it also I think helps us think about the kind of things we need to think about for for the LLMs and things of that sort. So we worked quite a bit early on trying to identify the gaps for the new technology. It's still something we're doing. This is one of the reasons we're here. So that's kind of an important endeavor that we've kind of been focused on. Standards and interoperability, it's for this market to mature, there's going to have to be sufficient standards that the vendors can build mature workflow solutions. We have seen that grow over time. In fact, we do a lot of work in DICOM, so for the imaging sector. And we actually just are now infusing some AI workflow into the DICOM standard that we've been working on for a number of years. So I think we're seeing this mature. It's important that continues for the market to really stabilize. Certainly working with the regulators as we kind of evolve and they evolve their understanding of what we need to do to test this technology. David touched on things like ethics and the like. This is kind of critical. So this was an effort we did a few years ago. It was a joint effort across a number of societies, actually in Europe and the US, that was kind of focused on how we start to think about and concerns about the ethics and bias and stuff of that sort. So again, just kind of critical issues as we think about kind of the early stages of this technology. This is from, we do an annual summit with SIM, which is another radiology society. And I really want to point this out just because of the topic areas. So, in 2018, our conversations were very much general on how do we think about the economics of AI? How do we think about getting data? When you fast forward to the most recent ones, we're definitely now into implementation questions. How do I show ROI to my stakeholders? How do I make sure that I'm testing it appropriately in production? So you definitely even see there kind of the evolution of the marketplace and the adoption. The other thing we worked on quite a bit were things, we're coming up with the use cases and specifications so that we could start to provide an anchor for what these algorithms were doing, how to think about what success looks like, how to think about how they're triggered. Kind of one representation of that is something we used a while back to kind of show, there's really a lot, it's a big problem space when you start looking at the intersection of modality and findings and anatomy, and we had to make sure that we were really tackling kind of each of these areas. I will say increasingly we're seeing models that are covering more and more clinical areas, so that kind of helps. But there's a long way to go. So there's right now about 351 software as a medical device solutions that are cleared by the FDA in the market. You more than double that when you get to the software in a medical device. But just to give you a feeling for kind of where we are in the journey, we're still fairly early in providing solutions that kind of range across the spectrum. So then as we kind of moved into the last couple of years, a lot of things we've been focusing on was how do we really get the workforce trained up? So we also termed this democratizing AI, and the lens we had was we said, if we think about our population as a pyramid, we had to have solutions that hit every strata. So at the very least, we needed everybody to be conversant and be a good consumer and understand the basics of the technology, up to the point where you have people that are interested in creating AI. And we needed to make sure we had a way to capture that interest, a way to make sure we had a trained workforce. And so we kind of had solutions and strategies across all those. So this is just an example of one we used. It was a workbench that we called AI Lab, and it was basically a way for hands-on engagement with the technology. You could actually create a model, and really aimed at educational purposes. Data, it was huge, it still is. We are involved in a lot of different data collection efforts over the years. These are a couple that we've been involved in to update things like the National Lung Screening Trial for data that's going to be appropriate for AI. We're involved with a project for under NIBIB called MIDRIC, which is bringing in data originally for COVID, and that's been expanding. You'll hear more about that in the next day. We've also been really focused on federated learning. We really feel strongly that it's critical that we move the analysis to where the data is. And so we've had a number of projects and efforts to focus on how do we train models in institutions by moving the model to the institution so you can train on their local data, you can test on their local data. Federated learning activities, we can actually train a model across several sites, again, while leaving the data locally. And essentially efforts, and there's one now with ARPA-H, it's kind of part of the biomedical data fabric, which again is kind of aimed at how do I kind of leave data in place and send the analysis to the data. So we think it's a critical part of the puzzle, both making sure you have well-curated data, but making sure that we can actually work where the data is. And part of that for us is leveraging infrastructure we built over the years to basically engage with sites. So this is just a map of the 40,000 or so facilities we engage with, and gives you a sense of the network that we've had to create to deploy software to be able to talk to local systems, bring data back. So Triad and ACR Connect are the tooling that we've deployed over the years. So it gives us a large footprint and an ability to kind of engage and kind of work a lot of these large data projects. Obviously working with the payers, both federal and private, obviously working with legislators and the like, the whole policy framework critical. And then this is work we do with the FDA to do follow-up on testing algorithms that were actually cleared and in production so that we can see if the performance characteristics met, frankly, what we were expecting earlier on in the process. So it kind of just speaks to the fact that you just have to be vigilant and continuing to look at these models. So I want to shift a little now to scaling and adoption and kind of what this looks like in production. So I've kind of talked about the first parts of this life cycle so far, and we have efforts to span, but really I kind of want to talk about what's happening now in the acquisition and use. And it really speaks to kind of the kind of infrastructure that we need to put in place if we're going to really, hit the folks that are kind of in the late adopters and folks that are kind of really waiting for better infrastructure to, to complement what they want to do. So first is an effort we call AI Central. This is just a free resource that basically catalogs the products that are in the space. And this was important because we had to bring together the thousands of members and radiologists and folks that wanted to know what was out there with the hundreds of vendors that were creating solutions and really bring them together. And so the notion is that we have information on the platforms and the products and the manufacturers, and it kind of becomes an information clearinghouse. And it just really speaks to the fact that this is a tough market to penetrate if you're sitting on the outside looking in. And so how do you find ways to create that clarity? There's tools to kind of look at the market. So this is an example, and it shows you a couple things. One is the number of products out there by intended use category from the FDA. So the folks, if you're familiar with this space, it basically catalogs the intended use. So CAD-T is used for triage, and so that's going to have a expected level of performance, if you will, to cover triage tasks. And then you get all the way up to detection diagnosis, and as you might expect, the burden of proof is going to be higher when you have solutions like that. But most of the solutions we see at the moment are in that kind of triage or operational world. The bar is lower, which is really one of the reasons I think that you see in the surveys there's not as much to help me on detection and diagnosis yet. But certainly we see, and you see on the right kind of the trend over time. We're seeing more and more cleared algorithms hit the market, more and more solutions. So it does, it does give you kind of a sense of the velocity in the marketplace. So we will see more and more solutions that hit these other areas. And this is just another cut according to anatomy and focus area and things of that sort. So again, we're kind of seeing, more and more solutions that kind of go with the fact that we're seeing, that demand. The other thing that we focused on was an effort to create clarity on what's in these models. So we called it transparent AI. It's essentially a model card of what the algorithm looks like, characteristics of the data used to train it, what are the accuracy statistics and performance characteristics, and really asking the vendors to provide this, make this public, and really kind of provide the consumers with a window into what they're getting. We think it's a critically important part of the puzzle. So we talked, and David talked a bit about the notion of needing to monitor. So we feel strongly about that. We actually, at the end of last year, launched a registry to monitor AI results. I want to talk to you a little bit about what that process looks like. The notion is that we get the AI output from the vendor. We also get a surrogate ground truth. So in this case, the radiology report. So from that report, we're going to find out what the radiologist said was happening with this case. We also know what the vendor now said. We also have a lot of other contextual information, in this case, DICOM for radiology. We actually use that Connect infrastructure I mentioned before to process, de-identify, and that data locally so that only de-identified data leaves the site. We load that into a registry, and then now that gives us the ability to provide information back to the individual. So the way that looks, we can provide, certainly at a national level, general statistics and characteristics of the different use cases. So how these typically perform, what they look like in terms of concordance rates, in terms of what the radiologist said and what the model said. We can cut it across different kind of demographics and equipment and things of that sort. So it kind of gives you that global view of how the market is evolving. More important to the facility itself, we can also give back then specific results for them. So in this case, this is just a report that shows you the concordance rates for you relative to national averages. And so, what you can see in some cases where the blue dot, for example, is higher than the star, that's going to be a signal that you probably need to look at what's happening in your facility because you're kind of underperforming, if you will. And then we have drill down for that too. So this is just an example of kind of that longitudinal picture. but it also gives you a sense too of your case mix, because it may be that your concordance rates have changed, but it also maybe your case mix has changed, and that may be the driver. And so you're going to need the ability to investigate what's going on, obviously, if you're going to understand kind of why these concordance rates are changing. So first and foremost, understand there's a change. Something's going on that needs attention. Next, kind of digging in and figuring out what that looks like. So that's kind of the assessment and the monitoring process. The other part of kind of the infrastructure, and it kind of dovetails actually really nicely with what David mentioned in terms of kind of key principles of trustworthiness, is something we call Arch AI. So this is a recognition program. It's the first for radiology. That's the Recognized Center for Healthcare AI in Radiology. And the whole goal here was to give sites kind of a guidepost and recognition, frankly, for good work. So the first tier for this is a recognition program. After that comes increasing levels of formality, if you will. So above a recognition program is something that would be a formal accreditation program. Above that, we have specific designations and something we call the DICOM Center of Excellence. And this really kind of speaks to the fact that we kind of really see AI as almost like another modality, if you will, just like we do MRI and CT and things of that sort. So the whole goal here is, we start with the recognition program. We build an evidence base in terms of technical standards and practice parameters, and that ultimately creates what is an accreditation program. So there's a lot of formality, if you will, in terms of how these programs get created. There's a lot of consensus building. We actually recently just published an article on this process. Actually, this came out last week. So if you're interested in kind of digging in and understanding more about how we're doing these kind of programs, I can kind of refer you to that. The key point, though, and this is really what I want you to take away, is what are we trying to ask these sites to worry about and think about? So first is governance. So what we're telling folks, and we're not telling you how you need to govern, but we're saying you need to have a formal governance program. These are just examples where you might have a clinical champion, a technical lead, administrative lead. Again, your mileage may vary at your site, but the point is that you have a formal set of policies and processes for evaluating, accepting, monitoring, and sunsetting AI models. Likewise, you have a local inventory. This is, and if you're, using kind of the data elements in the transparent AI, or however you're kind of managing the key characteristics, the point is, the model version, when it's deployed, you have things like instructions for use that are available. The point is that this is a controlled process, just like any technology process is going to happen in production. And in fact, because of some of the monitoring challenges and the like, it's all the more important that this is a controlled process. And of course, the various checkpoints for compliance and security that you might expect. So that's kind of one, is kind of the governance. Second is the model selection process. How are these actually entering kind of your clinical domain? That you have some process for selecting models, that you have some documentation of the inclusion criteria, what triggers these events and what are the context around which these models are applied, and that you've got a documented purpose for the model. So again, that you kind of have a controlled process for models kind of entering. Acceptance testing, also a formal process. So this is documented. You have a training process for the clinicians and the staff that are involved, that you disseminate information like instructions for use and the like. And again, we don't prescribe exactly what this looks like. Your mileage will vary, but the point is you need to have a structured program. And just to give you a sense of how we see a lot of folks kind of implementing, the typical deployment pathways tend to look like a deployment in a non-clinical setting first, usually on a retrospective data. That then tends to proceed to something that looks more like a shadow deployment, where it's now actually in a production setting, it's talking to production systems, but it's not being used for clinical use yet. So it gives you a chance to monitor. Next is really a limited deployment, or a canary deployment, if you will. So the point is that you deploy it in a limited fashion to measure how it's working before it goes to full rollout. Not everybody goes through this progression, and people do different things, but it just gives you a sense of the kind of ways that you need to really test this stuff out on local data. And monitoring, we've talked about the need for local monitoring and participation in a registry. And then finally, if you're developing AI, that's not a shortcut. Just like you're going to ask your vendor to have rigor, you're going to make sure that if you're locally developing it, you've got trained personnel, you've got standard procedures. So that's also a controlled process. And these are some of the folks that are already engaged. And so it's growing, and it's growing actually quite quickly. So there's definitely a demand. Folks are asking, how do I do this in production, right? We have a whole learning community where they're learning from each other as well, and we're learning and adapting kind of our processes and policies kind of along the way, since it's still, it's still early days. So I wanted to kind of finish up on a note on large language models and VLMs and Gen AI and the like. This is kind of one view of that world in terms of how we've progressed just in terms of trainable parameters. When you look at the CNN kind of models and you look at what we're able to do with these foundation models and the like, so that's kind of one way to think about kind of the evolution and progression. I kind of like to look at it, this is actually my dog, this is Rue. And so, back in 2018, when we were all excited about cat and dog recognizers, I put it into a recognizer and it said, yep, this is a dog. And some of the better ones would tell me the breed and things of that sort. But what I'd done is crop the image. And so when I gave it the full image, it really struggled. These models just couldn't figure out what was going on. Now, yes, this was my couch, and actually this was the second couch this dog destroyed, but they really struggled. The best it did is it said, oh, there's popcorn in the background, but it really could not figure out what's going on. So I threw this into ChatGPT, and it did a really impressive job of saying there's a picture, there's a dog in front of a green chair. It did kind of miss on the couch, but that's okay, we'll give it a pass. The chair's cushion appears to have been torn apart. I love how the fact that it does not infer causality, right? It basically says there's stuffing on the floor, suggesting the dog may have destroyed it. We weren't wondering about that, by the way. The dog has a guilty or sheepish expression, commonly interpreted as a sign of knowing it did something wrong. This is starting to feel like a radiology report, actually. The pillow from the chair is on the floor, undamaged. So anyway, it just kind of gives you a sense of the progression of the technology and how well it looked at a complicated scene and picked it apart really quite well. And so what we did is then we started to, just like we did before with things like iLab, where we kind of use that to train folks, we infused this and so that we could get folks comfortable in understanding the technology. So in this case, we took a radiology report, and we had a few tasks like use an LLM to make it patient-friendly. In this case, this was one to pull out the quantitative characteristics of the report. But again, it was really intended to kind of build familiarity. Now, actually, what we're focused on is how can we actually test these models? I mean, now that people are starting to use that, we're starting to get excited about it. So this is a consortium we're working with of medical centers looking at something we're calling the Healthcare AI Challenge. And the whole idea is that we're able to collect some diverse data sets, embargo data that's not necessarily been used to train the models, and we can define use cases and crowdsource, looking at these models. So this is kind of this arena concept, and if you're familiar with things like LIMSIS and the like, there's examples of this, but this is focused on radiology. And the notion is you can use this then to look at a public forum and how these models perform, but also for internal decision making. So it kind of gives you a window into, well, how am I going to start to deal with these kind of problems? So here's just an example of it. You can define different types of challenges. This one is an X-ray challenge. It's basically going to interpret an X-ray. We also have the parameters. So in this case, there's a 5-point scale that can be used to rate it. And then here's the example. So you give it the X-ray, it creates a report. And then you as the user can then decide how well the report was on this 5-point scale. In this case, it was as good as a fellow would typically do. And you can give comments and we can kind of get feedback. And this is the characteristics of this challenge. Then after that, you can see what the model was. And in fact, look at results from other models as well. And we also provide the unformatted text, the prompts, and again, really aimed at trying to understand kind of what's going on as we kind of evaluate these kind of solutions. And then we can kind of publish ELO scores and the like, so you can kind of get a sense of the different performance of the models. So just partially what I just wanted to kind of give a sense today was as we think about the risk and reward and kind of what needs to happen as we see this technology penetrate, as we kind of said, as I said earlier in the talk, we kind of have a sense of what people are looking for, what the upside is. What are the risks and the things people are worried about? Well, you've got to have, there's subjective risk attitudes, whether that's at the personal level, the practice level, local market conditions, people will have a different appetite, and that's going to factor into that cost-benefit calculation. Likewise, intended for use, your ability to accept inaccuracies is going to look very different if it's triage versus diagnosis. The clinical use case matters. There's going to be some that are going to be just on different parts of that ROC curve, and your appetite for errors are going to look different. And then operational safeguards. If we're going to bring down the downside of this, having monitoring, having transparency, having kind of best practice, guidepost implementations, all again kind of bring down kind of the risk factors. So that's what I had to share. Thank you, and look forward to the panel discussion.
All right, thank you very much. Just feel free to come and have a seat here. It looks like we have our own little fireside chat from Davos set up here. I feel very important. So again, please feel free to, can we get the Slido QR code posted up there so our audience can scan? And if you feel like you don't have a question, you're welcome to scan the Slido and you can actually upvote questions that are there. So you might find a question that's already there to be of interest to you already. So feel free to promote a question that you support. With that, Leo, why don't I open to you and I'll start scrolling through these questions.
Can you hear me? Okay. So the first question is about data privacy. As you know, for powerful AI model to work, we need a lot of data collection. So for David, in your talk, you talk about massive data collection of personal health data for your application, for example, right? So how do we encourage data collection without really a predefined use of it, right? Should we distinguish individual benefit for the patient versus a collective massive benefit for the general public?
Yeah, so to answer that question, there's sort of two aspects to it. One is the technology that enables us to be able to secure the data and enable a level of confidence that this data won't get exposed to different organizations and that people feel confident in the process. Federated learning obviously has a significant role to play in this because you are not releasing control of the data to another entity, and it allows you to be able to put your own safeguards in place and feel confident that you have done as much as you can to protect the data sets. When you start sending it out, you in many ways are relying on that other organization to do what's right. And for a variety of factors, some may be out of control of that organization, things may go wrong. And then who has the liability? So liability then comes back to either that organization, but usually it's back to you. So you're really in a bind if you don't have those processes in place. So that's why federated learning is particularly important. And as I mentioned before, it takes two to tango. Just because you're protecting the data doesn't necessarily mean that the algorithm or model developers are going to want to send their data sets or their models to you, because in many ways we have seen that you can identify what the models are just by looking at it running on your own data set. So this is a problem if you are trying to accelerate the amount of collaboration. This is why the privacy preserving environments are so essential. But that's like one element of it. The other is really around what we oftentimes attribute to, like how much should we inform and educate patients and consumers about the data that is actually being used. In many ways, this has already been done legally through the forms that people sign when they are working with healthcare organizations. And I think that what we just need to do is we need to reinforce that these are being used for these purposes, and to make clear some concerns that they may have relative to how the data might actually get exposed. This is particularly true now with the fact that many of these data sets are particularly sensitive. Especially with the environment where people may feel that someone could use this and come at them for a variety of reasons. So I think it's extremely important that we address the issue of patients feeling comfortable with how we're managing it and really being transparent in that process.
Yeah, if I could just, I think that I completely agree. And I think what I would add to that too is that, as these models become increasingly multimodal, it's all the more hard for any one person to actually aggregate and have all of the data and the types of data. So we do a lot of managing imaging data and increasingly pathology data. When you start adding genomics and other clinical data, at some point you get, you do have the need for federation, if nothing else, just to deal with the challenges, even for centrally collected data, that there's complex curation kind of going on. So you have that challenge. I think the other part of it, and as David was saying, is the privacy preserving part of it, and the concern of we've been collecting data for decades actually, and what we've seen in recent years as folks worry about everything from the liability with sharing data to the fact that data is valuable, and so there's business concerns that people will have. All those things kind of play into how do you kind of protect the patient, how do you protect the facility, all of that stuff. So we've really been big fans of the federated approach for that reason as well. That can we leave the data where it is? Can we leave it in a controlled environment, or put it in a place that isn't necessarily publicly shared? and then we can kind of keep control, and the facility has control, and they can protect their patients and protect kind of their concerns and their interests, move the analysis to the data. And so, that's for us to really be able to scale and kind of leverage the types of data and the modalities and the breadth of data that we need. Having some of these kinds of strategies become critical.
All right, we've got a couple of questions online here from Slido. I'm going to see if maybe I can combine these two questions. Let's see if it makes sense here on the fly. So combining the questions, this question is asking, do you think your approach would require a massive collection of personal health data without a predefined use for it? And should we distinguish individual benefit and collective benefits? And I want to juxtapose this with another question that was asked, is looking at incorporating minimal data quality. So here we're looking at massive collection versus what is minimally required as input for AI. Maybe you could speak towards that balance.
Sure, I can start. Yeah, those are great questions. Well, certainly. So for the first part of that was I started focusing on quality for a minute. Remember the first.
Sure. So looking at massive collection.
Yeah. So, so certainly the need for well. Let me start on the quality for a minute. So, curating data is difficult. And in fact, it can be very costly. So one of the challenges increasingly is how do I kind of keep that barrier low? And so, having kind of, minimal quality standards does two things. One is it actually reduces kind of my, the burden in terms of making data available. And often it also has the potential to mirror better what you're seeing in production. Because that's the other thing that tends to happen is we collect data, we polish it up, it looks really good, we then work with it, and then your mileage varies when you're actually in a clinical environment. And so kind of finding kind of the right place to kind of put kind of, quality standards, I think is going to be important, for that. I know the other part of the question actually in terms of massive availability, one thing we found over time is it's very hard to get institutions to open up their data for general purpose investigation. IRB boards and the like all want to understand what are you using my patient data for. I want to make sure that the patient's protected. I want to make sure the intended use is very clear. And so it makes it, we've generally found over time that you need to do your best to create scenarios where you can have access to data, but actually turning the spigot on is use case specific so that you can get the required approvals. So, I in general, and it's not that there are certainly examples of institutions that have made large quantities of data available, which is fantastic. But if you're really going to get representation throughout the country, rural, things of that sort, you need kind of strategies that kind of just accommodate those legal restrictions and those practical restrictions of how people can share data.
I think it starts with identifying the different types of data sets and putting a level of sensitivity around each one. There's a difference between describing, maybe having some basic information about whether you have a certain disease versus actually sharing your genomics, your genomic entire whole genome sequencing. There's obviously within the medical record, there's probably now with women reproductive rights, that's probably now at a higher level of sensitivity than maybe some other things for other diseases. And I think we're now starting to realize that based on level of sensitivity, we have to have higher levels of safeguards that are put in place to ensure that those are done in ways that people feel confident. Those conversations should be had with patients. We should make sure that they are aware of what's out there, and we should put in processes that allow us to be able to capture that data at scale and with diverse populations. The challenge we see today is most of the data sets today are captured through people that actually come into the facility. As I mentioned before, that is a subset of the entire population. If we truly want this to be representative of larger populations, we have to go and have strategies for how we acquire data outside of what are people coming into the system, making this more accessible, more convenient, and also finding ways that we can create value for them.
This is one of the initiatives that we were trying to implement throughout the pandemic, where we were trying to give individuals access to their own medical records and then have them be the determinant of where it goes, sort of like their own personal HIE. Unfortunately, it got kind of stalled for a variety of reasons. I think people started thinking this is sort of restrictive, as what they call vaccine passports, and a variety of other areas. But ultimately, the concept was that we wanted to empower consumers with their own health information so that they could make their own determinations. But in the absence of being able to do that, I think what we can do is we can have healthcare organizations serve on their behalf and be the spokesperson so that we can do the things that are on behalf of patients, what they want to do.
Change topic from the data collection to AI model development. There's a question about multimodality AI model, which is a very exciting topic, which we agree, by the way. That's why we have a section tomorrow to talk more specifically about that. So we want to get your insight about what's your perspective about the implication. How do we overcome the hurdle to interpret this model, which is sometimes more complicated?
Yeah, I think the challenges right now are first in the development of it. It's very expensive to build these models. It requires a massive amount of data. Diverse data sets, requires well-curated data sets, and that access to those type of information sources are essential to be able to build these models. But as I shared before, some of the stuff we can do collectively and we can make available through open source. So by creating open source and what we call embedding models, allow us to be able to identify shapes and structures from these images and be able to look at certain patterns through EHR and genomics that don't necessarily create a huge amount of value, but they're not, or differentiation, but create value in the sense that organizations don't have to build those themselves. Where the value can be created is in the unique data sets that individual organizations have that they can build and train their models off of those. And from there, apply the large language models to be what we'll call reasoning engines to be able to do many of the complex tasks and allow for the end user to be able to access that information very readily. That's a model that I think we should be thinking more of. Today, it's a lot of everyone build their own based on their own data sets and their own resources. That's not a scalable model. And we really do need to think about how we can work together in ways that will be coordinated, but also leverage each of our own capabilities. I think that most organizations would love to be, in a place where they can accelerate the development of their models and do it in a way that creates new valuable IP for them. They're probably not aware of many of the things that we're talking about, and because of that, we see companies just kind of going on their own. It's almost like we had a race and everyone just started going off, and now we're realizing that we could have given everyone a head start, and they just didn't realize that.
All right, so this question was directed for David, but I think could be equally applicable to you as well, Mike. So in the focus on the human-AI interface, I lost my question. Okay, here we go. In the focus in the human-AI interface for effective implementation, how are you approaching the presentation of uncertainty in the outputs to consider this in the confidence or trust and in decision-making?
I can start. I mean, what I will say is that, obviously the solutions, the vendor solutions vary in terms of how they're kind of presenting back to the radiologist or the end user, whoever that person is. I think what I would say that what is important is that there is some feedback loop, that basically provides, feedback on what the model's doing, what the confidence intervals are, what the uncertainty looks like. There's an opportunity for the user then to, process that, make decisions, potentially provide feedback. So, I don't know that I certainly can't give you kind of a particular solution, as much as to say, depending on the nature of the algorithm, what it's doing, in the radiology world, this could be part of the reporting process, could be part of interpreting an image. It may kind of show an overlay of an image and give you kind of some confidence intervals around that. So there's different strategies, but I think the key point I would make is that, it's critical that that feedback is provided and that we continually the vendors continually find ways not to give you a black box, here's the answer, but give me the context for that answer.
I think one thing that we're starting to see is that rather than thinking of having one model that does everything and that we test the reliability for every single use case is to break it up into the different use cases that we see in the different workflows and build models that are very specific and well-trained on those models, and then have agent-to-agent communication so that each can do its task very well with high levels of confidence. If we think about it in the context of specialization of AI in specific subtasks, and then connecting that through these organizers, it allows us to be able to overcome some of those concerns that we have, that this model will hallucinate and do a variety of different things. Because if you train it specifically with putting in the right safeguards to do certain tasks, we will have overcome some of them. And that's where I think the industry is heading. We're starting to realize that, while as much as LLMs can do so many amazing things, if we just simply let one LLM to try to solve all the problems, we run into a lot of issues with certain types of use cases.
I want to change the topic a little bit to the responsible AI or trustworthy AI, right? So there's a question about how do we prevent data from being monetized by vendor? Because as you get more data out, there's a potential risk for that.
Yeah, I mean, I think bottom line is that we have to find that right balance, because innovation is driven by organizations that want to be able to generate revenue so they can grow as a business. So there's that balance of creating value that people want. So like if the goal is to solve an answer of like, how do I diagnose this cancer? Or and if people are passionate about this topic, then you want the organizations to be successful in that venture. And again, it's about transparency, just making sure that people know that that's what they're signing up for. I don't think there's anything wrong with businesses thriving in the pursuit of something that's very beneficial for individuals, if everyone is aware of it.
I would just echo the transparency. And it's interesting, we talk about the human interface part of the AI interpretation. I would say it's kind of actually, it applies as well to things like consent and understanding, how do folks understand what's being used, why it's being used, how it's being used. Increasingly, folks, that are contributing data want to see some results as well. So I think the more you can just provide transparency on what data is being used, in what context, I think the better off we'll be.
I think we have time for one more question. Is that right? Yeah, Daniel's saying yes. So I'm just going to draw from here. AI seems to be able to detect stigmatized medical issues that patients may have hidden before. So for example, in the case of this question, they've cited depression. So aside from privacy protection, how can we balance AI and healthcare benefits with addressing and avoiding medical stigma?
That's a good question. I mean, I think one of the things that we are recognizing is that we underdiagnose things for a variety of reasons. We're oftentimes too busy. We don't ask the right questions. The patients don't share the information. And because of that underdiagnosis, when bad things happen, we always wonder, oh, I wish we would have been able to have identified that. I think AI serves as a great role for us to be able to uncover some of these things. There will, in some cases, be a conversation that needs to occur, and it needs to be done with sensitivity. And that's why I feel the AI doesn't solve the problems. What it does is it uncovers them, and then you need the clinician to be that communicator. So they communicate with empathy, they communicate with compassion, understanding the context of how this is being presented. I think the challenge we sometimes run is the technology runs faster than the patients, than our systems. So when people now, we always talk about people getting access to their lab results. Well, now sensitive information pops up and people find out about conditions that before the clinicians have even had a chance to intervene. I do think that that's just another example of how we need to smooth out these rollouts of processes so that when sensitive information is identified, there's always that clinician there to be able to make that communication as seamless as possible, and so that patients feel comfortable with it.
Yeah, you wonder too, this is an area where agents, both in terms of the multimodal question, but also in terms of this question, where agents can start to be increasingly helpful, because you can gather data, you can kind of, set rules, you can set parameters for what information is exposed where, but actually kind of leverage data, which is kind of ultimately what we're kind of trying to do. And then, if it's, whether it's teeing up, at the right point in the right time, the physician interaction, Whether it's feedback, it's interesting. Right now we increasingly are, collecting health information, right, from folks. Increasingly, it can be a bilateral thing as well. So where and how do you kind of use the data to feed information back to the patient, potentially tee up a follow-up with a physician. So I think that the evolution, the technology, I think as Dave was saying, there's lots of opportunities. The question ultimately is how do we kind of fold this into the workflow, into the clinician-patient dynamic? But the potential is kind of tremendous.
Let's thank David and Mike one more time for their presentation. We'll take a 10-minute break. Thank you, everyone.
Everyone, and good morning. And it's a very nice for the first session, and I learned quite a lot. So let's dive into the section 2 today. So I'm IE Lee. I'm the chief of the computer service and the clinical informatics at the Memorial Sloan Kettering Cancer Center. So I'm also the planning members of the symposium. So we're very excited to continue today's session. And so I will dive into more the open sessions to start to focus on AI in radiation oncology. This is the first 3 sessions that will focus on the future directions and opportunities to apply the AI ML to radiation oncology. And it's in one 3 fields interesting to the symposium. So for little context, comparatively to the other field covered by the symposium, and radiation oncology deal with larger and more acute dose at varying, but overall it's a high dose rate.
Thanks. I'm Seferino Absamaya. I'm a program director of medical physics at the Radiation Research Program at National Cancer Institute. It's a pleasure to be a member of the planning committee for this symposium as well. I will be co-moderating with Annie here the whole session, and we'll hear from both speakers their recent advances in applying AI for new approaches to personalized oncology. It's a pleasure to have both of the speakers here, who are our most successful grantees at NCI in the field of medical physics. And so each one of us will be introducing the speakers. First, Annie, would you introduce Steve Jiang? And I'll introduce the next speaker, Lei Singh.
Yeah, let's start. The first speaker is Dr. Steve Jiang, and he's a West Chair and of Digital Health and AI and Division Chief in the Medical Physics and Engineering Department at University of Texas Southwestern. Steve, and his topic is AI agent in the adaptive radiotherapy.
Okay, good morning. It's been an honor to be here to share some of our work and thoughts on how to use AI agents to enable adaptive radiotherapy. So radiotherapy has been there for like over a decade now. It's one of the 3 major modalities for cancer management, together with surgery and chemotherapy. But over the last 100 years, radiotherapy has been pretty much the same, delivering about 2 grids per day, every day for over several weeks. Recently, about a decade ago, SBRT, stereotactic body radiotherapy, or we call it SABR, started pioneered by one of my colleagues, Dr. Timmerman. Here, we deliver much higher dose every day. Every 2-3 days, give another, after 2-3 days, give another fraction. So you can finish the treatment in a couple of weeks. But both are quite like one-size-fits-all kind of treatment for the same cohort patient. They get the same treatment without interruption. And also, we only monitor the acute toxicity. The benefit and harm persist relatively long after the treatment is done. All treatments have been delivered, and at that time, there is not much you can do if you want to make some changes. So here it shows the kind of like a radiotherapy course fractions and the dose per fraction, and the time between two fractions and the total number of fractions. Like I said, currently is one-size-fits-all type of radiotherapy, and all those parameters, variables are constant. However, we believe those can be potentially be personalized or become variables for more personalized radiotherapy. So there are two dimensions in personalized radiotherapy. First one is the typical, when people talk about personalized medicine, that's what they're talking about, the upfront patient stratification based on the biomarkers, tumor characteristics, patient health status. However, the second dimension has not been explored. That is the adaptive treatment during the course. Longitudinally, we can personalize the treatment based on anatomic imaging, biomarkers, and functional imaging. So the anatomical imaging-based adaptive radiotherapy, I call that Gene 1 type of adaptive radiotherapy. The goal there is to maximize tumor control and minimize toxicity based on the anatomic changes, such as like a tumor shrinkage, the relationship between tumor and the nearby organs that can change from day to day too, right? Based on that kind of information, you can adjust your treatment. However, the goal is still to deliver the original prescription, just more precisely, right? So it's not that much of adaptation in that sense. It's more like a course correction and precise execution. It's, no doubt it's an advanced form of radiotherapy delivery. That's where we are, but it's, like I say, it's not true adaptation. And the overall impact will be incremental. So Gene 2 type of adaptive radiotherapy is based on the response, right? Again, we're still trying to maximize tumor control and minimize toxicity, but it's based on a real-time tumor and patient response to a treatment, right? Based on that, we can change the prescription, right? And so it's a true feedback mechanism in a control theory model. It's true adaptation, and I believe that is the future of cancer radiotherapy. And the response can be measured by functional imaging, biomarkers, that kind of stuff, right? The IGRT stands for image-guided radiotherapy. That's where we are right now. And from IGRT to adaptive radiotherapy, ART, there are a lot of challenges, such as greatly increased workload, increased complexity in workflow, increased complexity in technology, and increased challenges in decision-making, and increased risk errors because patients are waiting for the treatment under the machine, and there is a big time pressure there. It's easy to make mistakes. Increased resource requirements. So that basically says ART, adaptive radiotherapy, really needs help from AI. For Gene 1 ART, in the last several years, there are a lot of AI technologies have been developed to enable Gene 1 ART. That includes like image acquisition, image processing, including reconstruction, denoising, that kind of stuff. Image segmentation has been a focus. There are a lot of commercial products now for auto segmentation based on deep learning models. And adaptation decision-making, that is important. Treatment planning, replanning, there's some work there too. Quality assurance, quality assessment, delivery. For Gen 2 ART, AI is even more needed because, like I mentioned, a lot of challenges are more severe for Gen 2 ART, such as decision making. There are a lot of variables. There are a lot of more variables now in the decision making that is way beyond what human doctors can handle. Right? You need AI to help them making those decisions. And also the workflow, like I said, it's very resource demanding, very complex, tedious, so you need AI to automate the workflow. But it's challenging to use AI for Gen 2 type of ART because we don't have the data. Because in the past, the treatment has been quite uniform, right? You don't have the diversity, you don't have the spectrum of the data variable to train the AI models. We are trying to work on AI assistant for adaptive radiotherapy based on AI agents. So an AI assistant works side by side with clinicians throughout the whole course of treatment to retrieve, process, analyze, and present information to the clinician to assist decision making. And also to I'll talk about more about decision making, and also to automate and streamline clinical workflow. And we believe the AI assistant needs to work with a bunch of other AI agents. It cannot be the single AI agents doing everything. I think David mentioned that is not going to work. So all these AI agents can work together, can use the tools, can do function calls for other task-specific AI models, can use other clinical software tools, can access clinical database, right? What is the AI agent? What's the difference between AI agent and other AI models we've been working on in the last, how many years, decade also? AI tools, especially like supervised deep learning-based those AI models, to me, those are just like mapping from input to output from point A to point B. It's more like fitting a complex mathematical function with deep neural network. So there is almost no intelligence there, even though we call it artificial intelligence. But if you look at those models, for example, like outcome prediction model, there's no intelligence there. But AI agents are different. They can perceive, think, reason, make decisions, take actions, and they can use tools to enhance their abilities. They work like humans. That's why I believe that's kind of true AI agents, right? Or true artificial intelligence. So at ET Southwestern, our team is trying to develop a multi-agent AI system for adaptive radiotherapy. So here you have an AI assistant working side by side with the clinician. This AI assistant works with a bunch of AI agents, like a team, right? And the agents can actually talk to each other when needed. There's a very important AI agent that we call data collection and integration agent. Basically, this agent will get the data from all these sources for an active patient, a patient being treated from, for example, EHR, PACS, OIS, that stands for Oncology Information Systems, from treatment planning systems, and from machine data, whatever data you have in a clinic for this patient. This AI agent will actively retrieve the data in real time, and then will process data, curate the data, and then will index the data, right? Put data into different database for this patient, right? So including the pre-indexed vectorized database, so that other AI agents can easily use the patient's data. They don't have to go to Epic or other EHR to retrieve this patient's data. All the data for this patient is up to date. It's high quality and easy to access. This is similar to like when you do a Google search, you know, it does not go to every web page to get the information you want. It's already pre-indexed, right? And also there is a set of tool sets, right? Clinical softwares and other task-specific AI models and other tools. And also there is a large database based on the clinical guidelines, procedures, newest literatures, all this kind of stuff. So when the agents running the tours, they need this kind of information, right? So this is the system we're building. We are developing. We actually have done some quite interesting work. For example, based on this data agent, we developed an agent for clinician that can talk to the patient's data, meaning similar to like Google's notebook LLM, right? So when a clinician, a physician wants to know a patient's diagnosis or treatment history or dose to a certain organ from previous treatments, now you don't need to go to EPIC or another oncology information system, you know, found out by yourself. You can talk to this agent. Just ask this question through a conversation. This agent will give you that data, that piece of information quickly, right? So that's one application could be useful. There are a bunch of other applications such as the patient clinical trial matching, right? When a new patient, actually every night we locate the epic dump clarity, identifying which patients are qualified for which clinical trials. And there's a user interface for the clinical research team. So next day they look at that, oh, this patient is likely qualified for this trial, but there's a certain area, they will go there and check, right? So a bunch of kind of agents we're developing right now, which we believe will be very useful. Examples, including like data integration, summarization areas, such as automated chart preparation. Before you see your patients, everything is prepared for you, retrieving information from multiple sources, right? Clinical documentation assistance. Of course, task automation, workflow streamlining, right? I mentioned the patient trial matching, simulation order automation, auto segmentation, of course, and treatment planning, treatment monitoring and quality assurance, AI-assisted plan review and QA, real-time patient monitoring throughout the treatment course, and AI watchdog to detect any potential errors in the course of treatment, and communication enhancement, patient-facing chatbot, and clinician support chatbot. We developed 2 chatbots, one, for example, for CNS cancer patients, right? So the patient can ask questions about treatment. To answer the questions accurately, the answer is based on the clinical guideline and also the newest PubMed literature, right? An AI-empowered chart round assistant. You know, we have weekly chart rounds, and their AI agent can help preparing the chart rounds, can tell you, you know, like a summary of each patient, and also direct their attention to where you should pay attention to for this particular patient, right? Decision support, of course. Also, I want to mention a single AI model is not enough when you deploy the AI clinically. AI tools and AI agents need to work together. A clinically viable solution requires a company AI system. A concept developed, I think, at Berkeley, a company AI system to ensure accuracy, safety, and adaptability. A company AI system integrates AI agents to AI tools and other software tools and database. I'll give you an example. For example, auto segmentation, which sounds very, like I said, quite mature now, a lot of commercial products now. But I believe it's more than just an auto segmentation AI model. For example, I think David also mentioned this, when you deploy an AI model in a new clinic, right? You need to do acceptance testing, model commissioning, adaptation, right? You need to align the AI model with the local clinical standards and local patients' data sets, right? So you can have an agent doing that. And when you use this AI model for your patients, you also can have an agent to run this auto-segmentation model. After that, review the output and assess the quality, and then suggest improvements where you can improve, right? And then refine the contours with maybe another agent, another AI model, right? You do this iteratively until you reach the clinically acceptable quality of the segmentation. So it's more than just a simple auto-segmentation model, right? But then you also need another agent to monitor the performance of the model, right? Because the model works today, it may not work 3 years later. We have done some research there. Okay. Okay. So we saw model performance deterioration over time because of data drifting, right? So you need an AI agent to monitor that, right? And another example is a decision support AI system, right? Again, it's more than just a predictive model. You know, most people think, hey, that's what you need for decision making. It's way more than that. You need to build a clinical dashboard and a visualization agent, retrieve, process information from multiple sources, present the key information to the clinicians in your intuitive format, highlights the tumor response trends, right? And pre-treatments, risk factors. You can enable interactive exploration of patient data. Now you can use the predictive model or case-based reasoning. You can retrieve and compare similar cases from the previously treated patients, right? You can also have an AI expert collaboration agent. You can simulate experts with different specialties, right? And facilitate this kind of virtual tumor boards, right? And support real-time peer collaboration and consensus building. And clinical guideline literature agents to give you the newest, guideline reference and literature. So in summary, response-based adaptive radiotherapy enables truly personalized radiotherapy with longitudinal adaptation. You need the AI to enable the workflow automation, clinical supporting, decision support, quality assurance, to ensure adaptive therapy is scalable and clinically viable. Single AI models are insufficient to handle the complexity of ART. And you need a compound AI system with agents, clinical software tools, database, and other AI models working together to provide a practical solution. Thank you.
Our next speaker is Dr. Laising, who is a professor of radiation oncology, medical physics at Stanford University. He'll be talking on the topic of multi-omics integration and pattern discovery using a very specialized technique called spatially semantic topographic maps.
All right. Well, thank you, Seferino. Also, I want to thank the planning committee for invitation. So I'm gonna switch gear, talk about the multi-omics integration for healthcare application. So when we talk about AI for precision medicine, there are three major pillars, right? What can you think about? Well, first, radiation, computational resource, the modeling, right? That change every 3 months. There's new model coming up. And then the third pillar is really the data. And last session actually gave a very comprehensive discussion on the data side, right? When we talk about data, there are a lot of aspects. You talk about the amount of data, humongous amount of data, the quality of data, etc., security, and the format. So, I think I'm gonna spend a lot of time talking about, if you really choose the format, inform the AI with the right information in the right format, actually you can speed up, you can do a much better job, have a much better AI agent. So, starting from 2023, all these foundation models really taking off. Nowadays we're talking about, terabyte, petabyte data for the foundation model training. So understand the data and understand the relationship among the data are very important. Okay, let me just. So data come in different format, right? Image, it's what we are, as a medical physicist, we are most familiar with, CT/MR, PET, you name it, and also, pathology, omics data. So let's just skip this because of time. And, understand the data will help tremendously. This should just give you one example that, we including the interrelationship among the data. You can see that on the top, that's actually the loss function. You need probably 1,000 epochs to really train a model. But now with a new model that we developed, you can essentially, with 5-10 peak epoch, you can get a much better a model, and that including foundation model, BERT, transformer, you name it. Okay, so data presented in different formats, right? Image, table, language, and graph. So I'm gonna focus my talk on the tabular data, omics, multi-omics, and sensory data, and also clinical trial, right? This all come in the form of tabular data. A related format is a graph. So we have a recent paper on, using a similar approach, discussing the application on graph. So you can refer that paper if you're interested. But in general, the tabular data, it's just like Excel spreadsheet, right? Everybody familiar with. But that's actually by far, one of the most difficult data format that for AI agent to deal with. Why? Because AI is trying to find the relationship between, the features in different sample, right? When you have a spreadsheet, you have a sample, right? Sample 1, sample 2, that's your column, and then feature 1, feature 2, etc. That it's really the feature, that's the raw. To process the data, the AI really need to know the relationship between the feature in one of the sample with another feature in another sample. The latest technology, like a transformer, is trying to find the quote-unquote long-range relationship among the features, but it worked to a certain extent. So for big omics data, it's actually, it doesn't work that well. So this is just a specific example of tabular data acquisition, single cell sequencing data. If you run a biology lab, you're probably using the technology on a daily or weekly basis. In the end of the gene expression count, you get a table, and then cell 1, typically you have a few thousand cells, and then maybe 20,000 genes. So it's a huge table, and this is basically let me just show you the. So again, sample 1 in the case of single cell sequencing, sample 1 is just a cell 1, and then you have a lot of genes, right? A few thousand to even 20,000 genes. And it's a big table. So in order to find the interaction among the genes of different cell, so we convert the gene expression data into an image, okay? This image, there are many ways you can convert a vector into an image, right? So vector is 1D and then go to 2D, because any gene can go to any pixel. But there is one optimal way to do it. That is really to maximize the entropy of the data system, or really just encode the gene-gene interaction into the image. So just this is actually the same image. If you place the pixel in the right place, and you get a very nice configuration image, but otherwise you get a very random. This is what you get. So we develop a technique that really just take into account the gene-gene interaction, and so that you can optimally place the gene into the right pixel, and each cell will be converted into an image. So you can see that this is on the top, that's a vector, that's a gene expression in the regular case, and then we can convert that into an image. You can see that if you convert that into an image, different type of cell actually show up as a very, very distinct pattern. I mean, at this point, you don't need AI really to tell, hey, this is a different cell, right? You can tell by your eye. So, but using like a technique like a CNN, analyzing this image representation of the cell will give you much better result as compared to you input a very random 1D vector to the computer agent. So this is the pipeline. So we convert the tabular data, so each sample or each cell is converted into a map, and that's called a genome map, and then that go to the CNN network that give, you can get all the downstream application like a clustering, visualization, cell recognition, and trajectory mapping, right? So the same technique can, so we benchmark the technology with different type of state-of-art technique, and you can see that the accuracy is like 10-20% higher than the existing technique. And the same technique can be applied to this is from the bulk sequencing data to single cell sequencing data. So in other words, you don't need, in a lot of cases, you don't have a single cell sequencing data, but you only have a bulk, or for the cost reason, you only have a bulk sequencing data. We can actually convert that into single cell sequencing data. Radiomics, right? In radiation oncology, radiology, we extract a lot of radiomics feature. The same thing, right? It came as a table, so we can actually convert the omics data into an image and then do the survival prediction, do all the biomarker discovery. So we find the accuracy is increased by 10-20%. So this is the overall pipeline. Aging, right? It's very, very useful representation for tabular data. You can see that, when the cell at a different age, they actually have a different representation. This is radiation oncology application, using the image representation to really present the fibrosis, right? Lung fibrosis at different radiation dose, you can see that the representation is very different. And of course, you can use CNN to analyze this image and to get the biomarker or the downstream application. So yeah, just to highlight, tabular data, clinical trial, omics, they can be converted into a map or as a genome map in the case of genomic data, and then do the CNN and then do the downstream application. The same technique applies to spatial transcriptomics. We have a website. You can upload your tabular data with all the image representation and also downstream application. You can actually do it through our website. I mentioned that so this genome map or this tab map, it's really just try to use some physical knowledge to incorporate that into the the data representations. So having a better understanding of your data will help you a lot. So in the case of, help you not only train the model, but also fine-tune a large foundation model that also help you, if you can incorporate some prior knowledge about your data. So this is treatment planning. Again, we can incorporate not only the text, not only the tabular data, but also the isodose distribution, DVH, right? So all those information can be incorporated into the deep learning pipeline, and then to have a better, in this case, treatment planning. Well, going forward, so we are not only incorporating the relationship among the data, but also among the modality. So I think my time is up. I have a timer here. And then, so to build a foundation model, so that will be much more powerful and much more useful foundation model, because all the information among the data, among the modality, different modality are incorporated into the process. And we're building a multi-agent that, good, right on time, that actually can be integrated into the radiation oncology workflow, and so the agent can talk to each other and then do the optimal decision making, and also facilitate the radiation oncology practice. So this is the summary slide, and then acknowledge my colleague and students, and thank you for listening. Okay, yeah, so we do a lot of teamwork. That's how we do the work. Thank you.
Great. Great. Good? Okay. So thanks very much for both of you for this interesting talk. Annie and I will just ask the first two questions, one for each speaker, just to get the ball rolling. I'm just curious, Lei, regarding the notion of spatially semantic topographic maps. Most of us are familiar with the clustering technique of K nearest neighbors, but this is so much more because it is on the semantic scale. And I tend to think of it in terms of tabular data as a, let's say, a multidimensional Rubik's Cube. You try to manipulate in order to extract a pattern from a multidimensional table or a hypercube. In supervised learning, the way you do it is you do a steepest descent, and so there's a criteria. But with unsupervised learning, what sort of criteria do you have in order to get to that pattern discovery?
Well, yeah, this is a great question. I like your analogy. Yeah, this is really just like you said, right? You reshuffling the data. It's actually surprising to us, just simply reshuffling the data in a meaningful format, in a meaningful way, that you can get so much more information out of the data. So in our case, we encode the interaction among the features, right, among the data element into the spatial distribution or spatial configuration of the data. So that's it. In a way, it is like clustering. I mean, think about the clustering, right? If you have a data, if you can cluster them first, you can throw away a lot of data and then reclustering. So there are just a lot of things you can do really to facilitate the data analysis. I mean, I think people are overly relying or trust computer to do the job right. But a lot of time, that's not the case. So I mean, human intelligence still needed and much needed, and this is a great example. So you can just really just get the interaction first, and then use an image. I'm a physicist. I see everything as an image. So put them into an image, and then you have a basically the interaction pattern that incorporated into image, and then you can use CNN, right? The CNN is a very powerful tool, but your pattern has to have some meaning, right? Semantic meaning. So that's what we did. So we assign some semantic meaning to the data. I think you can actually do this for different type of data. I mean, even imaging. So a lot of people think imaging is already image, but yeah, I mean, we are doing it. We actually trying to really get more semantic information for imaging data, but I don't want to go to the too much technical detail.
Thanks, Lei. Thanks, Steve. So very, very nice talks. So this is some questions probably majority for Steve, but also Lei, if you want to chime in. I think that's from me. I saw that also in the audience. There's one question similar. I can combine myself and with that question. So you guys both talk about the agent, especially the multi-agent. Right, so this is all the buzzword we just talked about. It's happening so quickly every day. Even 2 days ago, OpenAI just announced they have the built-in the agent. You can use it right away out of box. But you know that, so if you use agent to do some creative work, maybe generative work should be fine. But in the healthcare, the accuracy and deterministic is very, very crucial. For one agent, it could have made a mistake, right? Maybe have random mistake or maybe random errors or systematic errors. Now you have a multiple agent. So this errors can be propagated and even exponentially worse. So maybe finally your final agent think, okay, so there's multiple agents tell me the same thing, but a little bit different. How should I make a decision? So what do you think in this scenario? How do you guardrail this, or some ways they can, make this less severe?
That is super important when you develop this kind of multi-agent AI system, right? You want to make sure they don't tell you something wrong because we are dealing with patients, right? So it's very critical. In the development process, our strategy is, of course, you build the whole system bottom up, right? Step by step. So for each individual AI model, you have to do very thorough validation, make sure it works. For each individual agent, perhaps you will use it not immediately in a multi-agent system. You use it with, for example, with human users through the validation process. So for example, like this patient trial matching agent that we developed. Now we're deploying that clinically, right? Right now it's just more like an assistant to human clinical research coordinators, right? So in this process, it just provides, through a user interface, this patient, it might be qualified for this clinical trial, which criterion, this one, criterion A, it feels very sure this patient is qualified. B, but it's not very sure. So it tells you where you should look in EPIC to find out why the information is kind of vague, right? Human coordinator, research coordinator needs to do that. So this will take a while, this kind of process, before you have the enough confidence to use this agent system, to embed this agent system into a multi-agent system, or a multi-agent system. So other agent will take this outcome and make decisions based on that, right? So that's one thing you need to do. And then, of course, the accuracy of using, when you use AI clinically, it's super important. You always have to do, for example, uncertainty quantification. So AI knows, what it does not know, right? That is super important. And also you need redundancy in the system, right? When you run a large language model, how do you know it gives you the accurate information? You need to perhaps have multiple models working on the same task. So that is one way. Of course, there are other ways. For example, I mentioned about this chatbot we developed for CNS cancer patients, developed by my colleague Michael Doho, developed this interesting system. So there, you cannot just rely on the pre-trained model to give you the clinical answers to clinical questions, to medical questions. You need to ground your answers based on the clinical guidelines, based on the literature. So there are many things you need to do, but like I said, this is a very important topic. We have to be super careful.
Well, just add one more, keyword, right? You need an agent that is a quality officer. And really, you're building a human society on, using computer agent. So what a lot of key components in the clinic need to be there reflected in the agent world. Yeah, I think quality assurance is important.
Just a follow-up question from the Slido on the agentic AI. Can you name and describe one type of cancer which can benefit from agent-based AI in the next 2 to 3 years?
Never thought about this because when we work on AI models or AI, it's kind of AI agentic AI models, we kind of think of all the cancer patients that we deal with on a daily basis, right? Maybe I should say, I kind of imagine what kind of cancer types that will not benefit from agentic AI in the near future. Because we're trying to improve the clinical workflow, automate the process, and also improve patient safety, efficiency of the clinical tasks, and accuracy, of course. So in my mind, every patient will benefit from this work.
One question from the online. I don't know. I think it's for Steve, for you. The tumor shrinkage readout, it's highly delayed compared to the active cellular death. And how about using other image modalities with standard one combined with AI for faster and more accurate decision making? I think maybe this for the adaptive therapy.
Yes, for most patients, tumor shrinkage it does not happen even during the course of treatment, especially with the SBRT, the course of treatment is so short, right? So that you have to rely on, other, like for example, image biomarkers or liquid biomarkers, whatever information you can get for this patient to adapt your treatment. I agree with that.
Question for Lei. You mentioned about transformers and foundation models. Why do you think is the most likely reason why transformers struggle with gene expression data?
Yeah, well, this is a great question. I think we struggle a lot. Why transformer is a very powerful tool. Technically, theoretically, if you have an infinite amount of data, and by that I also mean that if your data is clean, no noise, no missing data, transformer will do perfect job. But the problem with transformer is really the convergence or looking for solution is really slow. It's just the way that it's designed, right? It's not smart enough to find a pattern. It's just really looking iteratively. You need a lot of epochs. You don't take into account the interaction between different cells. Okay, it just go. Typically, each input is about the 700 or 738 tokens. Okay, so that's barely enough for one cell. So you're not really taking, treating the data as a whole. So that's where, the problem arises. I think if you, so that's why. So we actually developing a transformer, basically dual transformer that one goes just like a regular token, and the other side is a genome map, right? So using CNN, ResNet and then you combine them. So we found that helped the transformer a big time. So in short, transformer need help, need more human intelligence to perform well.
I'm trying to combine, there's the questions online, and the audience was asking the speaker for the multi-agent system, how to make sure that the patient, the sensitive information remain anomalous. And combine this to another one, I think maybe they're related, is that as the AI researcher, practitioners, and how do you see this regulatory oversight and on the usage of the AI in the clinical decision making and the patient care? I guess this may be related to even the government policy. We're in DC, it's hard to avoid the politicals here. What do you see? All the policies can impact the research and clinical decision making, and plus your decision to oversight of AI development.
Maybe I can try to answer the first question, right, which is about the patient's privacy when you develop this kind of agentic AI systems, right? So our solution is to either use the local large language models, use the models locally, or if we use models like GPT-4, we use this Microsoft Azure OpenAI environment. So it's kind of like a private cloud. It's HICcup compliant, so there is no worry about patient's privacy there. But I do agree, you have to be careful. You cannot just use, ChatGPT and put the patient's data there. That's not, that's not allowed. So there are solutions like that, either private cloud or local models. So that's my answer to the first question. Do you want to address the second?
Well, last panel discussed this very extensively, right? You talk about federal learning. That's one solution, and of course, security GPT. That Stanford Hospital, we already started using that in our clinical practice, writing email, writing clinical note, etc. Right? I think those are issues, but they will be overcome with time. Maybe not as fast as people wished for, but there is a problem, there is a solution. As long as it's beneficial to our patient, I think we'll find a solution. I mean, federal learning is a great way to do it. Or you can, even just a lot of time I just thinking, hey, can we just using the feature space data instead of real data, right? So there's just a lot of research need to be done, out box thinking. So I don't think we have a solution right now, a generic solution, but it will be okay.
I have one last question, just to follow up on the spatially semantic topographic maps. You showed a very nice picture of a blur, and then by using these spatially topographic maps, you manage to extract a figure, you giving a talk, right? But this is unsupervised. So if ever it should work, we need a very well curated ground truth on which we know that the pattern that you have extracted correspond to something real or desired, because from a blur you can get a car, a boat, or anything by just on what basis then could you have the human intervention, so to say, get into the flow so that it's interpretable and it's explainable and it's real?
Yeah, well, this is a great question. This actually reminds me of the work people are doing on the diffusion model, right? You start with noise, you may ending up with anything, a human face, smiling face, or crying baby. So yeah, I mean, one solution there is a condition, right? You adding you conditional diffusion model. So that's one way to do it. I mean, in our case, we if it's unsupervised, in our particular case, we're dealing with some knowledge that we have some knowledge, right? Biological, Let's say if you do clustering. Clustering is unsupervised learning. After clustering, after UMAP projection, embedding, you still need to use your biological or clinical knowledge to really understand. Sometimes it may not make sense, and then you have to think, are there any what's going on in the pipeline, right? Yeah, I think, so that's why I keep saying, hey, the human knowledge is the key. It's not only in the construction of this topographic representation, but also in the whole pipeline. I think it's a great, really great alert to everybody. Just AI will make a decision regardless what, but as a human, we have to really digest and understand and make it trustworthy.
We still have time to ask probably last question. I think this is very interesting. Oh, yeah. I know we all have the physics background, so I think physics turn to start with simple system, and then finally we get into complex system, right? So one body problem, three body problem, many body problem. I guess so. You two talk about this multi-agent system, and in the clinical workflow setup. Now we are not just talking one agent; it's multiple agent. Because in the clinical workflow, realistically, you have to interact with the human clinicians. And I think this question is like how you're planning for the training needed for the multi-agent clinical workflow. If I understand correctly, that's a training for human and AI interface. What's the role of the patient safety and the quality officers in an HRO framework?
So I think this question is kind of related to previous question, right? So when you, again, when you develop multi-agent AI systems, you need to do it step by step from one agent, make sure that one agent works, right? And then you integrate that into this system. So that's, I think, one strategy to do that. In terms of, we did talk about like quality assurance. Also, they mentioned that you need perhaps at least one dedicated AI agent to watch the performance of the other agents. Perhaps you need for each task, each clinical task, you may need multi agents, a primary agent, a secondary checker, maybe another one to also look at anything possibly wrong, right? So you need that kind of redundancy. What else about the question? I don't remember now.
What is the role of the patient safety and the quality officers in an HRO framework?
I don't understand the question. Is that the agent that we're talking about playing that role, or can you elaborate on that question?
Well, I mean, I think it's a very generic question. Obviously, it's a very important question. We are all looking for answer at this point. I mean, I think common sense and of course safety standard, right? There need to be a lot of tests, right? Standard tests, just like more than Turing test for sure, right? Because this is a safety related issue. So I think, yeah, it's really just having some, what I learned during our research is, I benefited a lot from public domain data, and especially those well benchmarked public domain data, right? Like a leaderboard that the Meta put together, because everybody claim, hey, they are the best, but let's have a common platform, and also let's just open source your code, right? So that other people can test, can really, examine your claim, and then more important, your outcome, your result, right? So I think those open data, open source platform are very important, for our community as well.
Well, we'd like to thank both speakers for the very interesting talks, and the audience as well for the very interesting questions. Let's continue this offline, and I'm sure if you just Google the two speakers, you'll find more details of their presentations and their papers, and we'd like to encourage that and continue the discussions. Thank you very much.
Okay. So thank you all. We were just playing the Oscar music so we can walk off the last panel. We got deep into discussion. It's a pleasure to be here. I'm Caroline Chung, for those of you who don't know me. I'm Vice President and Chief Data and Analytics Officer at MD Anderson Cancer Center. I also co-direct the Institute for Data Science and Oncology, and I thought that my positioning in this, between these two sessions, I find very heartwarming because I'm a professor in radiation oncology as well as diagnostic imaging. So we're going to bridge and transition across, going from much higher doses of radiation and uses of AI ML, which have been florid within radiation oncology as a field, as you've seen, and transitioning over to diagnostic imaging, where AI has really had an explosion. And we're going to pivot a little bit, thinking about across the different domains that we're going to be covering in the conference today. We're looking at, radiation exposure, and we're going to have a provocative talk about emerging technologies, perhaps reducing radiation exposure down. We looked at it from a diagnostic perspective, leveraging AI to use lower and lower doses in CT. But what happens if you don't need that radiation exposure at all? So that our first speaker is Cameron Piron, who's actually the CEO and co-founder of Synaptive Medical, and he'll be discussing on this topic. And then subsequently, we'll be presenting, I'll be bringing up Jayshree Kalpathy Kramer, who will be talking about AI as well as quantitative imaging. So, Cameron?
Yeah, thank you very much, Carol. Next slide, please. Let's see if that, actually worked. So I'm actually been focused on how we can introduce more MRI into the patient care pathway for many years. And after my graduate school, I founded a company, Sentinel Medical, that focused on the use of MRI instead of mammography for early detection of cancer. And that was a heavy lift. The cost associated and the complexity with MRI was significant versus a single 2D view of mammography, which could be read very quickly, versus MR producing three-dimensional multi-parametric data sets with contrast injection. So radiologists were not happy seeing a big transition to thousands of images versus one. But the power of the contrast in MR was much higher detectability of tumor. And over time, as we optimized the imaging modality for MR, we accelerated the scans, we made the software easier to detect and do some early AI analytics to be able to find the tumor. The gap shortened, and now MRI today is being used at thousands of sites, so very rapidly. So MRI kind of squeezed into a really important application in particularly a very important patient group to start, patients who had BRCA1 and 2 mutations. So these patients actually had very poor ability to repair DNA damage from radiation. So it was a really important footprint to be able to take on. So this has really inspired me to think about how can we use MR in many different ways. Near the end of our time at Sentinel, we started using MRI for detection of responsive tumor in stage 4 late-stage cancer. And that was a great program with NIH and NCI, and essentially looking at multi-parametric MR and how consistent and quantitative could you pick up very small changes with introduction of different doses of chemotherapy before surgery. So really, again, a compelling case of use of MRI in a very different part of the patient care cycle. So we see enormous potential for where MR can be introduced into patient care. My company today is Synaptive Medical. We now build an entire MRI system, but we use it in the context of patient care for neurosurgery. So we're using, on the right, you'll see some images of what we do in the surgical suite. We have hundreds of sites using robotics and MR data being integrated into better patient planning, into better navigation procedures. We do this for surgery and stroke and drug infusions. But really taking up a traditional role where you'd see CT being used across the patient spectrum. And now we're able to actually inject MRI by making MRI more accessible. It's smaller and lower cost as well. In Canada, you might catch my accent, but we have a multi-center program between academic centers and companies called Innovate. And it's a specific application of AI in the context of image-guided therapy and intervention. So it needs to take a slightly different form than maybe traditional AI for image analysis and diagnostics. So what I'll talk to you today is about a different form of MRI. We're actually, instead of pushing towards very high field MR, which has really been the drumbeat since the invention of MRI in the 80s, we've really pushed towards midfield MRI, which is much more accessible, and really not giving up on the performance. We want to make sure there's nothing that's missed. I think that's a really important thing to distinguish with AI, is that we can't cloud the missing of something, whether it's a tumor or a stroke. It's really critical. So we wanted to really elevate the performance with hardware, and now we're at a point where we can show equivalent imaging performance as the high field systems. Now how can we use AI to make it more accessible and spread its use throughout the hospital system? So we do optics, we do MRI, but I'll just pick up some very interesting areas that we'll talk about today. Tractography, non-contrast utilization of MRI. So you can start moving away from CT perfusion cases, which are very high dose for patients. The ability to have stereotactic accuracy in MR, which really has not been something it's been a major weakness of MRI for years. And this really exciting new use of MRI in psychiatric applications, not just in oncology, that's becoming really quite interesting. So if we were focused kind of on neuro, that's an area where we're seeing explosive growth and demand with respect to for MRI utilization. There's very little replacement for MRI for brain imaging. Particular note is in pediatric and developmental work, there's been an enormous shift away from CT, and that's due to early exposure of radiation to young patients, and it has an overweight impact to oncological risk later in life. We're seeing a lot more use in MR for screening. You're seeing a lot of screening programs happening where they're doing full body imaging and screening. We're seeing some big academic centers using MRI to image the brain of any patient who's ever had a cancer before. And increasingly, they're able to pick up very small metastatic disease that can then be treated at a very early stage as well. We're seeing a big advent of a shift of CT for stroke to MR for stroke. This is something that's being used pretty extensively in Europe, and really powerful. You're actually seeing 25% more stroke versus CT or CT perfusion due to the ability to use diffusion MR to be able to pick up on swelling in early stage detection of ischemia. And on the right, I won't talk about too much today, but a really huge foundational shift. There's new reimbursement now for use of transmagnetic stimulation for psychiatric patients, very effective in drug-resistant depression. New reimbursement codes are very incentivizing to sites, so you're starting to see neurology sites taking on MRI, specifically fMRI and DTI, to actually track patient outcome and targeting of TMS in those patients. And on the far right is with the new drugs that have actually been released for Alzheimer's, most recently, the Eli Lilly's drug. These patients require not only imaging to include them into the infusions, but yearly imaging in the patients, 5 scans per year per patient. So if you just take that group of patients and you say every one of the 7 million people with Alzheimer's today in the US had an MR scan, that would almost be the entire capacity of all the MRI scanners in the US today. So something has to change. So traditionally, there hasn't been a lot of change in MRI. Usually very high field systems, very complex, very heavy, very complicated to use as well. And as we've talked about many times today, this complexity and variability in data really is an enemy of really consistent and reproducible AI and analytics. So we've really taken down our field strength, taken down the complexity of the system, and not fighting the physics, we can really achieve some really exceptional imaging, and I'll share a bit of that today. So the progression of the imaging has really been rapid. We've been really excited about that. So I'll talk a bit about the thesis of why I think midfield is the right way to image the brain. But we're able to do this really wide spectrum of imaging. Really everything you can imagine you can do in high field, we can do in midfield. We've done some clinical studies to compare to stroke detection with high field imaging, 3 Tesla, with midfield and then CT perfusion. And we've been able to actually detect more strokes and detect all the strokes that you can see at high field. And that's really enabled us to really focus on an application and then start driving the hardware to do better imaging, and then the end be able to apply AI and even things like compressed sensing to accelerate the acquisition times. So we can do everything you need to do to detect a complex stroke in about 15 minutes. We've been able to focus and push the hardware to get that to about 4 minutes in time. And then recently, we've been able to use some AI approaches to half that time in about 2 minutes. And then recently published on accelerated optimizations with compressed sensing that then took us down to 12-second acquisitions. So really remarkable. This is something that would have been done in a half hour just a few years ago. We can actually do with the same diagnostic reproducibility in about 12 seconds. This then frees up where you can put the MRI within the hospital. And so we did a study with Dalhousie University of putting it in the emergency room. And instead of using an MR at the end of the workup of a patient, what if you use it when the patient's admitted initially? And that really makes a huge impact on length of stay and also the cost of what you can do, cost of actually delivery of care for the patient. It means you can start expanding the use of MRI into traditional areas where CT would be used, like the emergency department for head injury. And these are highly compromised patients. You know, giving them high doses of diagnostic radiation is really not what you're hoping to do, particularly if you have really traumatized neural tissue. Just a little bit of the physics of why this works. For years, it's been a push to higher and higher field, and on the bottom, the Larmor frequency associates with the field strength. Over the years, you get better performance, better signal to noise, and better contrast. So you got both were improved. This starts flattening out at about 0.5 Tesla, and then you start seeing diminished contrast between gray and white tissue. So your endogenous information starts getting compressed. So we really wanted to target where we had our maximum information on a platform that we could really drive better hardware performance as well. So to speak a little more specifically about radiation therapy, we have our first few installations of the system. This is actually in Hackensack, New Jersey, alongside a ZapX head-only radiation therapy system. And it really kind of brings together a whole vision of what we've been trying to achieve with this system. We create really beautiful images, but images that are geometrically accurate. And so we just had a paper accepted today to medical physics showing that we could actually get under millimeter accuracy in a patient, but in phantoms better than 0.2 millimeters. And of course, that's the key for radiation therapy. We work very hard to get accurate beam delivery, but if your image is off by several millimeters, you're not getting the benefit that you'd hope. So we actually published on this. It was really remarkable. This was kind of inspired by some of the work we were doing as part of the I-SPY trial for breast imaging. So how could you actually get MRI to be not just quantitatively, but geometrically very repeatable and reliable, which of course is a big strength with CT. So not only the cost and accessibility, but making sure that we're really much more accurate as well. We think this will have a really big impact when you start looking at trying to trace out the boundary of a tumor, where you could really be able to hit the tumor and not just hit, maybe fibers that are under duress. So it really becomes a really critical point of differentiation. Similarly, accuracy is essential for kind of a new wave of medicine, which is bioelectronic medicine. This was kind of course, developed in the heart with pacemakers, then adapted to the brain for deep brain stimulation, and now being extended with probably about 12 different companies with different conformations of deep brain electrodes. What's important is to be able to see the endogenous structures that you're targeting, but there's a real problem with MRI once you put in implanted devices. They tend to be incompatible. They may be heating up when you're using very high changing gradient fields and RF power. So at 0.5 Tesla, you don't have that heating on electrodes. So it's this heating of electrodes at 3 Tesla versus 0.5 Tesla. You can actually see there's no critical heating. So critical heating is about half that level. This is becoming more important because people have more implants. About 15% of patients have some sort of implant in them today. So where MRI is typically the gold standard on detection, but once an implant's put in the patient, you can't go back and get an MR scan again. So there's enough patients with DBS probes out there that they're having problems working up patients with tumors and strokes because they're incompatible with the imaging. So really, I think an important evolution we're seeing as well. For Alzheimer's disease, the indication to introduce somebody into the therapy is a clear MRI for safety, looking for bleeding of the brain and swelling, but also looking for indication of amyloid plaque on PET. So we've been able to really apply imaging for both the detection of microbleeds and swelling, but also using a thing called T1 row imaging, which actually is a surrogate for detection of amyloid plaque as well. So again, a patient population you hope not to be giving a lot of radiation to in a serial manner. How can MRI fit in and be a tool to be able to track over time as well? With respect to quantification, again, this is something we published just a couple of years ago, but really important to look at the serial variability of imaging metrics, in this case, segmentation of different structures of the brain over time. In 3T is well known, you get great imaging, but you give up that contrast, but you have much higher variability. So looking at tracking of patients over time, you're seeing 10 to 14% variability in these same structures. And at 0.5 Tesla, we don't have that. We're not fighting all the effects like coil shading and susceptibility artifacts in a patient. We're able to take that down almost an order of magnitude. And I think that's absolutely essential for complex AI analysis when we want to be able to do more with smaller patient data sets as well. And just my last slide, just something we published on very recently was the ability to actually use MR in areas where traditional MRI has not been very useful, so sinus region. And so this is an area where we've been able to optimize and reduce the scan time to 2 minutes. With some AI evolution, we'll be able to do this in about 15 seconds. And so you're getting away from a huge patient population, that's millions of patients a year, to be able to look at the sinuses, be able to differentially diagnose the patient, be able to track and detect tumors, and a really big shift away from a lot of radiation being dosed to patients to something that can be really effective and really, I think, integrate much better into interventional approaches as well. So thank you very much.
Thank you, Cameron. That was a great talk. Our next speaker is Jayshree Kalpathy-Kramer. She is the Endowed Chair in Ophthalmic Data Science and the founding chief of the Division of Artificial Intelligence in the Department of Ophthalmology at the University of Colorado School of Medicine. And we're looking forward to hearing your talk, Jayshree.
Thank you for the invitation to be here. It's such an honor to be in this location. You might wonder why somebody from ophthalmology is here in the symposium. But fortunately, our first speaker of the day actually talked a lot about the uses of imaging in ophthalmology, especially the notion of oculomics and the idea that you can take a picture of the back of somebody's eye and learn all kinds of things about a person in terms of their risk for cardiovascular and other diseases. So prior to joining ophthalmology, I've been in the field of radiology and oncology at Mass General and did a lot of work in AI, probably for now 20 years. And one thing I've come to learn is a lot of the problems are the same across domains. So the challenges we have in going from having algorithms that work in the lab to having something that you can deploy safely and trust in the field are very, very similar no matter where we are. So as we've seen thus far, and we'll probably continue to see the next 2 days, AI is being used sort of essentially throughout the workflow. We heard from a previous speaker in how the AI is being used in some parts of the image reconstruction and acceleration of the image acquisition. We've heard from Mike Tilkin in terms of the applications of AI in radiology and how many FDA-cleared tools there are. Radiology obviously has been at the forefront in the use of AI, Ophthalmology is also an area where we've seen a lot of use of AI. In fact, one of the first autonomous AI tools was actually in the field of ophthalmology for diabetic retinopathy screening. A lot of the work that we are seeing from many of the commercial vendors is actually in the space of going from a raw image to the reconstructed image, leading to reduced dose from an exposure perspective of contrast agents, as well as acceleration and better resolution and better imaging in general. So AI has been used a lot in this field, this area of image reconstruction. From the radiology perspective, a lot of what we've seen is in the diagnostic perspective. So if you looked at Mike's chart in terms of where the different algorithms were, image analysis was certainly one of them. CAD-T was another big chunk. Some diagnosis and detection algorithms as well. From the academic perspective of publications in the literature of where AI is used in imaging, a lot of what we've seen has been in that diagnosis space, as well as things like segmentation. So from the sheer number of publications, that's the area that we've seen a lot of work on thus far. This morning, Caroline and I were chatting as we were walking over here. There's in some ways a huge gulf between what we see in the forefront of these frontier models from an AI perspective. So we've seen tremendous progress in terms of foundation models, in terms of large language and vision models, all of these things. But if you look to see in terms of what is actually being used in the clinic, it's surprisingly, there's quite a gulf between what we can do in theory and what we see happening in practice. And there's many different reasons why that might be, but that's something I'm hoping that as a community, we sort of figure out how to translate things and move them from what's possible to what we really like to see. In terms of what applications of deep learning in radiology, we've seen image reconstruction, segmentations, response assessment. We've heard a lot about radiogenomics, survival predictions, and things like that. So this was a relatively recent survey on the use of deep learning for image reconstruction in CT. Again, there's lots of work in this area. And in fact, there's a lot of work in the commercial space in this area. A lot of algorithms are already deployed and available commercially. This allows for a dose reduction of fairly substantial amounts depending on the kind of methods and the tools that are being used. Artifact reduction is another area that people have used. And there's many different ways in which this can be accomplished. So going from the low-dose sinogram to essentially the image, we can just have a direct conversion from the sinogram to the image, or we can use a variety of hybrid approaches where you improve the sinogram, so you use deep learning to make a better quality sinogram, and then use more traditional FPP or iterative reconstruction methods to get the image, and then perhaps do another deep learning to make the image better in terms of resolution or other things. So again, there's a variety of ways in which people have combined this, but the idea again is going from the sinogram to an image to potentially a higher quality image, and there's a number of products out there already that are being used. Segmentation is an area where we have seen a lot of work for the last 5 to 10 years. And obviously in radiation therapy, as we heard previously, this is something that's making its way into being used routinely. Why might we want to do that? One of the questions that we've seen discussed is it doing things that make life easier, more efficient, but also potentially reducing variability and improving conformity. So we've done a lot of work in the past looking at agreement between clinicians in terms of contouring, and we see a lot of variation, and the hope is that as we get these AI tools being used, potentially we'll start to see better agreement and more better consistency as well. This was a study we did in terms of adrenal gland segmentation. We had 5 different people, 5 experts segmenting the adrenals, and you can see a fair amount of variability. And what we see in the bottom right is the AI model. And the difference between the AI model and any of these in terms of inter-rater agreement was no different. We've seen it a lot of use in brain tumors. Some things such as the BRATS effort, which made publicly available data set, have really increased the number of algorithms that we've seen in that field. And so I think, again, as we talked about making public data sets available, it's important to think about how these data sets can help propel the field forward. This is some work we did look in brain mets. We've heard from many clinicians that reading cases with brain mets can be challenging because there's a lot of them, and essentially tracking each of them over time can be a pain in a sense. And so by registering and segmenting these and sort of uniquely identifying each met, we can see how the sizes and change over time in response to therapy. What's typically used in clinical practice for assessing the tumor burden is often bidirectional metrics, unidirectional metrics. And what we see is because of the way these are tracked over time, you can have the same overall tumor volume, but very different configuration. And because people, again, have tended to essentially use clinically only single or bidirectional readings, the ability to distinguish between these different configurations can be challenging. So AI tools allow us to really scale up the ability to track all kinds of, not just tumors, but normal organs of the whole body and get large-scale data sets that allow us to do that as well. An area that's been very exciting is this notion of opportunistic screening, the idea being that you've already taken an image of a CT of a person for something. Can you also segment all organs, all muscle, fat, bone density? Can you do a lot more with the data that you've already acquired in terms of looking at things like sarcopenia, cachexia, looking at osteoporosis? So opportunistic screening enabled through the use of AI is really tractable in a way now that it was not possible even a few years ago. Tools like Total Segmentator, which essentially you feed in a CT or an MR and automatically get every organ segmented, now allow you to create sort of normative atlases of different organs and see how those change during the lifetime, how they change with disease, and so on. We have to talk about generative AI. It's very much has taken over in some ways, and even in the imaging space, it's being used for a variety of things, like both diffusion models and GANs and others are used for reconstruction, registration, outlier detection, disease detection, looking for classification, segmentation, and so on. So a very exciting use of all of these tools in imaging as well. It's really getting quite easy these days, as we've talked about, to train models, right? You can just take your data, you can put your annotations, you have, even a few years ago, you had things like AutoML, where they've shown that clinicians who have no coding experience can essentially create AI models. As long as you have data and annotations, you put it all together and outplops your code for an AI model. Now with ChatGPT and Cursor and Cloud and all those things, you can have your AI algorithm written out. So not only do you sort of get out the trained model, you can actually, without much experience in coding, get it to write your code for you. You can get it to write your abstract for you. We've shown that it does phenomenally well. And now with this whole idea of vibe coding, you essentially talk aloud to your cursor and you tell it, okay, this is what I wanted you to do. I want you to create me an algorithm that will create a classification for any disease, and it does that. You don't even have to write one line of code. You just tell your tool what you want it to do, and all of that is doable. So the challenges, though, are what we see is a sort of funnel. Most of the public, at least prior to a few years ago, most of the publications actually only used internal data sets. Very few of them validated their algorithms externally because it's very hard. It's hard to get access to data sets from other sites. It's hard to get your algorithm deployed elsewhere. And then going through the regulatory process, and then going to the next step of deploying. When you ask clinicians or academic centers how much effort it is to even validate an external algorithm, it's not a trivial amount of work to set up the infrastructure that allows you to take a vendor's algorithm and deploy it and get results. And then doing the continuous monitoring, which is really critical, can be very, very hard. And so we see this sort of funnel where there's a lot of publications on the use of AI for all kinds of things, because it's really very easy to do that today, but to get it to use in the clinic all the time safely, where things can change, is really challenging. So from our experiences, we've seen these many challenges. The first one is on generalizability. These models tend to be brittle. They work really well on the data that they were trained on and do not work well on external data sets. And we've seen this no matter whether we're talking about radiology or we do a lot of work in cervical cancer, we do a lot of work in ophthalmology. In all of these cases, we see the same issue. They don't necessarily generalize across populations, across disease presentations. And so how do we put in guardrails to know even if the data that you're trying to apply this new model on is within the distribution that it was trained on and should be used is a challenge. This whole idea of shortcut learning. We've heard, again, from this morning about how you can take a picture of somebody's eye and assess their risk of all kinds of things. One thing that when we look through the literature, this is an area we do a lot of work in, this notion of oculomics, and the idea is that you can take a picture of somebody's fundus and they get a sense of whether they have a risk for developing Parkinson's or Alzheimer's or whatever. And what we found is many of the publications did not adjust for age, surprisingly to us. So what the model was actually learning is age. And when we adjusted the age, the AUC, the model dropped down from 0.8 to 0.5. So what the model had actually learned was a proxy for disease, for Parkinson's and AD, which is age, and not really the disease. So we've seen other people talk about this, the models are extraordinarily good at being able to pick up things like self-reported race. They've shown that you can take a picture of a chest X-ray and say what somebody's self-reported race is with over 95% accuracy. How humans cannot do that? How does a model do that? What is it picking up on? These models are black boxes, so we can't really interrogate them and say, how do you know? When we start to deploy these models that are completely black boxes, that are not very transparent, how do we know that it's not picking up on a shortcut of some sort? So this concern about shortcut learning is something that we need to be quite aware of. This was the third one surprised us. Sometimes these models are not repeatable. You take the person, do test, retest, and they don't always get the same answer. Often they're not calibrated, meaning that the score of the model is not necessarily associated with the risk of disease. We have a lot of silent failures. The models can be confidently wrong. They can be the score can be very high, but the model can be wrong. So how do you deploy them safely? We see a lot of over-optimistic reports in the literature. There's a lot of overfitting. The notion of explainability and interpretability continues to challenge these kinds of models. They can be biased in very hard to detect ways. The other challenge that we often see is this notion of incorrect metrics. So what is a correct, obviously if you have relatively low prevalence, using accuracy is not great. People often use AUROC, but again, when the data set is balanced, when the prevalence is low, we don't really have good metrics that people use. I mean, there are good metrics out there, but people don't tend to use them as often that take into account like all aspects of the confusion matrix, for instance. What is ground truth? This is something that continues to challenge us a lot, is where do we get really good ground truth from? Because we've done many studies when we ask the experts across domains to rate the images based on likelihood of disease, and we get very different answers. People tend to be, again, this is both in ophthalmology and radiology, people tend to be lie on the ROC curves in different parts of the ROC curve. Some are more specific, some are more sensitive, meaning people are under colors and over colors. And this tends to hold through over time. We've had the same people come back and we compare them, and they tend to be, again, on different parts of the spectrum. Some people tend to definitely are more cautious. Some people are more are okay with because many diseases lie on a spectrum, finding that ideal optimal cutoff point can be difficult for humans as well as models. People say, okay, why not use downstream things like response or biopsies? And those are obviously great to use, but sometimes the problem is that people act on how they feel. And so if you use who got treated, it really depends on who was a clinician treating them. So some people treat at a much later point, some people treat at a much earlier point, and using that can, again, we don't have the counterfactuals in that sense. So getting to ground truth can be quite challenging. There's often inadequate testing and validation in the field. So there are many frameworks out there, and one that we developed recently is this thing called Future. It's again an international consensus. A lot of the group was from Europe, actually, the few people in the US. And the idea is that we need to have tools that are fair, universal, traceable, usable, robust, and explainable. And this has to be happen throughout the cycle. So before you develop a tool in the design phase, we need to really think about very carefully about all of these things in the development phase, evaluation phase, and deployment phase as well. So again, there are many such frameworks out there, but it's important that we use at least something. Very often that we don't have sort of a checklist or a framework that we can assess all of the tools through. So again, this is our internal checklist in terms of what we think about before model development. What is a test retest? Does it work across, we take it somewhere else on a different scanner in a different population? Does it have an out-of-distribution detector? We were doing some work in cervical cancer screening. We had a handheld camera. It did really good job of classifying the disease, but if you took a picture of somebody's sort of fist, it would also give you an answer because it didn't have the first step of saying, is it a cervix or not? And many of these tools are like that in that they don't have are the out-of-distribution detectors as a first step of the subsequent AI model. Is the model calibrated well? Does it make grave errors? When we have, again, diseases on a spectrum, in the borderline cases, making an error is quite different than making errors in the extreme situations. Is it confidently wrong, or is it when it makes an error is a score in the middle? Do you look at image quality? Do you need to have image quality assessed before you feed in the AI model? Does the image actually contain enough information to make the prediction on the downstream disease that you're trying to make on? Should it be adapted locally? Or what is a continuous monitoring plan? We've heard a lot of talk about federated learning. A question that keeps coming up is, do we want a single federated model that works relatively well on all of the data that it has been trained on? Or do we then want to adapt locally and fine-tune on the local data? And how do things like that, how are they even monitored and regulated? Because if you're going to be tweaking your model each time, there's all kinds of regulatory implications. On the other hand, you get much better local performance if you do that. So there's sort of trade-off between a general model that works relatively well to one that's hyper-tuned for your local population. There was a really interesting FDA publication that came out recently. This is a paper out there. And so they had, it's definitely worth reading if you haven't already seen it. It's LLMs and generative AI is a unique challenge because of a variety of reasons, including hallucinations. They were talking about AI scribes, for instance, and it can hallucinate or include diagnoses that were not discussed. So we heard from our first speaker about tools coming on that are better able to assess LLMs, specifically things like hallucinations. Those are really important before we start to deploy generative AI. The whole notion of AI lifecycle management. So we need to think about the environment in which it's being used. We have to have an information ecosystem, but many, many institutions don't have that. So how do we allow for the development of such ecosystems? And then finding this balance between big tech, startup, this is something that we in academia grapple with a lot. And then the tension to optimize financial returns versus improving health outcomes. So all of these things, I think, are something that as a community that we continue to discuss a lot of. So thank you.
Thank you both for those great talks. Very thought-provoking, Jayshree, as usual. So I'll start off with something, we'll warm up and do a little bit of an easy piece. In terms of AI applications within the diagnostic imaging space, what are you most excited about, and what do you think is ready for prime time today? For both of you.
See a lot of, in MRI and CT, accelerated imaging. So ways to go faster. I think there's something that has to be watched out for when you start giving up. You trade speed for potential missing something, right? That's just so essential in screening. So that has to be a really proper check for that. But you're seeing that across the board is, you know, the cost of MRR versus the ability to speed, you can really have an immediate return on investment. So you've seen a lot of evolution there. What I'm most excited about is across modality, but across discipline. So the ability to link pathology results with spatial information and imaging, which has never really been locked down. So the ability to really get that ground truth built into imaging in a way that hasn't been done before.
You know, I completely agree with that in the image ecosystem is very nice, great area. The other area, I think, is quantification of all of us. So we have still, even though we've had these tools for automatic segmentation, they are really not fully used with clinic, and I'm hoping that it makes it so that segmentation is something that mostly. Better now? Okay. So yeah, I think segmentation is a fairly trivial example for quantification of tumor burden over the lifespan. But quantification more generally, whether we're talking about DCE, MRI, or other things. So quantitative, making imaging much, much more quantitative than it's been, I think is, we have the technology now. I think we just need to start deploying it.
In terms of the follow-up on that comment there, Jayshree, and we're actually going to be talking about quantitative imaging later in the symposium, so great segue. Cameron, as we think about accelerated technologies, what should the vendors be doing from a QA/QC process, as well as revealing to the end users around those acceleration techniques when they leverage AI, so that they understand so that you keep the imaging in that quantitative imaging metrology?
Yeah, no, I think it's essential, and I'm not sure the vendors are doing enough in that space, to be honest. I think the systems have become more opaque, and less accessible, when I think, given our trust in new algorithms, you need to have much more visibility to what's going on. So I think I think there needs to be a really definitive pushback to be able to let people see what's happening behind the algorithms so that we can have that trust.
And I think the notion of model cards had been brought up before, but I think we really need to sort of standardize that aspect of it. So we need to know what the data was used for training the models, what the model characteristics are, and where it's likely to break. There has been some really good studies that showed that depending on the data used to train the model, whether how much it had, like it was a brain tumor case, but if it was all normal patients that was used to do reconstruction, it made the brain tumor disappear, and vice versa. If it was all trained with tumor patients, it introduced a lot of tumors in it. So this balance between the data used for training is really important. And from the vendor perspective, we need to know how likely it is to hallucinate based on the data that was used for training it, for instance.
There's a whole range of model card templates out there that are starting to mature, and we're still early in these days. Do you think that the model card templates that have been captured so far, I feel like many of them are focusing more on the patient population characteristics when you say describe the data versus the technical, and there's the biological and phenotypic versus the technical, and I'm curious to get your thoughts on that in terms of what should be included.
No, I very much agree with that. I think we need to capture all of that, because if we just have sort of broad demographics, that's great. We need that, but we need a lot more than that in terms of, we need to know the sort of range of spectrum of disease. We need to know anatomical variations. We need to know disease presentations. We need population differences. So we need biology plus all these other things.
I want to ask another warm-up question. Where do you see the future of generative AI and large language model in the general medical diagnostics? You mentioned FDA have some concern, right? So where are we going next?
Personally, I'm very excited about it, but I think it's with good reason that there are concerns. Till we can have sufficient guardrails, and till we have the technology that allows us to figure out when there's hallucinations or when there's
other things. I think we still have to be a little cautious. In terms of things like counterfactuals, it's really great to explore what-if scenarios. So we've done, many people have done this, but you can simulate what would happen under different scenarios and things like that. It works really well. It works well for more traditional things like classification and all of that, but there's still a little bit of concern when you're generating synthetic data, for instance, to make sure that the physics-based and biology-based constraints are implemented in a way that are valid, in my opinion.
Sort of related question from the audience along that, in terms of, you mentioned the black box nature of many of these, and the question is around whether AI/ML models that are published should be required to produce graphical explanations, example, force plots, or something like that, to present an easier way to explain how these models work.
So I think I'm not the only one, but I think at least with the current technology, some of these post-hoc methods like saliency maps are quite flawed and have to be used with a lot of caution. And I think we have to be very, very careful in saying you have to provide an explanation. Firstly, because technically today's technology has some limitations. There's different ones, attention mechanisms and things like that, that might be fine. But many of the traditional ones like GradCam definitely had challenges. The other thing is that when we ask clinicians to explain their thinking, we get a lot of variability. And so the question is, do we necessarily have, it's a very controversial question in terms of, do we want it to do something that the clinician, there's variability in the clinical space in terms of explanations. How do we balance accuracy and performance with the need for human explanation? And I think, obviously, it makes it harder to monitor these models because if they don't provide explanations, you don't know how to assess them, especially models that humans cannot assess, right? We have AI models that will tell you what your risk of developing breast cancer in 5 years is. They seem to work phenomenally well, but no human can assess if they're correct. They can take a picture of your eye and say what your risk of heart attack is, or MI, or whatever, but no human can do that. How do we deploy these models safely in a way that we trust without an explanation? Because they don't have they don't point to the area. They seem to work well based on retrospective and some amount of prospective data. How do we gain trust in deploying these models that are not something that's easy to check? So I don't know. I'd love to hear your thoughts.
A lot of really important points there, right? That's, yeah, I mean, I don't have an answer to it. But I think it's an important thing to focus on and understand how to move forward.
I guess the other question that's philosophical, and I'm not expecting a concrete answer here, is you mentioned sort of saying, well, we can't really explain these models, and should the models be completely explained? Because human thinking is different and everyone has a different explanation. Do you think as we move towards, as we build these models, should it actually be mimicking human cognition, or is it a different mechanism that we're actually deploying?
I think it's a different mechanism. I mean, increasingly you're seeing solutions coming up that are just not intuitive, right? But they're correct and they're logical. So I think that's the strength of an orthogonal means of adding to intellect. So I don't think we want to curtail that, but need some sort of visibility to it because it's a bit unnerving, I think.
Speaking of things that you can't necessarily appreciate, I'm going to go to the image reconstruction space. You said that Jayshree, you present a lot of AI that has been used on image reconstruction. And yet, these AI models can also potentially find a lot of patterns in data that we cannot necessarily appreciate. So what data should AI models be trained on? The image reconstruction has been focused on because the consumer of the image reconstruction is humans. And so we reconstruct that imaging data in a way that's human consumable. But should that reconstructed image be the data that we're training AI models on, or is it the raw data?
On that topic. But no, but it's a really good question, right? We reconstruct it for the way we think.
is that the best way? Can we go from the raw data to the result that we want?
It's similar to that in terms of their image reconstruction. There's a lot of technology that's being presented as we reconstruct that image. Cameron, you know, is it that should vendors be providing the raw data in addition to the reconstructed images that we can actually start to better understand what is happening?
Yeah, I think definitively yes. I think the MR world specifically is a perfect example. You take some, you know, dense RF data, and often real and imaginary data is even like merged together up front, and then it goes through a Fourier reconstruction. Like you've really funneled down that information. So I think there's just very little work is being done there, but I fully think that there's a wealth of information filtered out through the process. And I think that'll transform imaging and transform MR. I'll just quickly add, we did work in early days in breast MRI and registration with ultrasound. So we'd use MRI to target where to deliver an ultrasound probes for easier biopsy. And what was really remarkable, these were tumors that were missed with ultrasound, screening ultrasound. But when you targeted it and you took off the ultrasound filters that are kind of built into the system, you could see the tumor. Because the system, the ultrasound units had been trained for years to highlight and make a tumor with the knowledge we have. It's something that's echogenic and less, I guess, more fibrous and less cellular. So the algorithms over time optimized to see those tumors, which you could already see well, and the ones we couldn't see became harder to see. And I think there's probably an analogy there with ultrasound like MRI as well.
Great example. That is a great example of how we can actually migrate and kind of converge on thinking rather than keeping that open space of what are we actually detecting, because these are measurement detection tools at the very base. There's a question from the audience around the fact that the vendors are invested in AI integration, but reimbursement policies discourage double charging, limiting incentives. So how can we accelerate AI adoption while ensuring affordability for patients? And if either of you want to take.
I think it'll be a back and forth for a while. I mean, it is interesting. In the 90s, there was kind of AI analysis for second look for mammography that was called out as a reimbursable code and then kind of fell off, and now new codes are coming. So there's this tug of war all the time. And, you know, I imagine that's going to happen again and again here. So there are interesting new codes coming out specifically for quantitative MR, recognizing that is actually harder to do and more important. So that I think that it may change how the codes are allocated as well. And then some of these codes, of course, are embedded within entire procedures as well. So we were just looking at a neurosurgical procedure, and there's probably AI being used across this procedure 6 different times, but not called out as a single reimbursable item. So I think it'll be interesting. It's going to change, definitely.
I ask another question from the Slido. So with the faster method of screening and the ability to proactively imaging, do you run the risk of over-diagnosing or over-treating disease in a similar way of how PSA screening causes over-treatment for prostate cancer? So how do we avoid over-treatment?
I think it's a critical question. You know, so, you know, I served ads last night getting off the plane for full body MR screening, right? So you're going to see more and more of this. You're going to see more and more of early screening, but that has to come with a means of better specificity, right? If you don't have a perfectly specific imaging modality, which you don't, then you're going to lead to biopsies, lead to surgeries, lead to everything else downstream. So I think the two have to go hand in hand. Just better screening on its own without the closing the loop with diagnosis and treatment has to be done responsibly. I think PSA is a good example of that. You know, MRI has really taken the field now for prostate screening. And I think things like watchful waiting are becoming important paradigms as well. So not just seeing you have a mass in MR, it's an immediate prostatectomy. You know, it's actually what's the right interval of screening to make a decision on when you need to take your next step in the treatment.
Perhaps that goes back to your earlier comment, Cameron, about not just detecting there's something there, but connecting there's something there, here's the potential biology that's underlying, and do we think that's going to change very quickly? Is it benign, malignant? What could it possibly be? And that'll require a whole different type of data generation for us to get there.
And seeing these full body MR sites, I think, is exciting, but it's just not consistent enough to do full body diffusion weighted scans, and you're going to see everything. You really are. So I think that's going to be, you're going to see a lot more pushback. I know the radiology community is already pushing back on these very, low resolution, fast full body screens that use AI to accelerate the scans. You're asking for problems, I think.
There's an upvoted question from the audience just around the kinds of devices that can be used within your 0.5 Tesla system. So perhaps you can share that with the audience.
Yeah, so we, our engineers designed it very carefully, so the length of the magnet is shorter than the frequency of the imaging. So you actually can't induce heating on any conductive element. So that means theoretically every device means we have to actually test them just to be certain. We've tested, I think, 50 different devices, and there's been no incompatibility. There's a lot of interesting devices. Devices have a lifetime, so there's a lot of patients who might have implanted leads from a pacemaker, for instance. So the pacemaker is gone, but the leads are still there. And those cause enormous problems in MR because you can't really predict the orientation, and it can cause really unusual electromagnetic effects. So we've tried to design it from first principles out, knowing that you can't induce any heating on any electrodes, and that makes it kind of amenable to every device going forward.
We were talking about, you had mentioned ground truth, and your example about the aging patient is a great one. How do you think that we could leverage AI to better redefine normal in our data? Because I think that there's a lot of normals in our data that really just represent the data that was collected.
And I think, I'm hoping that as we start to analyze pretty much all the images for all the things, right, segment everything and see what the range of normal looks like, we really will get better understanding of what normal did. I mean, we've done studies where we segmented all kinds of organs, and the range of possibilities is large. And typically when we only do disease versus not, we're only looking at the disease. We're not looking at sort of the range of what is normal. And so I'm hoping that AI will allow us to, at scale, get better normative assessments. But yeah, I think it's a good question. Do you have a thought?
I mean, I think that taking the unsupervised approach is probably the better approach. I think that there's a lot of bias and dogmas that are inserted into normals when we actually take it from expert opinion in many ways. And so I think there's a lot of learning to do from that unsupervised approach. Agree.
In the brain, the most extreme organ, they're starting to do connectomics imaging. So you're looking at fiber patterns and resting state fMRI networks, and and then segmenting into different groups. And then what is normal? Get a little bit of OCD, little depressive, are these, do you treat them, or this is just who you are, right? So I think that's the extreme case where the baseline of normal, what really is that?
Buckets of normal, but it's neither here nor there. So the other question that we've gotten from the audience is around, can we use AI ML in improving the precision of SPECT CT images or PET CT images, and are there cases that support such applications? Another question from the audience is around how can MR accuracy, and perhaps I'll call it quantitative MR, help with GBM treatment with radiation?
You're best suited to answer that.
You can start and I can add.
I mean, I think that's something we've been really desiring as a field for a while now, right? How do we take multi-parametric MR with diffusion and K-trans or whatever the DC parameters and DSC, and how do we combine all of that to get local definitions of disease, and how do we then use that to look at disease response assessment? And so again, we've seen a lot of variability in the old days with even trivial things like AIF, right? How do you do quantitative DCE without getting all of these other things? So how do we make DCE or DSC or whatever the parametric MR technique that we want is to be much more consistent and quantitative and not operator dependent as much? And then how do we take those numbers into something that's actionable? But I think you were...
I mean, I think that when it comes to targeting and radiation, we're still, the precision of the delivery of the radiation is incredibly high. And we've gotten to a place where we could actually very, very precisely miss tumor because of the way we're defining the tumor. And I think that there's a lot of work to be done in actually defining the biological target in any targeted therapy, radiation being one that is highly precise in delivery. But the actual target definition is still has major gaps in terms of our understanding. So when we actually look at, let's say, ADC as a diffusion measure, what are we actually looking at? We haven't really quite deciphered. There's been some studies that have attempted to look at, functional diffusion maps and trying to map out, does that map to cellular density, et cetera. But is that truly what we're looking for when the tumor starts to get very aggressive and there's enough necrosis that starts to mess up what you're actually looking at biologically? And so going back to Cameron's point about connecting the true biology and getting that in vivo imaging, getting that in vivo biological information out of the imaging data will require us to be more quantitative in our image acquisition, but also have us intentionally doing research where we're connecting the biology and the pathology spatially mapped to the actual imaging. Because right now we're still reporting patterns, we're reporting quantitative measures, but there's still patterns in those measures. So I don't know if you have more to add there, Cameron.
I think even like looking at a GBM and, people taking a single biopsy to characterize it, it's just, hopeless, right? That's a bad starting point. You've got enormous variability in the mutation and you're taking one biopsy sample. So there's just so much more that can be done there. I think MR has a lot more to offer, and we can ask more of it. And, I think even things like tractography, the importance of seeing where the tumor plane is growing, you see that in other parts of the body and breast and otherwise along the speculations, but now we can actually see the fibers in the brain. You can see the interface of tumor and healthy, which can be more important for targeting as well.
Well, thank you both for a great discussion. Hopefully it stimulated the audience in terms of sparking additional research ideas. You can see there's a lot more growth to happen and a lot of exciting opportunities moving forward. So thank you both. I believe we are breaking for lunch. There is a cafeteria. I don't know if, Daniel, you're going to take the mic and fill in additional details from what I've read.
Yes, so just as a reminder, lunch is available. The cafeteria is down in the basement. And so there are additional tables upstairs, so on this level in the west courtyard, we have a map right out on one of the tables out of the auditorium. And as a reminder, we will start the next session at 1:25. So please plan to be back probably around 1:20-ish. Thank you, everyone.
My name is Sylvain Coste. I'm a former NASA data officer for space bio and physical sciences. And to kick off the afternoon, we are going to continue the discussion on future direction and opportunities for AI and its application in radiation occupational health and safety. including public health. So in general, the occupational workers tend to receive low dose and low dose rate. And for this session, I would like you to prepare a question for us so that we can really have an interesting panel at the end, focusing on the two sets of AI tools you're going to hear about from our two speakers, and trying to think of it in the context of predicting risk for these occupational workers. How can we leverage this kind of study to health outcomes from radiation exposure at the low dose and low dose rates? So without further ado, we have two great speakers lined up to discuss ways that AI can be used to leverage epidemiology data, geospatial information, and personal data to help predict individuals, to help protect individuals. So to start off, in this session, we'll welcome first speaker Heidi Hansen. She's a senior scientist and group lead of biostatistics and biomedical informatics at Oak Ridge National Laboratory. And then she will be followed by Pierre-Antoine Gouraud, a university professor and hospital practitioner at the Faculty of Medicine at the University of Nantes. He's in charge of clinical data for the hospital over there. So Heidi, if you want to come over. Should work. Green button too.
Okay. All right. Thank you. And I'd like to thank the organizers for the opportunity to speak today. So I'm going to talk a little bit about computational approaches for assessing exposure, radiation exposure across the life course. And I'm going to start with my big idea. My big, wouldn't it be cool if I had all of the data that I wanted? And the data that I want is the data that can be used to follow an individual across the life course. I'm talking in utero until time of death. And the reason I want all of that data is because generally when we think about, I'm going to assess the exposure to an individual and the health outcome, we think about an exposure at a single point in time. Maybe if we're lucky, we think about an exposure over a 6-month period or a 1-year period. But that's really not what individuals are experiencing. And they may be exposed to factors that affect their risk from a single exposure later on in their life course. And, moderate those effects. So have some sort of exposure early on in their life course that moderates those effects later on in their life. And so I absolutely think that this is a reasonable, wouldn't it be cool if, sort of dream. And I'm going to talk you through some of the things that we're doing within my group and on my projects to try to get us closer to this overall vision. So a few years ago, this has been kind of my dream for quite a long time, but I worked with Sherry Barkin, who's a pediatrician, and we organized a group of folks that were really interested in putting together a blueprint for charting the life course or figuring out what needed to be done so that we could realize this goal. And there is a paper that talks about some of the ideas that we had at that period of time. But the thing that I would really like to talk about are these first two points. So when people talk about AI in healthcare, they really tend to focus on that outcome-driven perspective. So they're thinking about, I want AI that's really going to predict outcome X, Y, Z, and I'm going to develop an algorithm that predicts X, Y, Z. But what fewer people are thinking about right now is, how do I use AI for harmonizing data? How do I use AI to get to the data that I need to then be able to build predictive algorithms that are trustworthy and high fidelity? And so some of the things that I'm going to talk about are those, maybe to some people, a little bit more boring data sorts of questions, but where I think that AI can really get us to this point where we have enough data to develop fantastic predictive algorithms for precision medicine. So as everybody in this room knows, I'm sure, this is a really hard problem because electronic health data is heterogeneous. It's not collected in the same way across different institutions, and making it even more difficult is the siloed nature of the data. It is very difficult to get to that charting someone's trajectory across their entire life course because it's hard to link those data sets together. Now, I absolutely think it's possible, especially with some of the computational tools that are being developed now, and it's something that we should work toward in the 10-year horizon. But in order to be able to do that, we need to develop a set of tools that can allow us to do that and allow us to figure out how we can keep the compute at source or keep the processes standardized so that we're all doing the same thing to our data, and that we can be confident that when we harmonize that data together, that data is clean and devoid of as much noise as possible. The other thing that I'm going to walk through a little bit as well is not only the health aspect of this, but the geography aspect of this. So individuals in residential radon exposure is one good example of where individuals can be exposed to different levels of environmental toxins that can affect their later life health outcomes. So to start off with the health perspective here, why do I think this is possible in the 10-year sort of time frame? I lead a project called Mosaic, and this is a project that is a partnership between the Department of Energy and the National Cancer Institute. This project has been ongoing for about 9 years now. Over the past couple of years, we've been able to deploy our AI tools at all of the surveillance epidemiology and end results registries across the United States to help expedite time to reporting. So if you know what a pathology report looks like, it's going to be something of around 10,000 maybe words. It's unstructured data. And so when you're trying to extract information that you need to do downstream statistics, like give a report on the state of cancer in the US, there needs to be some way to take that unstructured data and put it into a tabular form so that we can then calculate statistics. So what our tools do is they automatically process those reports, put them into a tabular form or a common data model, and then those common data models can be used to report out on cancer, and they're used by many researchers downstream. So the tools that we've developed, AutoCode, right now, approximately 23 to 27% of all path reports that come into the SEER registries. This means no individual or registrar has to review those reports manually. They're automatically coded, and we're good to go. And the reason that we know this 23 to 27% number is because we've built in an abstention classifier into what we're doing, so that when we're not highly confident that those reports are correct, those reports are then sent to manual review, and the registrar gets to see information about what our algorithm's predicting to help assist them with the further coding of those records. And I'm happy to announce that as part of this project, or as part of these, because of these systems and other things that the SEER registries have been doing, the time to cancer reporting was decreased last year from 22 months to 14 months across the SEER registries. Again, this was just part of what they did in order to increase that time to report, but this gives me hope that my dreams might come true one day. The other thing that I wanted to show is the tools that we developed are not only applicable to the specific type of data that we were working with when we developed the tools. So as we develop our tools, we develop our tools with agility in mind and the ability to predict across many different record types. So a group of individuals at the VA picked up the tools that we developed. So one of our models, which is a hierarchical self-attention model, was used to train and predict a model using VA EHR data. Again, the ability to use these models across different institutions is very important if we want to get to a space where we're all extracting information from our healthcare records in the same way. So then now I can extract information from a centralized cancer registry quickly. I can extract it from the VA quickly, but how do I get to the space where I actually scale this into the national level? And so some of the things that we've been developing within our shop are federated processes for federated learning. And one of the key components here is the privacy aspect of this. So federated learning on its own is protective of your data, but it does not fully offer the privacy guarantees that we need when we're dealing with PHI data. So there has to be some sort of privacy mechanism imposed as you're doing the federated learning. And what a lot of people aren't talking about right now is this privacy accuracy trade-off that actually exists. So when I tried to train the models that I used to develop cancer predictions for the National Cancer Institute with enough privacy to guarantee that there will be no information leakage, I absolutely diminished my accuracy to a level that I'm not willing to accept. And we've tried many different things. We are currently working with some mathematicians to improve those, or to offer other solutions for privacy. But right now, when you're working with a complicated model, by turning on differential privacy, at least for the tests that we've seen, we get a considerable drop in accuracy. So a lot more research has to be done to be able to implement this at scale. So it's very exciting. We're still continuing to research it, but it's something that requires a lot more research to be able to be used in the real world. In addition to developing better privacy mechanisms and better ways to do federated learning, we also need to develop standard processing workflows that can be implemented at each one of the different silos. Again, in reality, we want to do all of the compute on silo A, silo B, silo D without having the data talk to each other. So we need portable, easy to use engineering workflows that allow us to pick up the messy EHR data, clean it, process it in the same standardized way, tokenize our data if we're using large language models, and then get it ready or AI ready so that we can then do our federated runs. So not only do we need to develop the privacy mechanisms that allow us to train the models with high accuracy and still protect privacy, but we do need to develop those workflows. We have a set of workflows that work quite well for our tasks, but there's still so much to be done in this space. And as we're developing these workflows, we're thinking about how do we develop them in a way that they can be applicable or used across many institutions. Now I'm going to pause here and I'm going to switch gears into the environmental space. So I've talked a lot about data harmonization in the environmental space, but now I'm going to talk about data harmonization in the environmental space. And this is another space, maybe people who aren't used to dealing with geospatial data sets don't realize how messy and difficult these data sets are to harmonize as well. So we've spent the past few years building something called a centralized health and environmental repository. And these are basic processes for data ingestion, processing the data, metadata storage, adding ontologies to the data, spatial indexing the data, so that we can harmonize data across many different exposure types to develop new models to predict something like indoor radon exposure or predict something like PM2.5 exposure or to tie other exposure metrics to cancer patients. So just to give you an example of what you can do once you start to build these workflows for data harmonization, again, my goal is get your data ready for downstream AI. So early on, when we started this project on predicting indoor radon exposure, we had multiple teams looking at the same problem, and each team was developing their own code to process the data, which led to not reproducible results. And so as we built this share protocol, what we did was we spatially indexed. We had one central location for all of the code. All data was processed in the exact same way. And then we spatially indexed the data so that it could be easily stackable for any problem that I wanted to have. So if I wanted to predict radon exposure, I could pull data off the shelf in these stackable hexes. And then I could build a model to predict indoor radon exposure. If I want to build a PM2.5 exposure model, I can pick up the data sets that I need, stack them together, and develop my model for PM2.5 exposure. So it's really reusable ways of storing and processing the data so that we can use them for many different applications. And why am I so interested in this? Because as part of our Mosaic project, we have been able to get access to LexisNexis residential history data for 11 different SEER registries. And this allows us to link environmental exposures across the life course, going back 25 years, to cancer patients. So then we can start to assess how indoor radon exposure throughout different periods of your life might affect how your treatment outcomes are, or how it might affect your treatment outcomes. And so we're linking all of these exposures to the cancer patients so that we can then start to pull everything together. So I'm going back to that picture at the first where I wanted to be able to combine all these different things. So I showed you 2 examples on the electronic healthcare side and on the environmental side of where we've done that. And now I'm going to talk about how we're combining all of this together so that we can then start to get to that vision that I have to be able to assess an individual's data across the life course. And we have a project called the Ehrlich Project, where we are putting all of these systems together to allow us to do this. Now, I talked a little bit about the downfalls of federated learning. And as one of the solutions, because we really wanted to be able to do this quick and not wait for a 10-year timeline when we would be able to have better privacy, we started to develop methods to do synthetic data generation. And that synthetic data generation is done while still protecting private information. So we've built a set of agentic workflows that extract PHI data, put the data into bins so that we can make sure that it's a second step where we're extracting the information without picking up information about health, and then develop synthetic data sets that are completely devoid of PHI. And in order to assess the privacy, we also do red teaming attacks against that data to make sure that we have purely private data. And then outside of that synthetic data generation, we're starting to marry the electronic health records with environmental exposures through a couple of different mechanisms. So more than just looking at an individual's residential history, we are building tools that allow us to simulate where an individual might move throughout their day so that we can assess the uncertainty in different types of exposures rather than just assigning an individual's exposure to indoor radon at their residential location. So here's my big goal, my big dream. I would like to be able to place a pulse on population health, and what is required to do this is to develop many different computational tools that can work interoperably that would allow us to really get the data that we need to understand human health. And I will thank this is not just me, I will thank all my Mosaic and Ehrlich team members, and I'll stop it there.
Thank you, Heidi. Pierre-Antoine, you're next. Green button for.
Thank you very much. It's a great honor to be here. So, as you can hear, I'm coming from France, and since my luggage was left over the Atlantic somewhere, it's actually the first time that I'm going to make a presentation without a proper shirt. My wife and my mom say, it's okay, it's United States. You can have a T-shirt. And I would like to take this opportunity to thank Sylvain, my fellow French compatriot, because I'm going to talk about a paper we published back in March 2023 about synthetic data. And we actually took pretty much the title of that paper, published in Nature Digital Medicine almost 2 years ago, talking about how do we generate synthetic data and how we kind of propose a new approach that led us to say no reason to risk re-identification in any kind of biomedical data analysis. So I think it's opening a new era, an era where we actually are going to all use anonymous, synthetic, and probably augmented data set to create the kind of things Heidi I was talking about just before. And this is actually interesting because it's probably coming from the big constraints we had in terms of regulation in Europe. So there's many things I'm not going to talk to you about because I'm running the biomedical data warehouse in our university hospital. We basically deal with about 200 projects every year, including pharmaceutical companies, which I have to disclose here, all run with contract with the university. So you may have heard that before. The United States invents and innovates. China imitates and replicates, while Europe regulates. It's a little bit offending. I totally agree with that. There's probably a little bit of truth, in particular for European. We love regulation. But actually, the goal of that talk is to show to you that EU regulation can actually foster innovation and probably helped us to go a little bit further in terms of innovation with data. And we've been doing that, replicating individual data. So I'll be happy to answer any question you have about GDPR, about the different recitals, where are all these principles. We've been thinking quite a lot. It has been in force in France since 2018. There's a lot about to say about what is personal data, what is pseudonymous data, what is really anonymous data. I think to make a long story short, it's basically what's very important to understand is that data usage is really at the center of the problem. And if you're responsible for the data, you're responsible to show the proof that your data is actually anonymous, or you're responsible for its qualification. That's actually a translation of a very important document for me as the leader of a 3 million patient biomedical data warehouse. We have more than 100 million text documents. And if we want to export, if I want to send Sylvain or Heidi some of these data, I actually have to prove this is totally anonymous. I have to prove that there's no way we can go back to individual data. And especially when you're a geneticist or when you're using imaging data, I say this is totally impossible. And actually, I'll tell you how we do that. But that's also in maybe more of a graphic way, a way for us to better realize in what time we are. What are we talking about? There's obviously the original data that we may think as the holy grail, where all the information is. That's actually probably not that true. This is the original data with the maximum re-identification risk to the left. And we can go to the right with actually original pseudonymized data, so basically with no direct way to identify a patient. And in the US, you're very good because you have a list of 19 PHI, so it's extremely convenient. And to the right, if you go to anonymous data, you have to prove that there's no possibility to re-identify a patient. And that's probably where the value is, because then our ability to use and reuse and use again the data is getting very interesting for any kind of purpose we have if we get the data with value. So synthetic data will get popular. They have basically 3 properties. They're, structurally speaking, they're exactly identical to the original data. They are relevant. They deliver the same kind of analysis that you may have with the original data without the risk. And neither an expert or trained algorithm are able to distinguish what would be data that are synthetic, that are simulated from the original data. And what is very interesting in the GDPR is to define that the data, to prove that the data is anonymous, we have to answer 3 questions. The first one is very difficult. Is it possible to single out an individual from the data? That is the first criteria. The second one is whether we can link records together. And the third one is actually, can we deduce something about an individual? Yes, maybe, no, etc. How much? This is what it's about. And then all the traditional techniques like differential privacy, inference, membership attack, and etc. really are not like a full guarantee to answer these questions. So we actually had to, in partnership with the company, we actually developed that method that we call the avatar method. And I keep asking myself how we had that idea. That's actually one of the figure from the paper. What's very original there is that we do a model for each and every one of the observation in the data set. So if your data set is a table, you're going to do a model for each of the rows in the table. And the way it works is that you're going to start with one row, let's say Sylvain, and you're going to find in the data set, you're going to define mathematically a number of neighbor rows, let's say 10 or 12. And from these 12 neighbors, these 12 rows that are very much like Sylvain, the one you target, you'll have a local model, and within that local model, where the original data actually is not, just probably close to that, you're going to do a single-time simulation. It's a little bit counterintuitive because you do a kind of a private local model that is used only once, and the very link you're trying to destroy, you're going to use it just to measure how many other simulations are actually closer from the original observation than the one you just sampled. And you can do that again and again, and you do that for each and every one of the rows if the original data is a table. That works very well. I'm going to give you a couple of simple examples that we use that in publication. The first application is when colleagues want to do open science, open data. I think that's very important. That's actually a way to release a copy of the data set with no risk of re-identification. This was an example where actually was very important for one of my colleagues to enter the reviewers. If we were to do a demo, and I'll be happy to do that today or tomorrow if you want, we have a web version of the software that is running on-prem within the hospital. So we basically start from an Excel spreadsheet. And the game is to generate the exact same spreadsheet, the exact same table, same number of variables, same type of variables, same types of rows, by selecting this, the parameters, the hyperparameters that will be very important to see what kind of balance we can get between accuracy and privacy. That is actually the very first example, almost 5 years ago, that we used. We were to publish a great paper about risk factor for rupture in intracranial aneurysm, and my colleagues were very keen on doing all in open sciences, all the code, and they came to me and say, well, how can we publish the pseudonymous data? Well, saying we can't do that. These are private health data, so we can't just let them out free. And so we use the method here to generate simulation for each of the observation, about 2,300 of them. And you can see in this projection that we basically have the same projection, the exact same properties, and that's what we demonstrated up to the prediction models. So that's is a very significant advance for the dataset. And now we are also using that maybe in a much more extreme way. We're using that to develop a clinical decision support system in multiple sclerosis. So we heard that this morning. There's a lot of AI tool, but there's also AI tool that basically start with data visualization. And what we do in this project is actually quite simple. We use the data for one patient, and we go into the reference database, and we're going to pull up subgroups of patients that have similar characteristics and say, well, this is how similar patients are doing within the next 2 years on treatment A and on treatment B. To do that, we're actually very lucky that we convince very large observational studies to share the data with us. And we also convince pharmaceutical companies, namely Biogen and Merck, to share with us their clinical trial data in multiple sclerosis. There was actually two arguments, and these all relate to data governance. We said, okay, in this project, our ambition will be to use a federated learning or a distributed database infrastructure. And many times you will hear that this is for privacy and say, no, this is not a matter of privacy. This is a matter of control. And it's actually fair that you have produced this clinical trial data. We will let the data in your center, and we'll ask computation remotely so that you can monitor what we're doing with the data under your responsibility. That's control. And the other arguments say, you know what, maybe it's not right to ask from you that we use the original data. We can probably use high or very high fidelity simulation like the avatar. And that's actually what we did here. This is a typical example of how we're using the tool. We're basically pulling data, and here we're comparing the real data to the virtual patients that we would get through the method. So our neurologists were very satisfied, empirically speaking, when they tried the tool and say, okay, we do get the same results, no matter we use the original data or we use the synthetic one. And together with a great PhD student of mine, we actually said, well, this is not enough that they're happy. We have to demonstrate that actually our synthetic data perform exactly well, no matter how you're going to use the tool, no matter what subgroup of population you're selecting. So each of the blue dots that you can see here is actually a subgroup of a database with 25,000 patients and data coming from both observational studies and clinical trial. And basically we compared the result on the main outcomes coming from the synthetic data sets and the original. And very soon, and that's something we've seen now in many projects using synthetic data, say, well, it's great, we got rid of the privacy problem, but we have the ability to augment the data. So we actually generate not 1, but 10 synthetic observations for each of the samples. We also we can recalibrate that. And at the end of the day, we really think that synthetic data is actually better than real data because they're ready for prime time. They've been calibrated, they've been matured for the data usage that we are using, and in particular, one that is very extreme in here. So there's multiple ways actually this anonymous synthetic health data could become. Obviously from the anonymization point of view, to rule out the way we're going to do export from biomedical data warehouse. Maybe we can do a different export for each of the use cases. Very important for data sharing in general, if you want to show a sample internally, externally, if you want to better understand what private partner want to do, well, you can give them a sandbox with synthetic data and you get to understand what they want to do with it. It's obviously very useful for teaching, and I want my student to have real challenging data sets to work on. It's not very common, but usually software are tested on real data. This is bad. It's like on patients. We never do first-time surgery on real patients. That should be the same for software. We can do also archives of data. You don't need to delete everything. Maybe you can learn from the past. And as I've just shown to you, I think what is really important now is that we can actually augment the data, explore rare cases, and that's actually better for training AI system, up to the point that these are used as a reference for decision support system, like the one I've shown you in multiple sclerosis. So because we had that pressure, that constraint from the GDPR, I'm truly convinced that EU regulation actually can foster worldwide innovation that indeed replicates individual data. It works for different type of data, images, signal, like ECG, GPS signal, genetics, and text. These criteria are very extreme, but they were also very challenging, and they are now becoming central in our AI regulation because they're also questioning how the models, not only the data sets, are actually private. And at the end, I really think it's a matter of ethics. There's actually no reason to risk re-identification if the patient is not using or the caregiver is actually not directly benefiting from the analysis that we are conducting. And with that, I'd like to thank all my colleagues from the hospital unit that we call the data clinic, and my research teams in multiple sclerosis and transplantation, with whom we are running this project. And thank you for your attention. I'll be very happy to answer your questions.
Well, thank you very much. It was very inspiring, and I see there's a few questions already. Please, if you have any thought, put it down so we can ask the speakers. I'm going to start with questions that I prepared so that we can let people warm up. And so the first question is going to be on data integration and readiness. And it's for both of you, so whoever wants to take it first. So your method seems to be pretty advanced already. And can you comment specifically on how your tools address data silos to transform diverse data sources into format ready for AI? So AI readiness, basically.
Yeah, I'll go ahead and take that first. So most of the solutions that we've built so far with unstructured text. And so there is a lot of, even in unstructured text, there's a lot of heterogeneity between the different siloed data sets. And we're lucky enough to be able to deal with real world data that is naturally siloed. So when we take the data from the National Cancer Registries, we are dealing with 6 to 7 states, depending on what we're doing at a certain point in time. And that data is collected differently at every single site. And there's some similarities, but some differences. So we've been building, number one, the data engineering tools to be able to transfer the data and store it in similar sorts of structures so that when we get to the step of taking it and pre-processing it, that we can have similar structures. So there is a bit of a kind of rule-based code system that takes data as it sits, puts it into a harmonized structure, and then we can pull that data from that harmonized structure and process it in the same way. Everything that we do, we try to do at an overall level. So we're not doing specific rules for the specific institutions because we want our tools to be very flexible. So we try to develop a set of rules that can be applied across all the different data sets. We harmonize the data as much as we can at that period in time. And then some of what we're doing, we're hoping some of the heterogeneity gets worked out in the model training as well. We're working, right now we're stepping into the structured side of things. I've worked in the EHR structured data for a very long time. I know that that's a very hard problem. The unstructured is actually easier. So the hope here is that we can build models that take data from a single institution, get it to a common data model, and then we can go ahead and train models at that point in time. But that is something that we're just diving into right now.
It's probably a little bit of a different perspective from us because the goal of the hospital unit called the data clinic is entirely dedicated to secondary uses of data from care. So I think retrospectively, I think we were lucky to have a very much of a bottom-up approach. We take the questions from colleagues, say, we have the data, we don't have, or what can we do with these data? So I think we solve the issue step by step from the bottom and say, okay, now we've done that for ophthalmology. Okay, how can we make that a regular purpose? And that has been like that for almost 10 years now.
So just to continue on this topic, basically this data harmonization is the essential ingredient for both of your tools to be democratized. And I think this is a challenge, right? So you give an example where you have maybe 7 or 8 different states you're working with, but how scalable this approach is. I mean, when you start thinking about the national questions, do you think you're prime time ready? Something for the French, how do you go from a university hospital to the entire country? Maybe you want to start.
So we also have a structure that is organizing the same kind of initiatives in each of the university hospitals, and we have also a regional responsibility on the data. So that has been very helpful for us to be able to coordinate how we do. And then the question is really about how you get the data to be exchanged. That's how we got interested in anonymous synthetic data, because the best way is actually to show the data. If I'm starting to talk to ideas, I can send her some of the data that I have by email, say, hey, look, this is the type of problem we're facing. And because care is organized differently from one city to the next, this is actually a great substrate to have a discussion about how we can converge into comparable data.
I would say, so no, we're not ready to scale up as optimistic as I am. What I've also noticed as we've brought on new data sets is even if they're very similar in nature, there are gotchas as you start to process the data, characters that you didn't expect to be in there. And so there's a fair amount of prepping as you're scaling, making sure that your systems are working correctly as you're scaling. And I don't think we'll get past that point, but maybe, right? So, I think it's possible, but it will take work to get there.
So I'm going to try, go ahead, Pierre-Antoine.
I'm looking at the
Oh,
question,
okay.
so I'm happy to take them. Talking
you were
about
gonna-
outliers, because that's a very good question.
So I'll take this. I'm taking this one first because I think data heterogeneity is another big topic, and you both touched on it. But there's also a question on multimodality, and the question is, let me read it. Does the synthetic data generated preserve the correlation present between different features? And the next question is, can the correlation in multimodal data set be preserved too? So
Yes.
No. So I'm going to disagree with you a bit, right? So maybe this is where I'm not an optimist. And would I like to get there? Absolutely. But I think as we're developing synthetic data sets, if you had the best synthetic data set, you would be able to use that data set for many different applications, right? I would even be able to use that data set for hypothesis generation. I don't think we're there yet in synthetic data because of that question about making sure that you're protecting all the correlation structure. And I think as you move into multimodality, it gets even harder, right? It's hard enough to do, even with one modality. Multimodality, I think it's exceptionally difficult. Do I think that we can maintain the correlation structure for a single application? Yes. So if I train my data, if I want it to for this specific application, I agree with you. But if I'm talking about that really big synthetic data set that's just as good as a human population data set, no.
So I think what we realized, so we really built this private model, this local model for the sake of privacy, just to be able to deliver individual metrics, saying ID between you and your avatar, there is others, etc. And what we realize very often, we have extremely heterogeneous population. Most of the time when my colleagues come with data set, they have actually 3, 4, 5 different subpopulation. And it doesn't matter for that kind of method because they will automatically use the local model actually to do their model automatically in these subgroups. So it's actually extremely robust and extremely useful for hypothesis generation. And the same for multimodality. So you may use the synthetic data generation modality by modality. That's certainly one way to do it. And then you control your reconnection between the data set. That's how you build data sets that are extremely realistic. And I would say most of the time it actually works too well. I would say, do I really need to expose that many data to create a collaboration, develop a new software, or generate hypotheses for new research? So, and here again, that's really what types of data usage am I able to accept? Do I want to lose control? Or do I just want to show a little bit of it just to give it the taste of it?
Very interesting, and it makes me think of this, you really look, the multimodal takes you to multidimensional, and I think something we heard this morning is really these hidden features that AI seems to be able to capture that we don't necessarily see, right? And so I think the question was really focused on, are we going to be able to capture these hidden features that we don't even know ourselves? And I think the way I think of that, and that's why I'm a big proponent of synthetic data set myself, is that even if we're not capturing it, the best way to know if we don't capture it is to make this data democratized and accessible to everyone to play with and see if indeed we can, we lose some features that we discover through the access to the real data. So I think as we play with these different modalities, we'll be able to answer these questions. But obviously we have some difference of opinion here. So, okay, I'm going to switch to kind of the topic of this session, which was dose reduction. Well, the dose question in the concept of radiation exposure. So the question is, how does your work specifically support efforts to reduce radiation dose to individuals, particularly considering targeted population at higher risk due to genetics, occupational history, or previous exposure? So I really want to emphasize those two things, genetic, and also what happened to you in the past, and that could be your epigenetic status, but it could also be simply how you feel today, and you may not respond to the same stress depending on where you are at the moment of the exposure. So I wonder how you fold these very complex features in your approach. And maybe Heidi, you want to start since you dealt with the environmental data?
We do have a project where we have access to data across the life course for individuals with lung cancer.
in the state of Utah. And so because we have access to information basically from birth to death, we have information on their genetics, on their transcriptomics of their tumor, we can go ahead and look at, okay, I want to see where this individual has lived throughout their life course. I want to see what their potential indoor radon exposure was from birth to death. And then I'm going to assess how that affects different types of omic signatures that I'm seeing, or how those two things actually can be combined together to see how it affects cancer outcomes. Maybe it leads to some sort of different phenotype if you've had indoor radiation exposure and occupational exposure to radiation. And I'm going to try to parse those things out. So that's research that's ongoing right now. I don't have an answer for you, but I can tell you that once you're able to start to combine all of these different data sources together, you're able to get a much more holistic picture of what's happening to the patient at the time of treatment and what happens to the patient after that treatment has been initiated.
Yeah, on that, I think we totally agree. And yet it's very sensitive data. So we definitely want to make this data more accessible and enable anyone to do comparison, how the patient are going to compare to subgroups. And that's why we made the parallel example with multiple sclerosis, I think.
Yeah, and I would absolutely agree with that. This is a place where, you know, I can do the analysis, but that data is very locked up because there is so much information in it. But then wouldn't it be cool if everybody could start to interrogate this data? I'm one researcher, I'm only going to have time to ask one question, two questions, right? Let's open this up to everybody so that we can really start to have innovative discoveries in ways that we haven't before.
So in this context, you talked about federated learning, but it looks like the only solution to really democratize the accesses would you agree, synthetic data sets or anonymous data would be sufficient? What strategy would you be?
So I think if all things were perfect, I would combine the strategies. So I think the really interesting things are coming from combining synthetic data generation and federated learning. And part of why I'm saying that is every institution is going to have different sorts of compute power. Not everybody's going to be able to participate in a federated learning run. Federated learning, if privacy worked well, would be better, I think, because you wouldn't have to worry about, am I protecting all of the data in the ways that I could? And I'm going to say kind of on that because I still have to add noise while I'm doing federated learning, so there's an issue there. But it's the combination of both of those that I think is really innovative and really going to lead us to cool places in the future.
Yeah, I think again, we totally agree. Let's imagine, and you don't have to believe me, that we have perfect anonymous synthetic data. You still may want to control who is doing what with the data from your institution, and that's where federated learning is very important.
Actually, on the federated learning, I see there's a question, and I'll read it to you. I think you may have addressed some of that, but what are some realistic privacy concerns with federated learning? Are you most concerned about membership attack, malicious participant, adversarial attacks? What are some realistic scenarios for such attacks?
Yeah, so the membership inference attacks are kind of your baseline easygoing attack, and they're even more sophisticated attacks. So yes, we're worried about those types of attacks. If you actually, there are a couple of repositories online where you can reconstruct data from the gradients that you're passing back and forth in a federated learning run. And it's a shockingly small amount of code that gets you to that recreation. So without any privacy at all, even though you're only sharing gradients back and forth, your data can be reconstructed downstream. Adding privacy on top of that reduces the accuracy like I talked about. So that's an issue. How can we maintain that privacy and then also keep accuracy? And then there's the question of, if my data is really so good, do I start to get into problems where I have what's called basically a mosaic attack, where one feature by itself is not identifiable, two features by themselves, and a patient is not, they're not identifiable. Three features, I can start to triangulate who that person is. Four features, including location, I really know who that person is. So even though I'm looking at a feature one at a time, they're not identifiable. But we're talking about combining multimodal data sets. And once I start to do that, I can start to triangulate, and that becomes an issue as well.
I think that's where GDPR is very smart. They force us to deliver proof and to ask the question in advance. So definitely federated learning is not really an answer for privacy. And it's great for control and it's totally legit.
So I don't know if you see my screen, but that was my next question about GDPR and basically given that GDPR and similar regulations can complicate data sharing, how do regulatory constraints impact the development and the deployment of your AI models? Maybe we can start with you, Pierre.
Well, it's clearly a constraint because we feel like, but I think I'm also full of hope because we do have technological solutions. You know, many of our colleagues, they think we have to centralize all the data. This is very Napoleonian in a way of thinking. It's probably actually generating a risk to centralize all the data. So we can use distributed database, and it's and as Heidi said, it's very important for computation power as well. First, I really never thought I was going to use synthetic data that much. It's kind of deep fake or kind of deep true, but that are not really true, etc. And you know, when you work with physicians, they're used to manipulate private, ultra-private data all the time. This is very important to deliver care to an individual. When you analyze population of patients, there's actually no reason to go into that privacy. And we hear that since the Hippocrates oath, actually.
Okay, so I have another question still on synthetic data. So when generating synthetic data, how do you address the lack of outliers or edge cases? Or if you are adding in edge cases, what are the limits of the parameters of such cases?
So that's a very good question because that's actually the most difficult cases. Somebody who stands out of the crowd is somebody that you are going to re-identify. So the way it works with the local model is that you will get them back into the pack. So they won't be as heterogeneous as outliers out they are. And these ones, you can't really get rid of. You have to make a decision about whether you want to release data about a single outlier. Now, if the outliers are a subgroup, there are like a little bit of many. There are actually secondary effect or subpopulation, and these become to be very interesting because, and again, the local model will be actually a local model of outliers, and you can generate actually more than the few you had in your database. So, and that will help AI to be better trained on detecting outliers, a little bit like gradient boosting techniques or stuff like that. So that's why now we actually, at minimum, generate 10 times more synthetic data that we had as original data.
So maybe as a follow-up, like maybe what comes to mind in this question is outliers only are outliers when you have a small numbers, but let's say you scale things up. So right now you're working in one hospital, but do you think this could be, you know, a person who's isolated now is part of a subgroup, and so suddenly you can still deploy this kind of technique? So how do you see, you know, scaling things up, helping this question, or yeah? I wasn't clear.
So, I'm not sure I got the question right.
Basically, when you're talking about a small group, you will have outliers because of the if you have a small n, as you increase your group from your real data, you start having this going away.
Yeah, the outliers are not really outliers anymore.
Right.
But it works also very well with small data set. I was very surprised with that as well. But as Heidi said, as soon as you start combining or adding some variables, then you have to redefine all the metrics, and that's really what GDPR asks us from the regulatory point of view.
And I'll add to that just to say, I mean, this is where I think that there are some problems with the synthetic data generation. So if my purpose is to develop a predictive model, maybe it's okay that I overinflate the number of the smaller minority classes to protect privacy, because that's going to give me class balance anyways, and maybe my predictive model works better. But if I'm doing something where I'm trying to assess the effects in a population, and I'm trying to maintain what my population distribution looks like, overinflating those minority classes may lead to a problem in what I'm trying to estimate on the other side. So when you're really thinking about it as is this model or is this data, can I use it for anything? Does it have high utility for any question? That's where I start to question the synthetic data.
There's actually probably at least 3 different point of view on synthetic data. As a leader of the biomedical data warehouse, I care about privacy because I don't want to have problem with the patients, and that's totally fine. If I want to share data, to have other people do things, I will really care about the data set being representative of the population that I have, because I have no idea what question they're going to ask. That's exactly what Heidi said. But as much as I know exactly what I'm going to use the data set for, let's say training a predictive algorithm, then I'll try to rebalance the classes. I'm probably going to, try to correct biases and particular gender biases and etc. So again, the data usage is very central, and that's a key message from the GDPR regulation. What am I going to do with the data?
Right, and I think there was a follow-up question on that first question, which was, what are examples when synthetic data are not appropriate? And I think you already gave us one example. Do you have any other example in mind where synthetic data set would not be the right approach?
So I can give mine, but it may differ from your perspective. I really don't think we're ready to use synthetic data for hypothesis generation yet. If I knew I was protecting all of that correlation structure that I needed to be able to generate hypotheses, then would I already know that information? And my answer would be, yeah, I would have to know that in order to make sure I was protecting that information. So I personally don't think synthetic data should be used for hypothesis generation. But don't get me wrong, I am a huge proponent of synthetic data. I think it can lead us to many different amazing innovations. I just think it's not appropriate for all questions.
Yeah, in many situations, I like to remember that is either synthetic data or nothing. So in this situation, it's hard to say, whether it's bad or good or bad, and etc. And you can always try it, and then it will be time to go back to the sensitive locked data set and see if we were wrong or if the analysis was not performed the right way. You expose both the data and the way to analyze them, and that I really think it's good for everyone. And that's true that if the data set is very noisy, and that's what we have many times in omics in general, well, any kind of method, synthetic data generation methods, will probably take noise or random fluctuation they will take that as signal and they will reproduce that.
So another question is on time dependence and the individual predictions at the patient level or at any individual. So one thing that both of your talk makes me wonder is, and you did talk a bit about this in your projection of MS disease, but how do you fold in the time dependence? And Heidi, I'll start with you because the mapping idea is great. I love it. But having a population being exposed to radon doesn't tell you that the people living there were the people living. You have the problem of taking into account the time it takes to develop cancer, which is kind of like the big endpoint for us. On the radiation side, cancer is the one thing that we track. So it takes 10 to 20 years to develop. So how do you fold in this big time scale in such tools?
Oh, I have my big smile. Time is one of my favorite talking points. So this is a great question. It takes a lot of work and it's hard to do. And there's a lot of, you have to be very careful about the methods that you're using because many methods in the ML AI space aren't quite ready for time. But there are ways to do it in more traditional senses. And for the question that you were talking about in terms of how do I incorporate time in residential location, this is why the residential history data or knowing where someone lives across their life course becomes very important. And I'll give you a little snippet to my talk tomorrow. I'm going to talk a little bit about ways that we can quantify the uncertainty related to those exposure estimates, because right now what we do is we take an individual's residential location. I ignore the fact that they might not be in the basement all of the time. I ignore the fact that they're probably not home 24 hours a day. But I can start to use something like agent-based modeling to simulate what an individual's normal trajectory would be throughout a week, and then incorporate the uncertainty in my estimates or start to think about how there's uncertainty in my estimates that way. So I really do think it's something that can be done. It's a very interesting problem to me, and that's just one example of how I would answer that question.
I totally agree. I think it's even, as you said, it's actually a matter of data and how you really look at your data. And this is actually the key, no matter what kind of algorithm you're using.
Yeah, and then the other thing that that's really critical in this time projection is who you're dealing with. So going back to the genetic question, I say genetic here, where I think some people will argue that not everything is genetic driven. There's also other features, but when you add this feature on top of the time, it becomes pretty daunting to be predictive. So it's a big exercise here. Let's see. I've got one question. Okay, so this one is, and I think I still have about 13 minutes, is that correct? Yeah, 10, okay, 10 minutes. Could you pull synthetic data set to increase statistical power for epidemiologic analysis across several populations? Would synthetic data behave as well in this scenario?
Absolutely. So there's actually a great paper from a colleague from Toronto, Raled Eleman. He did something very smart and very simple. He took a clinical trial in cancer. He stopped halfway from recruiting and say, well, let's now use a synthetic data generation method and see if we can predict the outcome of the clinical trial. And they're comparing multiple methods. It works very well. And intuitively speaking, it's actually, if you've discovered the overall structure of a data set, then it's just a matter of quantity, how much you augment the data set, and that's really what the methods are done for. And I think he even tried basically sampling with replacement, which should be the most naive way to generate synthetic data, and that's actually worked pretty well. So that applies very well for clinical trial data, where again, the question is very clear. There's one question: is treatment A doing better than treatment B on average? And that worked very well. And that's actually a way to expose this data and to try different algorithms and challenge the data sets.
Yeah, and I agree. We've tried things like sampling with replacement, doesn't work as well, right? Synthetic data is even better than sampling with replacement to solve some of these issues. But then even better, if we're thinking about pulling data across multiple populations, it's the combination of synthetic data and federated learning. We have a postdoc, Jai Wing, who's working on some of this for us right now, where basically what we see is if you just train a model with synthetic data from different populations, you get okay results, but it's when you start to fold in the real data, when you can use real data, synthetic data, when you need synthetic data, and that's where you start to see really promising results from in these spaces where you're trying to pull data from multiple places to get more power.
So now back to the concept of radiation risk and cancer. I'm a big proponent of mechanistic model. I spent a lot of time doing this. So one thing that's a bit, right now, it seems that people are either doing AI or they're doing mechanistic deterministic model or stochastic model. And I'd like to hear from both of you how you see the integration of mechanistic model where we have a clear understanding of processes, biological processes, and how we could really leverage them, because right now we're asking so much from the AI when there's so much we already know, and folding it in seems to be a logical thing to do, but it's actually quite difficult to merge those two techniques together. So I'd like to hear your thoughts on this.
Well, I think first, I think we agreed on saying it's not so much about the algorithm, it's about the data. So rather than being in the hype of let's try the newest model or AI algorithm, I think we're both a big believer in data, and that's where we're putting our efforts. It's on making data available from our hospital, from our research lab, from the environment, and that's probably half of the answer to your question. Now, I'll be very short, and I'm sure Heidi will probably give more insightful examples, but it's great to count on the computation power of AI algorithm. And again, no matter what synthetic data generation method you're using, it's kind of unfair not to give them the knowledge that we have on mechanism, and even saying that there may be other mechanism. But I think we have to find a way to implement this knowledge into the algorithms.
Yeah, and I think if it's not clear, I'm not a fan of one-size-fits-all sort of solutions, but a fan of multiple types, triangulating with different models, using different types of solutions for the right sort of problem. So I think that you absolutely should be combining different types of models, and I think that you can use mechanistic models to help you identify where there should be guardrails on some of what we're doing with AI, or thinking through how do we make sure that we really are maintaining the biological signal in our other types of models or synthetic data generation. And I think that you cannot do that alone. You need the other types of models to be integrated with them. So I don't know the exact answer, but I think that you absolutely want to start combining these models together so that you can keep everything that you're doing closer to truth. And I think if you're not, you're going to start to miss things that you shouldn't.
And I would add that another thing that we start seeing in the field is the usage of mechanistic model to generate data that are then used for training. And that's kind of a way to harmonize the entire structure. And that's going to be my last question. I handled all the questions from the public. Thank you. But the last question is going to be about data standardization, because, you know, I think that I keep talking about scaling things up, because I think the solution you presented are really exciting, but the bottleneck is going to be the adoption. And you mentioned that people are doing things differently. So, and we heard this morning too, that data standardization is a big deal for everyone. So I'm wondering if you believe into some kind of strong consortium that could be put in place. Is it a dream, or is it just unpractical and we will continue having these silos? I mean, where do you see the field going in terms of the ability to standardize data so that all your AI sees similar type of data, so it's very quick to deploy and test?
I absolutely think we should build something like that, a consortium, but not a consortium to develop all the rules that we may put in place for a rule-based sort of system, but a consortium to start to think about how we can identify technological solutions that will allow us to standardize and harmonize the data. I've been in too many meetings where I guess I'll just say arguing or discussing how I standardize feature 1, feature 2, feature 3, and those meetings can take a year and get you not very far in that year. So I think we should change the conversation. We shouldn't be talking about here are the specific rules that we need to apply to every single feature. The conversation should be what kind of technological solutions will allow us to get to common data models faster and be easy to use and very flexible, right? Because even if we all get in the same room, I want one standard, my collaborator wants another standard. So there needs to be that flexibility in mind as well.
Yeah, I totally agree. I think it's great to have the ambition of having standards, but we have to remember that they are a mean to an end. And that's by doing projects, by being grounded into practical examples that are useful for patients and for caregivers, that we will succeed.
Yeah. I think that closes this session. Thank you very much. Thank you. We're on time, right?
Yes, and so thank you, everyone. We're going to go on a break. Please be back by 2:50 for the next session.
So we'll start focus on the medical image as examples, but I think that's the ideas can be expanded to other data. And we'll talk about the data qualities and data collections, curation, data management to support the AI development.
Let's join me to welcoming our first speaker and fellow panel member, Carol Chung, tenured professor in radiation oncology and diagnostic imaging at the University of Texas MD Anderson Cancer Center. Caroline.
Thank you. So it's a pleasure to kick off this session on data readiness. And I'm going to talk about data for AI and the critical role of metadata and context as far as data readiness goes. I think many of us think about data readiness being perfectly cleaned data, and that may not necessarily be the case as long as you actually consider the context of how you're actually wanting to use the data. So I'm going to start with what we mean by the context of that data and why it's so critical. This quote from Eric Topol from 2018 was that there is a lack of awareness of the so-called AI chasm that is the gulf between developing a scientifically sound algorithm that you'll see that I've labeled as sort of the AI publication on one side of this bridge and bridging it across to real-world implementation. And I would argue that context is that critical bridge. to actually realize that impact. And one of the things is that when you think about data that you're using to train AI models, most of us know, if we've built an AI model, that you've actually done a ton of cleaning, curation, fixing, et cetera, of that data. And yet that is the gap. That's the gap in this bridge of allowing that model to successfully be deployed in the real world. So the more work you need to do with the data as you actually feed it in for training is probably the amount of gap in performance that you're going to see afterwards. And so how do we actually start to bridge those two worlds? And one of the things is considering what you're actually working on. Are you actually building a widget because you have the data? Many people start with the bubble at the top of what data is available, and then they say, yay, I have data, and they start building a model of something that they can do with that data. But is that really going to lead to the clinical adoption, because it's a useful question, or is it going to be something that you can actually deploy? Because if you've started with a collection of cleaned data, that data may or may not be readily available in the real world. And so even though you've got this tranche of data from maybe a clinical collaborator, and they've done a lot of work to bring it to you, how much work did they do to actually gather that up? How common is that data? And is that tool really widely deployable? So I would argue that we need to start with what is the actual problem we're trying to solve, and do we actually, from there, look at the data and say, is the data available to solve the problem that we're actually trying to solve? And the reason why if starting there is helpful is because then you can actually bridge across and say, if the left of this circle is in terms of considerations of your deployment, you have to think about the model training. And so what problem is it that you're trying to solve? And that's going to influence the model training and validation and the type of data that you need. And it'll actually help guide what data do you have. And it may stop you from starting projects that aren't actually going to go anywhere. Because remember, everything that you embark on means that you're not doing something else. The second piece is around the stakeholder readiness and whether the team is ready to employ that model. And that's considering how are you actually going to implement this model if you actually build it and that you're successful in your validation phase and you've got a publication. Finally, understanding all of the outputs by the stakeholders. We've started to talk about that human-AI interface and that model output with uncertainty, and how do we communicate that in a way that people will pause and not become complacent or be so skeptical that they're not willing to believe the model at all and continue to do what they're going to do. And finally, in the middle there at the bottom is that full lifecycle management and ML ops. And imaging is a really promising beacon. And so although we're talking about AI data readiness for AI, we thought we would actually take the theme of imaging in terms of medical applications as well as in radiation application. We're talking about patients at large. And in cancer care, certainly, imaging has become a beacon. As an oncologist, when I see a patient and I treat brain tumors, I want to see the MRI to know what is going on, because we can do the exam, but the MRI gives us additional information that's so important to actually making those clinical decisions. And there's been a lot of multimodal models, we started to talk about multimodal today, that actually incorporate imaging data into these models as one of the beacons that actually help guide the model predictions overall. And so whether the tumor is growing or shrinking is one piece, can we actually interrogate that image even further to actually get biological information, physiological information is that next piece. And how do we do this in a way that we actually gain confidence? And so when we think about that broad range of data domains around the multimodal biomedical imaging, whether it's looking at the omics and metabolites, whether you're looking at the actual radiological scans, whether you're looking at data perhaps from your smartwatches that's gathering all sorts of data at a frequency of the ICU, as mentioned by David Rue this morning. How do we actually integrate all these pieces? And are we actually, when we actually build these sorts of multimodal models, are we actually considering the time scale and the timing of the biopsy and the omics data relative to when the scans were done? And if those time scales are so separated in time, are you actually right in making this association between the imaging findings and that pathology? When you take that specimen, do you know exactly where in that image that specimen was taken from? Has this been done under image guidance? And if not, you're making a big assumption that somewhere in that 5-centimeter tumor, you've got this particular omics profile. And so thinking about that spatial and temporal separation in your analyses as you build out these multimodal models are important. And so this all means, when you think about that spatial and temporal nature, this all means bringing data into context. When you take that specimen and you look at the pathology and you look at the omics profile, you have to put that into context. When was it taken? Where exactly was it taken from? How does it correlate to the imaging? How does it correlate to the symptoms that were reported? In this publication that I published back in 2021 in Cancer Research, really reports out that data in context and the importance of metadata being the glue that will bring together those observations in context, meaning that exactly those things, the timing, the space, how was it technically done, what were the technical differences in terms of how that data was gathered. Looking at that quality also in context. So as I said, as I started out, I said we don't always need perfect, pristine data. It may depend on the kinds of questions you're asking. And so if you're doing exploratory work and you're looking for general patterns, perhaps a bit of noise is not so bad and you can learn to ignore it and you're looking for bigger patterns. If you're trying to predict a very specific prediction of for a particular patient in a clinical context, perhaps you want to make sure that the data going in as you're feeding it into that model is of a very high quality because you don't want a lot of uncertainty in that output. We don't necessarily think about it in that way. And in fact, it's often the opposite. When we're trying to build a model, we're looking for patterns, we're also often taking a lot of time to clean that data. And then we deploy and we're taking noisy data and we're feeding it into a model and making clinical decisions. So we're almost reversing that principle. Thinking about where that data came from, and this we'll be hearing about in the later sessions around centralized data collections and how we can actually collaborate and what are the limitations versus strengths versus a federated system where you keep the data in context, and what kinds of provenance do we need to track along to make sure that we build confidence and trust that the data is reliable, that there were no assumptions inserted as you cleaned that data, and that no transformations were made without you being aware so that you're not making associations. There was a great example of a data set where people had imputed data into a data set that was centralized and published it out, and there was no provenance that was so apparent that people knew that there was imputed data in that data set, and you had hundreds of other researchers using imputed data without actually realizing it wasn't real data. So going back to that synthetic data piece, yes, synthetic data may serve its purpose, but yes, we need to document that some of this data is synthetic when it is. And finally, the only way you can actually have this work is if we have an integrated data governance system that considers that metadata and flows that metadata through the system. And part of the reason why that context is so important is because at the end of the day, the data in the EHR, we celebrate this explosion of data, but this paper in JAMA really highlights that there's a lot of data that's actually generated in the EHR that are copy and paste. There's a ton of duplicate information. Some of that duplicate information are actually errors that get propagated through. Now, does that mean the clinician necessarily is making decisions on these errors? Probably not, because as I said in pink on top, is that the relevant information that leads to the actual clinical decision may or may not actually be documented in the EHR. The physician may be clicking around and going, this just doesn't make sense. The story doesn't make sense. They pick up their phone, talk to a colleague, gets the real story, talks to the family, clarifies the story, makes a decision, and the decision and the treatment is documented in the EHR. Now, you come along as a data scientist and you're looking at all the data in the EHR and you're seeing these series of events that are documented and the treatment, and now you're making associations between this series of events that have taken place and the treatment, but you're missing the big black box of the conversations that have happened that may or may not have made it into the EHR. So it's a bit of a words of warning that what you see is not necessarily everything that you need to get to actually build an effective model. And some of the technology that's emerging, such as ambient listing, et cetera, may start to fill in some of those gaps, but it may not fill in all of those gaps. Now, thinking about other pieces of context and metadata that may be missing, in terms of the impact of data quality, and we're looking at standard of care imaging, standard of care, although it has the word standard, does not necessarily mean the imaging is actually standardized. It means that people can do what they need to do for clinical practice. And so we actually recently looked at the NCTN Clinical Trial Network imaging data for brain imaging, and the imaging slice thickness, this is just one particular feature of imaging the brain and on MRI, ranged from 1 millimeter slice thickness all the way up to 5 millimeter slice thickness, with the highest peak being at 4 millimeters in slice thickness on a brain metastasis clinical trial. Brain metastases on MRI can be diagnosed at 1 to 2 millimeters, and I, as a radiation oncologist, treat these small brain metastases when that's the only site of disease. And so we actually did this study in 2021 that showed that if you actually reconstruct the image of a 1 millimeter slice thickness MRI, which we do at MD Anderson, you can see it at the end of the red arrow, and then you reconstruct it at 3 millimeters, that tumor disappears. And so imagine this patient actually went from one center to another center, and many patients go to more than one center. This tumor, this tiny tumor, could actually appear and disappear. What are the implications clinically? Well, if they went from a site where they were using a thicker slice image and the tumor was not there, and they appeared at a center that was using a thinner slice image and suddenly the tumor appeared, that patient might be diagnosed with stage 4 disease all of a sudden and be put on a clinical trial. Could that tumor have been present perhaps even 6 weeks earlier? Very possibly, and they may have been enrolled in the trial erroneously because it's not necessarily a new metastasis, and perhaps it's a metastasis that's been sitting there relatively stable on their current systemic therapy. It's just one example, but this is just an example of missing context and the impact of the quality of the images and how it can influence clinical care. Now, the quality of these images and that quantitative imaging can also influence the ability for AI tools to be effective. So you can actually run segmentation tools, and we've done studies where we've actually looked at the performance of the AI tools on different quality images, and this actually motivated this day one paper from the Federation of American Scientists, which had the privilege of co-authoring on the role of quantitative imaging and building out that infrastructure to facilitate quantitative imaging to allow us to really revolutionize the use of AI for precision medicine. Finally, in terms of having metadata that's readily available, but maybe not utilizing it as you consider building out the AI models, this is a great example within COVID. So these AI tools were built. There was a big global effort to actually gather images together and put it up in the cloud. And a lot of brilliant minds, lots of data scientists came together to build out these COVID models to help diagnose COVID. If you recall, back in the early phases of COVID, children were not getting sick. And so similar to what Jayshree gave us an example around age, what happened was the COVID negative patients in the early phase were largely pediatric, and the COVID positive cases were largely adult. And because these models were black box and people were ignoring the metadata and didn't account for the age, the models were actually being trained to learn the difference between a pediatric and adult lung. Now you go and throw that model into an emergency room where you've got adult after adult coming in with symptoms, and now the models are not performing because it's ignored the fact, it's learned the age difference and not the COVID difference. So that piece of metadata, the age of the patient, was very critical to actually making sure that you've accounted for that as you actually build your model. So actually, as you think through the data sets that you're working on, from training, validation, and test, all the way through the deployment, you need to pay attention to the context because it can actually really influence how you build your model, what you're considering, as well as how you're going to interpret the outputs of those models. And many people think about context and bias as the demographic differences of populations and making sure you've got representation so that the model is generalizable. But there are other aspects that can influence the model, including the availability of data. If someone is only getting scans every 6 months and someone else is getting scans every 2 months, you're going to detect progression faster in the person who's getting scanned more frequently, and you're going to be able to detect that progression earlier in that patient? And how does that influence how your model prediction is going to perform? And secondarily, the measurement error bias, many of the examples that I've been giving around the scanner, the protocol, patient cooperation, other aspects that you'll be hearing about today in terms of quantitative imaging will really influence the way that you actually need to build your models, considerations you have to take in as you use those models, as well as build those models. So when we're tackling complex questions like cancer, we can benefit from empowering that complexity rather than simplifying it, ignoring it, so it'll deepen our understanding. And that means considering both the content, the data, as well as the context, the metadata, so that we can curate, utilize that data in a meaningful way and make sure that meaningful insights are generated. And this really starts with, we can't do metadata and curation and getting, considering all the context around everything. So it really starts with defining that very specific purpose and problem we're trying to solve so that we can actually gather the appropriate data in the best way and considering that context as we both develop and implement the model. Finally, the verification, validation, and uncertainty quantification, considering both the data and the model come through so that we can actually consider how we can actually critically evaluate the confidence and trust that we have in the models and inform our decision making. So I'll end there and I'll pass it on to the next speaker. Thank you.
So we'll welcome next speaker, Dan Sullivan from Duke University Medical Center. He'll talk about requests of the challenge in the quantitative imaging.
Thank you. I was asked to talk about some really basic concepts that have to do with the quality of the data that we're talking about. And most of the speakers today, when they use the word data, have been talking about, in general, large collections of scans. And I'm going to focus on the issue of the data within a single image. And I want to start with, do this one, there. Some basic concepts, some clinical implications, and then some of the challenges. And I wanted to start with really the problem that we're trying to address. We're talking about AI to make things better. I thought because many of the people in the audience are not really familiar with clinical imaging, they might not have a clear idea of what is the problem, what's the baseline that we're trying to make better. The issue is the variability of radiologists' subjective interpretations, which has been a problem for almost a century. And there's not much that can be done about the subjective interpretations to make them better, but certainly now that we have digital imaging, we can extract objective, consistent information. I wanted to show out of hundreds of papers that have to do with variability, just this one to kind of set a baseline. This was a study done a few years ago. An orthopedic surgeon in New York was frustrated by the inconsistency of radiology reports on his patients. He recruited one of his back pain patients, a 63-year-old woman, to get a spine MRI study every other day for 3 weeks at different hospitals in New York City. And he used money from philanthropy to pay for these 10 scans, so there was no issue with insurance reimbursement or prior approval. And none of the hospitals knew that they were being studied. They found there was no interpretive finding reported unanimously by the radiologist at all centers, and 1/3 of all reported findings only appeared once in the 10 study reports. And the authors wrote, this indicates significant prevalence of interpretive error, both false negatives and false positives. And they further noted that a patient should expect to receive the same radiologic diagnosis regardless of when and where she visits or he visits, but that assumption is not correct. So just for today's purposes of this AI symposium, consider this thought experiment about this problem we're dealing with. Imagine that the radiologists at each of these 10 hospitals had access to a suite of AI algorithms that provided them with a list of diverse, objective, quantitative information as proposed here. Is it likely the 10 reports would have varied so widely in their observations or conclusions? So obviously not. And this is entirely feasible today, technically, but why is it not yet the norm? And there are many issues that people have talked about and others, but the key one is that we need very large training data sets, and for the most part, we don't have them. Another basic concept that I think it's important to convey again about the data within a single image is that all clinical images provide spatially and or temporally localized information about some property of matter with which the energy has interacted. They're not simply pictures. So every pixel actually conveys, the number in that pixel conveys some information about a physical reality. It is not just a computer construct. You may have heard the term radiomics at sometimes with regard to images. Radiomics are computer constructs. There is no physical reality behind them, but for the quantitative imaging that we're talking about here, there is physical or biological reality. And so we often think of images as visual representations of objects, but for our purposes of thinking about QI and AI, I think it's essential to realize that clinical images are ND data sets. Each individual image is a data set where N is greater than 1. It could be 2D, 3D, or 4D if it is dynamic. And each pixel in that image, as I said, conveys information about some physical or biological property of matter. We could, if we could slice up that organ and take out each cubic millimeter, for example, and weigh it or measure some chemical constituent, we would get a physical reality that corresponds to that number. And the process of interpretation, and particularly quantification, is to extract a subset of this overall data in the image. And we call this segmentation. And in biology, unfortunately, we're usually talking about a blurry, noisy data set. And by that, I mean that even though we have very high resolution scans, even if the resolution is in the order of 1 cubic millimeter, the signal in that voxel averages together the signals from on the order of 1 billion cells. So if we had a PET scan, for example, with FTG, fluorodeoxyglucose, and we're looking at a single number in that PET scan, there is a finite number of FDG molecules in that piece of tissue making up that single signal. And we should be able to get an absolute number, ideally, from our scanners that tells us what that number is. So for the benefit, again, of those not completely familiar with the clinical images, here is the situation. This is a CT screening exam for lung cancer, and the task of a radiologist or an AI algorithm would be to detect this small nodule towards the periphery of the lung and measure its size. This is the overall data set of numbers that I'm talking about. Each pixel has a number corresponding to a Hounsfield unit, which actually measures the density of this tissue. And the task of segmentation is to identify the subset of data, that is the pixels that correspond to the nodule. And it is in this region of low density Hounsfield units here. The task of identifying which pixels really correspond to the nodule is somewhat challenging, but particularly the nodules that define the edge. And that's clinically consequential because it will determine what size is measured. Also notice that there are no error bars around any of these numbers, and I'll come back to that in a moment. Quantitative Imaging Biomarkers Alliance was started by the RSNA to improve the value and practicality of QIBs by reducing variability, and a soundbite version was to encourage manufacturers to engineer their scanners to be measuring devices rather than simply imaging devices. So as I mentioned, the quantitative metrics that we extract from images are analogous to the quantitative results from any lab test on blood or specimens. And those tests are referred to as laboratory assays, and so we can refer to imaging tests, quantitative imaging tests, as imaging assays. Assays are characterized by their technical performance and clinical performance. And technical performance is usually determined by evaluating how a test performs against reference objects of known characteristics. And clinical performance is determined by clinical trials. So Kiba focused on technical performance because no other entity was doing that. In Kiba, we formed the metrology working group because of the importance of having clear understanding and definitions of metrology concepts. One of the major underlying principles in metrology is that no measurement result is complete unless it is accompanied by a statement of the associated uncertainty. So recall that those CT pixel numbers I showed you had no indication of the uncertainty associated with them, although they certainly do. This concept of measurement uncertainty is often either unknown to people or ignored. Many of the established technical parameters for laboratory assays can and should be adapted for imaging assays, and the metrology working group advised that the most important ones to focus on for QIBs are bias, precision, and linearity. And precision has two subtypes. This was mentioned earlier by Josh Rhee. Repeatability refers to measurements under the same conditions, and reproducibility, in contrast, is measurement when conditions differ. In clinical decision-making, it is reproducibility that is the most relevant, but the magnitude of reproducibility needed for any clinical use of a QIB varies according to the intended clinical use. So here's an example. These CT and nodule guidelines from 2017 gave 3 clinical decision thresholds for small nodules. If it was less than 6 millimeters diameter, no routine follow-up, and I'll call this the weight decision for my simplified graphic. And for nodules greater than 8 millimeters, there would be some intervention, and I'll call that the treat decision. So here's a schematic of the clinical problem and the Kiba approach. If a radiologist or AI algorithm says the nodule measures 7 millimeters, what's the precision of that measurement? If the precision is 2 or 3 millimeters, plus or minus, then we don't really know if the nodule might be as big as 9 or as small as 5. We don't know if the correct management decision is to wait or treat. The Kiba approach is to identify all the sources of variance in this measurement, then write specifications about what must be done to minimize all those sources of variance to get to a level of precision which is acceptable or suitable for this clinical task, in this case, plus or minus 1. Then we would have a high confidence that the measurement of 7 is very close to the truth, and we know that the correct management paradigm is the middle option. But here's another example of a QIB where the reproducibility varies according to the intended use. The FDA in 2016 gave biomarker qualification approval to total kidney volume as measured by MRI or CT or ultrasound for identifying patients with very large kidneys due to polycystic disease. And the intended use was to determine eligibility for clinical trials of therapies for polycystic disease. In this disease, the kidneys tend to be in the order of 1 liter in size compared to a normal of 300 to 400 cc's. In this guidance document, the FDA did not require any specifications around precision, which was somewhat unusual for the FDA, but their reasoning was that in this intended use, polycystic kidneys are so large relative to normal that one can reliably make that determination for eligibility in the clinical trial with any imaging test, even if there was poor precision of that test. But here's a paper from last month where decrease in total kidney volume compared to normal as measured by CT was used to evaluate kidney damage after treatment with lutetium-177 for prostate cancer. The authors found that a 10% or greater decline in total kidney volume at 6 months predicted a 30% decline in renal function at 12 months. And then they went on to suggest that this could be used for decision-making about continuing or discontinuing therapy and so forth. Now, they're not making definitive recommendations in this paper. This is just exploratory, but a 10% biological change is relatively small. And if it's going to be used as a threshold for decision-making, then the precision around that needs to be estimated. The magnitude of precision needed would be about half that, or plus or minus 5%. That's a pretty tight level of precision and would probably require rigorous image acquisition standards. In this paper, the authors provided no information about imaging standards or reproducibility of their measurement on CT, but they referenced the publicly available software they used, which was Total Segmentator. I reviewed this paper and didn't see any information about reproducibility of volumetric measurements, and I contacted the authors to be sure I wasn't misrepresenting them, and they told me, in fact, they don't have any reproducibility information at this point. One can assume that the computer output of this algorithm itself would be relatively consistent on a given scan. But when it's applied to a range of clinical scans and there is radiologist review, this introduces both a scan and reader variability, and the impact of this on reproducibility of using this algorithm is unknown. So I don't want to sound like I'm singling out these investigators excessively for criticism, because this is all works in progress and very worthwhile. And it is admittedly difficult to get reproducible information for organs or lesions in situ. I'm just using this as an example of a QIB where the clinical requirement for reproducibility varies. It ranges all the way from 0 for one indication, that is the eligibility for a polycystic clinical trial, to a very tight requirement if it's going to be used for deciding on management of cancer. And I believe it illustrates that clinicians often do not fully appreciate the importance of understanding reproducibility or getting the data to measure it when they are going to use it for clinical decision making. I mentioned it's difficult to get reproducibility data in living humans, and I just want to mention one approach would be to use synthetic data that we've heard about where lesions or organs of known size can be generated in silico and inserted into clinical scans. And I'm not going to discuss this, but just offering it as a potential topic for Q&A. One other issue that I think Caroline sort of alluded to relates to not just the imaging data per se, but the association with clinical data. This is a paper from last month, which I chose because I think the authors appropriately highlighted this issue. They took CT scans from NLST, which, keep in mind, now is 25 years old, so it's old technology scans. And they used AI to measure change in volume of epicardial adipose fat tissue on serial scans to see if it was predictive of mortality. So they're looking at a really long outcome. But even though this data is 25 years old, I know that the subjects only got a couple of follow-up scans over a couple of years. So I was interested to see how the authors dealt with that limitations of clinical data. And in fact, they do acknowledge it in their supplemental materials. And this is the text from that. They point out the 2-year imaging follow-up was short relative to long-term outcome. Important covariates were not collected. No information about medical therapies and body mass index and BSA were available only at baseline. So there really was very little information about what actually happened to the overall fat content of these people. And the authors point out correctly that you need comprehensive longitudinal data collection to understand these dynamic changes. And they are an experienced group, so it raises the question, why did they use this training data set when it was obviously not appropriate to their task? And I assume they knew that, and I assume they did it only because there's no better data set available. And this is a serious problem, and I don't know how you could take this kind of work and then go on to external validation or other validation. So these are the kinds of large data sets that we need. I want to mention that the work of KIBA is now being continued by a few organizations, including the Quantitative Medical Imaging Coalition and the RSNA Quantitative Imaging Committee, among others. And just lastly, mention a couple of comments about the challenges. One is, why is there clinical reluctance to implement QIBs that are relatively mature and reliable? And I think the overriding issue is that there are yet very few clinical treatment decisions actually driven by quantitative imaging results. There are lots of papers suggesting what QIBs could be used, but no long-term validation data, so clinicians are wary. There are some other contributing factors as listed here, which are common to the problems in healthcare. And aside from QI specifically, why is there such resistance to standardization? Some of it is passive or active resistance because people don't like to be told what to do. Sometimes it's skepticism about the need or value of standardization. There can be professional turf issues. There's need for education of both radiologists and treating physicians. And there are some regulatory issues, including particularly the absence of any national accreditation or certification programs to assure QA and QC of QI. In imaging, we need something like the CLIA program, which exists for laboratories. And so I pointed out the problems. Here are some potential suggestions to improve the acceptance of standardized imaging. We've learned from Kiba. Standard documents must state a clear rationale. They must be based on published data as much as possible, should reflect broad stakeholder input, must reflect an open consensus process, and they must be dynamic documents that can evolve or be revised periodically. So the take-home message I'd just like to leave you with is it is essential for us to prioritize and incentivize reproducibility. Thank you.
If if you have question for any of the speaker, please ask them in Slido. So let's welcome our next speaker, Paul Cunningham from University of Washington. He will be talking about centralized image collaboration for AI readiness.
Great. Thank you for the introduction. I believe my talk is going to build off of both Carolyn and Dan's talks. Thank you, guys. Just some acknowledgements here, in particular the Midrick group that I'll be talking a bit about. So you've seen this before. I believe Mike Tilkin this morning presented this. So there's about, actually I just checked recently, there's now over 1,000 algorithms approved by the FDA, a combination of software as a device or in the device. Radiology has over 3/4 of those, which is pretty remarkable. And so it's a fair question, well, why? One of the things is machine learning, machine intelligence, AI, and radiology, partly because there is a demonstrated ability that it can help. I mean, that's been well established. In addition, in particular and unique to radiology, is the digital workflows and the universal data formats, in particular the DICOM standard for transfer and storage, which generally isn't present in electronic health records or other things. So it's already close to a fair standard, but it's not perfectly fair, as I'll mention in a minute. However, oops, sorry, a sec. I think it was telling me it's my time for my talk. For AI in particular, but also for quantitative imaging, as Dan just alluded to, large amounts of data are needed. So just a large volume. And for AI, for some of the very sophisticated or nuanced tasks, it could be hundreds of thousands or even millions of images are actually needed. So where are we going to get that? Well, it's hard. There's just a lack of that. And in particular, there is a marked lack of curated data. By curated, I mean things such as Carolyn was talking about, where we know the provenance, we've tracked what's happened to it, we know something about it, we know the context, both the images themselves and the metadata associated with them. And that's because a lot of it, the majority, as you'll see, although there is a lot of data potentially available, it's all in isolated imaging systems. And the reason it's doing this is because it works quite well for the local clinical needs. For the diagnosis task at hand, generally things work well. Where we run into trouble is where we try to collect more data, pool it, and then somehow make sense of the different types of data and their formats, error bars, and which may or may not be reported. And generally, you know, there's challenges to sharing clinical data, images. Sometimes it's the lack of motivation, like why should we do this? Or even if we are inclined to do this, how are we going to pay for it? And of course, there's privacy concerns and risk concerns. So what it ends up with is that a lot of research group of these thousands of algorithms that I mentioned earlier, or 1,000 algorithms, are based on limited data sets and small sample size. So here's, I use the same, mentioned the same paper that Carolyn did, and there's another one, but it wasn't just COVID detection. There's been several papers on AI in general, as you may know, and specifically to imaging. The bottom one was, or they're both, these two are both about AI, and there's also some other analyses on this that were published around the same time. Several things went wrong. First, the one I'm going to focus on is the poor quality of the data, and a term that in one of the papers is called the Frankenstein data sets, because things were bolted together, and there were some examples the paper pointed out where cohorts of data were duplicated within it because the well-intentioned people providing the data just went and gathered data without realizing that the data they were adding was already in their collection. And this comes down to a lack of traceability, limited quality control, lack of external validation. All the information is about the provenance. There's also another key issue, of course, is the lack of valid ground truth, lack of communication, and then is the data that you're using actually representative of the populations for the task at hand? So, well, where are large data sets? What are they? So there are thousands of data sets of just images, medical images in a DICOM format available. I just went through and looked through the largest ones that had some track record behind that. And you'll see the name of the database, whether it's free or paid, what modalities are included, and whether it's multiple institutions or single institutions, because that can be an important determinant, and the number of exams. And an exam can contain anywhere from one image to thousands of images, depending on exactly what the exam was. So MIDRC, I'll talk a bit about more just after this. By the time the pending exams, it'll have over 500,000 exams available from multiple sites, multiple modalities. The Stanford AMI program has made available about half of that or more than half of that, but it's from a single institution. The Cancer Imaging Archive is an exemplar of curated data. It's really well run. It's from multiple modalities, multiple institutions. It has a little under 100,000. However, it's cancer specific, so it doesn't have other diseases necessarily, although there may be some by happenstance. The Chest X-ray 8 collection is radiography. And now you see we're getting down to the double digits of thousands here. It's 30,000. And the National Lung Screening Trial, which you've heard about several times today, which is extremely valuable, was only CT. It did multiple institutions. It's 26,000 exams available. And now we get down to the paid ones. So there are at least 3 companies that will sell you access to data. And these are indeed multiple modalities, multiple institutions. As far as I can tell, they all offer over 1 million exams. And then in development right now, perhaps was supposed to have word of this by the end of the calendar year, is the index program proposed by ARPA-H. But at the bottom, if you can see this, in contrast, I was looking up in 2023, there were over 600 million exams in the US in 1 year, procedures. And those were collected at over 12,000 imaging centers. So that's the data we'd like to have access to, if we could. I mean, there's a huge gulf. The numbers on the right column, according to Wilmec's paper, these may get us there, but it's still, that would be kind of like a minimal threshold. We'd love to have, of course, much more than that. I mentioned a bit about the MIDRC Center. It was funded by NIBIB and now also ARPA-H, and this was in response to the COVID pandemic and the lack of data. And this is a partnership between the Radiological Society of North America, you see at the bottom, the American College of Radiology. Mike Tilkin, who presented this morning, is actually also one of the PIs. American Association of Physicists in Medicine, and I'm one of the PIs from that, University of Chicago, and Gen 3 Data Commons from University of Chicago. And so basically, this is the intent here is to have something that's a curated set of data with provenance that's available, and you can sort of get the general idea of the workflow. So to date, we've ingested over 500,000 exams. It takes time, effort, and resources to process those. So we're not yet halfway through, but there's now almost 190,000 exams, and anybody can just go on. It's free. You have to sign an agreement, and then you can just download the actual images themselves. The curation then allows you to do the cohort selection. So you don't necessarily want all the exams. You may want a series of CT exams of the chest in patients with cancer or something like that. So how do you do that? Well, part of the curation process is building up a model of information of the data that you can then go through and select that. So this is just a very high-level illustration of the curation data chain. And it's much more complex than this because we have separate streams flowing through the RSNA and the ACR, but we work together, and all the data that's released is in a common bucket. So at the top right here, you can see a user will query to find out what cohorts they want. They'll get a manifest, and then they'll get links to download the image. And the Data Explorer, this is a tool that allows you to go in and pull out a whole range of criteria. One of the interesting challenges I won't have time to talk about here is the study descriptions themselves are amazingly variable. You could have over tens of thousands of different terms, or well, let me back up. You could have several hundred different terms for study descriptions that all mean exactly the same thing. So it's actually just a harmonization challenge that we had to work through as part of this, which we did with the help of LOINC codes, which was a great thing. So there was a whole bunch of other things that had to go into making this more usable. In addition, you also have to have, we believe, sequestered data. And 20% of the data is permanently sequestered and unavailable for the public, and it's just there to allow for testing or evaluation of the algorithms, potentially for submission to FDA or other purposes. And the group responsible for that has done a lot of work making sure that the data is representative of the populations you intend, both in the regular data and sequestration, and worked out methods that if you're going to test the data and come back, you don't get the same data. It's a randomly sampled with replacement process to be a statistically valid approach. And then this allows people to test things. We can provide an independent assessment, which would be sent back to the developer or potentially to the FDA. And the idea is that especially with the FDA, that this would potentially provide a route for sustainability. And why that's important is, as you've heard already, and I've mentioned, this work to have a curated data set requires resources, significant resources. So how do we keep providing that? It's great if somebody like myself is an enthusiastic volunteer at an institution and I make some data locally available, but then I'm going to move on. And then 2 years later, 3 years later, who's looking after that data? You need a process to maintain that, which is one of the great things about the other sites I mentioned, like the TCIA or the lung cancer screening trial that also looks after that. Those are curated and maintained. Another thing going beyond the MIDRC collection or centralized collection like MIDRC, TCIA, AMI, things like that. Those are great, well-controlled things, but it's still not enough data in general. So I'll just briefly mention two more approaches. And I think Dan in his next talk will probably talk more about that perhaps. First is indexing. So this isn't federation. This is just saying, well, can we at least point to other data? We can't say as much about it because we're not in charge of it, but if you need that. So you can't quite read it, but the pie chart in the middle on the left, I should say in the middle row on the left, shows in yellow the MIDRC data, but we also index directly into the TCIA data, the Stanford data, and the cancer NCI's imaging data commons. So you can, and there's a small other component from the ACR DART program. And so this already holds almost 600,000 exams. So you can then drill down to try to find the data you want. So indexing is another approach. And then finally, of course, the other one is, well, how can you do federated? So on the left is we have the centralized storage I've been talking about. And on the right is the opposite approach where the data stays in the silos. And we know that there's a lot more out there, but you can take the algorithms to train them there and update your models there. So this is my last slide. So Bob Gillies, a mentor to leader to many of us, had this statement that numbers are king and quality is queen. This has been debated of whether the assignment's correct, but the general statement remains true. Centralized repositories are valuable because they can teach us things, teach us the problems that we're running into, but we still need more data. We need more flexibility. We need better tools technically to give us that flexibility. And these options could be applied to centralized, indexed, or federated, or perhaps even hybrid systems where we have combinations of those. Curation is an essential aspect. It's supporting both AI, but also quantitative imaging or other types of analysis, if you've heard. And in addition, sustainability is a key. How do these things persist? So I'll stop there and thank you for your attention.
So next speaker will be Dan Marcos, and from School of Medicine, WashU St. Louis, who will talk about data management tool strategy for responsible image AI.
Well, thank you for hosting me today. Some quick disclosures. So any radiologists in the room today? There's a way more fun quote when there's a room full of radiologists. But so this is from Jeff Hinton, Nobel medalist and considered godfather of AI. Said this going on, about 8 years ago now. I think that if you work as a radiologist, you're like Wile E. Coyote from the cartoon. You're already over the edge of the cliff, but you haven't looked down yet. There's no ground underneath. It's just completely obvious that in 5 years, deep learning is going to be better than radiologists. It might be 10 years. They should stop training radiologists now. And as we've seen today, there's all kinds of amazing progress in AI with deep learning, beating radiologists. These are just some quotes I pulled from random papers. We've all seen many of these. And so you can look at specific tools like Total Segmentator, Dr. Sullivan mentioned, the MONAI Vista model. These can segment organs, hundreds of organs in an individual patient set in a matter of minutes. Quite well, actually. So, what is Dr. Hinton's thoughts now some years later? He's suddenly switched his views on whether these things are going to be more intelligent than us. I think they're actually very close to it now, and they will be much more intelligent than us in the very near future. How are we even going to survive that? So he said this a couple of years ago when he was the head of AI at Google, and then he immediately quit and has kind of gone, can be controlled and is aligned to humanity. But despite all of this progress, as we've heard from many of our speakers today, there's actually a whole lot of issues around AI, including around imaging AI. And as you dig into some of the findings, there's a lot of problems. So just looking at some papers, more research is needed on AI-derived software to analyze chest x-rays. AI-derived software should not be used in clinical decision-making support. That's from a British paper from the National Health Service, which found that some of the commercial software that they were using was really unreliable. And that using this software could lead to lung cancer being missed. There's a lot of issues here, despite the progress that Dr. Hinton notes. I think we've already heard from many of our speakers around some of the issues, the insufficient evidence of effectiveness and reliability, insidious bias in algorithms, unknown performance in local context. So these models trained up in like a metric data set, what happens when you deploy it locally and you don't have all the context that Dr. Chung mentioned. And then overall, how does this actually impact how radiologists and other clinicians do their daily work? So much of the work I've been doing for the past 20 years is to really think about how can imaging informatics help address these issues. And that includes the plumbing for working with the data and how to host the data itself. And that work has been done in the context of XNet, which is an open source data management platform that has been built in my lab and supported by many organizations around the world to really manage and organize workflow around bringing data in from sources and moving it through controlled workflows. Hopefully all the way out to public access into repositories like what Paul just discussed. So XNet, it's a feature-rich data platform. You can archive data coming off of sources, manage that data through workflows, and link it to related data like the kinds of context that Caroline mentioned. It's an open platform in the sense that it's open source, but it's also open in the sense that it has open programming interfaces. So you can code against the platform. And you can think of it as a platform because you can do a lot of different things with it, from clinical and translational research, building institutional data repositories, and doing data sharing programs like MIDRIC. It's funded through a number of NCI and NIH programs, which we're incredibly grateful for. Specifically, we've been building a lot of tooling around cancer research in XNet, all the way from data ingestion, from pulling data from sources, curating that data, linking it with related data sets, running automated quality control processes, annotating the data, so labeling the exams and contouring the data, and running computational workflows around that data, and eventually publishing models and data sets from it. These are just some of the tools that are built on the platform, including computable notebooks, image visualization tools, and search tools. Okay, so related to the platform, we have the ability to capture data. We have what I call the feature stack, which starts with the foundation of the source data, the data actually collected off the scanners and other devices, all the way up to the kinds of biomarkers, what I call phenotypes, that Dr. Sullivan referred to. In addition to being able to build AI models, you can use AI itself to help create this feature stack. All right, so starting with the raw data on which all the subsequent workflows are done, we have a number of different sources for finding these data, which include the kinds of open data repositories that Paul just referred to, things like Cancer Image Archive, MIDRIC, Hugging Faces, many resources for finding open data sets. These are typically free, although in some cases you'd have to pay for them. And that's obviously a huge asset because it means many, many people around the world can work with these data. So they're regularly used for things like challenges and can serve as common reference points for comparing different models. One of the issues is often these data sets are lacking the kinds of outcomes and related context that Caroline mentioned. And they often have somewhat limited novelty and specificity. They're basically whatever data sets were created by others. That's what you find in these repositories. Then there's also the kinds of commercial data sets that Paul mentioned, several mentioned here. A number of academic medical centers are actually building their own commercial outlets. So CuraMeta is actually a commercial entity formed by the hospital system at Washington University to provide commercial data sets from the patient data at our hospital. Undoubtedly, these data sets are very costly. They're never free, and though they do complement the kinds of open data sets that come in TCI and MEDRIC and places like that. And often you can get data sets bespoke for whatever your particular application is, so they can be tuned to the needs of your particular project. And because you're paying for it, the commercial companies have often done the work of validating the data and characterizing and making sure it's well curated. But the time to getting a particular data set is getting shorter, but often it takes a long time because you have to go through a licensing and contracting process. The data has to be sourced, curated, and finally delivered to you. And then there's the institutional data. So if you're fortunate enough to be at a large academic medical center, you can often work with your hospital information systems to get data sets from your hospital systems. At a place like Washington University and other academic medical centers, there's typically no cost to this for the investigators at the institution, but of course you have to be at an institution like that to have access to these data. And there's a real heterogeneity in the range of capabilities at institutions and being able to build these kinds of data sets. It's often a lot of work also to find the right data amongst the millions and millions of exams and related data in the hospital systems. And that identification of those cohorts is typically up to the researcher to figure out how to get all of that data. And depending then on how the capabilities there, that can be a very long time before you have your data set in a state where you can begin working with it. But that's the raw data, that's the base, the foundation in which all of the subsequent work of getting out to those biomarkers is built. I guess I should also mention federated data, which we've heard a bit about today already. So one of the things we've been building in XNAT recently, we call XNAT Scout, helps to build the original source data, getting it from the hospital information systems into a state where you can work with it. So it connects to the hospital systems, the PACS, the EMR, the pathology database, and indexes all of that data so it can be searchable. So if you have 50 million exams and the related reports to that data, Scout sits on top of that and allows you to search and create cohorts from it. And as I mentioned, AI can often be helpful in creating these data sets or in helping to work with these data sets. So one of the things we've done is put into Scout a language vision model that extracts features into a vector database, both from the actual pixels as well as from the radiology reports into a common space, which is shown here in the embeddings from both the images and the text reports, and puts them into a state where you can now ask questions about them. And we've all gotten used to ChatGPT kinds of interfaces that allow you to just use standard human language to interrogate some field or space. In this case, we're interrogating these data. So here are the users asking for patients under 85 with lung cancer from the whole data set, and it comes back and says, okay, I found 768 cases like that. Then the user says, okay, we'll narrow that down to cases with emphysema, and then exclude cases with pneumonia. And importantly, it's using both the pixels from the images as well as the dictated reports to find the patients that match those queries. And then the user can go into this interface and actually explore individual patients. So in this case, they found, looking at the report for one of the patients, this dictated text, which doesn't actually use any of the words that were in that individual's user's queries. It finds related words in related context and related features from the images. And if you weren't looking closely, you may have not noticed that I actually spelled emphysema wrong as a user typing this in. And because it's spelled close enough, it was able to find that using the embedded feature space, which is not necessarily the case with, standard keyword searches. All right, so that's the source data. Using this kind of exploratory tool, you can narrow down a data set from 50 million exams into just the number of exams that make sense for your analysis or for the model that you're building. But you really have to understand the quality of that data. Caroline did a really great job of kind of digging into the issues around data quality. You're not necessarily trying to find just high quality data. What you're really trying to do is characterize the quality of your data well, so understand the operating characteristics of any analysis or model that you build based on that quality. And so we've deployed onto the platform a number of quality control and quality analysis tools. So this one's called MRQI or MRKey. Generates hundreds of metrics from the images, including things like SNR and DVARs and things like that. And we've deployed that into XNet using a containerization platform. So you can take those kinds of algorithms, put them into a Docker container, and then deploy them into that container onto XNet. And then XNet deploys it into the computing infrastructure to actually execute that code. So there's a whole lot of schematics here, but the good news is the hard work is done by XNet. If you have a good quality analytic tool, it can be easily containerized, deployed onto the platform, and then run at scale. So there's a dashboard that allows you to review a particular cohort and run your quality tools against the large data sets so you can get quality metrics on 50,000 exams, for example, very quickly. And then you can get a group level report. And you can see in this particular data set, there's a fair amount of heterogeneity in various quality metrics. So for example, SNR here, there's a number of outliers outside of the group. And this would make you wonder, should those be included in my data set that I'm going to use to build and train a model, or should they be excluded? And those are decisions you can make based on the application that you're going to do, but you're doing it with eyes wide open, understanding the quality of your data. And then you can publish the operating characteristics of your model so that when it's deployed into the real world, you're only deploying it into the range of data that you've built the model against. Okay, so now moving up the feature stack a little bit, thinking about curated data. What is curation? These are all the tasks that you have to go through to, you might think of it pre-processing, all the things for harmonization and labeling and annotating that data, sorting it, getting it organized. This is the kind of stuff that for a graduate student takes up like 80% of their time. And it's like maybe 20% actually goes to innovation. So can we use AI to actually help with a lot of the curation tasks that typically are done by poor graduate students? This is the kind of thing that AI is really generally good at doing, repeatable tasks. Paul actually mentioned exactly this issue. When you get a lot of scans out of a heterogeneous clinical environment, the way they're labeled is just wildly unpredictable. So for a single acquisition type, let's say a sagittal T1, you may end up finding that the labels for that, there may be 50, 60 different labels, and so it can be very difficult to tell what is my post-contrast T1 scan. So we have built various kinds of models to automatically align the scan acquisition type to a standardized labeling scheme that uses both the DICOM metadata as well as the pixels in the actual images. And so using a tool like that, you can go from very heterogeneous labels into a standardized set. So for example, these are how the scans were labeled clinically, and then we have our standardized naming schemes here. So you can very clearly see your post-contrast T1 weighted scan. So doing that can take the curation process from literally weeks and weeks and weeks to a few minutes. Similarly, we have automated tools for if you get a heterogeneous data set. So for example, maybe you asked your informatics group for brain tumor patients, and they just give you a pile of everybody they could find that had brain tumors. But really all you're looking for is high-grade gliomas. And so you have to kind of sort through all that to find that particular tumor type. So we've built algorithms that are very good at classifying individual tumor types into various classes. So here's a model for what that might look like. And then you can see that a data set is classified into things like high-grade gliomas, metastatic lesions, and so forth. And importantly, the AI gives you some clues about what it's looking at in the image. So you can see it's actually looking where the tumors are located, which isn't to tell you that it's definitely looking, using those pixels to classify, but it helps to assure that things like that Jayashri may have talked about this morning or others, that there are other artifacts that could bias what the model's using to classify by tumor type. And then moving up the feature stack even more, we're getting closer and closer to the kinds of biomarkers or phenotypes that can be used to make clinical decisions. What kind of computed features can we extract from the images? So these are things like the radiomics that Paul mentioned earlier. These are the computed features, but they can be very sensitive to the underlying data distribution, which is why all those preceding layers of the feature stack are so important to characterize that data before you're going into the sort of computed feature space. But these computed features can be really helpful in building models. You're kind of leaving that individual image space and moving into numeric space. You can hand these data sets to your colleagues as spreadsheets instead of thousands of terabytes of imaging data. And there's a lot of different kinds of features that can be thought of as part of these computed data. Typically, they fall under the category of radiomics. They include things like intensity-based features, histogram-based features, textures, and the like. Okay, and now moving finally up to the top of the stack, we have our computed phenotypes. And these things align to attributes of actual disease. So something like maybe a molecular characteristics of a tumor type. And often there's other ways to get at these phenotypes. So for example, doing an invasive method like a biopsy. So a computed phenotype can be very helpful in being either non-invasive or done earlier in the workflow to help guide downstream clinical decisions. So phenotypes, biomarkers, for me, those are largely identical and synonymous. This is kind of the end game of what many companies and labs are working to build. This is just an example of some that we've built in my lab around glioma, of looking at can we characterize the molecular classification of IDH and IP19Q status. And we built a number of models in this direction. They're really quite good at getting very highly accurate prediction of molecular classification. And what we've now built is kind of a full proof of concept around this feature stack, all the way from getting that source data from a hospital system, building specific cohorts around that, doing the quality metrics and quality assessment of that data, and then doing the feature extraction for radiomics and automated tumor segmentation, all the way out to that kind of tumor classification. And all of that has been built into automated tooling on the XNet platform. So we can look at the specific feature steps and we read one. Okay, yeah, almost done. Yeah, looking at the different stages of the processing, all the way from the scan type classification all the way to the molecular classification. And then finally, that's built into just containers on XNet. So as soon as a patient comes onto the platform, you can launch that entire processing stream all the way from quality metrics out to patient classification. So just very quick summarization, lots of different ways to do AI, but all of them really benefit from having this kind of characterization of the data, and that can be supported through an informatics platform like XNet. So thank you.
So I'm going to ask a warm-up question to get the panel going. So we heard four different perspectives about AI, data readiness for AI. So we heard about data quality, data quantity, metadata, data context, data management are all important in the AI overall life cycle. So are we teaching this important concept to students in university? Do we have an education gap?
An education gap for the users or radiologists or both? I would say both. I'll answer my question. Yes. In terms of data quality, specifically for quantitative imaging that I was focused on, I tried to give some examples where people don't understand that there is an issue of reproducibility around each pixel value and the overall quantitative result that you get from that. And I think particularly there is a non-understanding amongst a lot of users, referring physicians, ordering physicians, that quantitative metrics, quantitative properties can be extracted from images. They think of images as pictures, and they don't think of them as a source of quantitative metrics in the same way that they would think about getting lab tests on tissues or specimens. And one of the interesting examples that just as recently came up at our institution that I'll mention in connection with this, I mentioned this earlier to Paul and Caroline, is that there is an imaging, an AI process for extracting volumes from brain MRIs. And probably a lot of people who are ordering brain MRIs know that, but many of them don't. And at our institution now, for the first time, when they put in the ordering system, when a neurologist or a neurosurgeon orders a brain MRI, there is a drop-down list that allows them to choose which actual image acquisition protocol they want used for that brain MRI. It's a very different paradigm because in the past, radiologists were always the ones who would decide how imaging would be done based on what was ordered. But in this case, the ordering physician now has the option to choose quantitative brain analysis. It's one of the image acquisition parameters, which has a CPT code associated with it, which means there will be a charge for that to the patient's insurance company. And the reason this is being done, actually, and this is what drives a lot of issues in healthcare, is to increase reimbursement. But a side effect or a side benefit of this is I think it's going to educate the referring physicians that this exists and that they can, in fact, order it. So I think that has been a big gap in the past.
I'm not sure if I exactly heard the question, but I think it referred to education issues. And for me, one of the biggest issues is the gap between the people who build AI and the people who consume it. So like I have a lot of grad students in my lab, they're all in computer science or electrical engineering, don't come from a biology background or a biomedical background, and don't necessarily have intuitions about how a radiologist experiences their workflow, and don't necessarily have intuition about even how to look at an MRI scan. So they'll come in, they'll go spend a week or something building a model, and then they'll come into my office and say, oh yeah, it performed like this, it had this such and such dice score, and such and such dollars or whatever. I'm like, well, did you look at the scans that looked like they were failing in the model? Like, no, they were just failing. I'm like, well, you really ought to go look at them. And then half the time they go look at them and I'm like, it was a foot and it was just labeled wrong and it was, supposed to be a brain. But they don't even, have necessarily the thought around, let's go dig into the images. And so that wasn't obvious to me as a person who came more from a biomedical background until I'd started working with grad students. And now I'm really careful to make sure that like one of the first things they do in coming into the lab is to spend a day in the reading room with radiologists and really seeing what it looks like for them to practice radiology. And I think it changes the way they think about how to build a model, and certainly shows them how to at least open up a scan and take a look at
it. There is a huge training gap. I think that we're sort of like at the invention of a car, and people are mechanics and they know how to make the car, but then you may be living on an island and what you need is a boat. And so to your point, they may just be building the wrong tool. And these are the people who are actually the engineers who actually know how to build these things. But even the people who are actually going to use these tools, we don't just release people onto the road without driver's licenses. And I think that there's no driver's education at this point that is really in a stable setting where we've actually set limits and saying these are the things that people need to know, understand, and know. At MD Anderson, we've actually started to build out a data literacy program, and I think that there are increasing requirements around data literacy as well as AI literacy over time. The Texas state has actually started to require some of this base level of training, but it's coming at everyone so quickly that I think those pieces are just not yet in place, but there's certainly a training gap that needs to be filled over time.
Maybe I could add a slight variation on that. I think there's also a gap related to knowledge or training in that, for the long history of radiology and practice, where it's used locally, a local physician, referring physician wants a scan, they get scanned, the radiologist interprets it, gives the results back to the referring physician, and now the patient typically reads it before the referring physician these days. That works well. I mean, it's a system that works well. What we have, though, is that if we also want to use that data for other things, such as AI algorithms or quantitative algorithms, then there's a gap in the knowledge of what's needed for that, both in terms of like the data integrity or curation, as well as just how do you manage large volumes of that. There's also, I think, a lack, an educational gap in that aspect as well too.
I think I could try to combine some questions from the Slido, and I think two of them plus myself, the similar question relate to this. So I think Caroline, to you, I echo your slides. You were talking about the clinical notes. There's so many duplications over there. I think that's really true. So the stories I had last year was teaching a student, taught the medical student, the summer student, so working with me. So we started to build the AI agent. I thought it's okay. What's the big deal, right? You can try it. We started with to extract the patient age from EHR, right? You thought that patient age should be definitive answer. You have it in the metadata. You should get 100% accuracy, 100% precision. But actually, we get very low, and we just dumped the data from Epic, and the students started running the prompt, and we cannot get everything correct. So look at the data, we found there's so many copy and paste. Along the patient, the longitudinal record, the age change, and sometimes there's a typo in the birthday. And so I found that this is very hard. So that's part of this AI for readiness, right? So the models we're building, we think that would be good, it will train for the ideal situation. But actually, when you deploy to the use the real world data, you realize there's so many challenges. This link to this is two Slido's questions while the audience asks the garbage in, garbage out, right? It's all common audience. We know that for many, many years. So how can we make sure that our model to prevent garbage in and garbage out? Second, relate to this that if the data quality is so important and saw this gap from the real world data to the actually input data you train for the model, can we use AI to do the data curation in the middle? So you have some AI models looking at the kind of garbage data, but laundry out the clean data, and then pipe into your powerful model to do the prediction. So what is wrong with that?
I'll take your example of the patient age, because this is a great example. So you went to the actual clinical notes to find the patient age. So this is starting with the problem. You're trying to find the patient's age. And you knowing that's what you're looking for, it can actually inform where you want to find your source data. And your source data is probably not the most reliable in each of the progress notes and clinic notes. You probably just want to go to the patient's date of birth, which is registered with their ID, and then calculate to the date or whatever granularity you need the patient's age at whatever point in time that you need. And so your source data that you selected has created the challenge of actually curating the data. And so there's certain sources of data that you can actually find that are more reliable. And so I think that, again, starting with what is the question that you're trying to tackle, and then finding the right source data with the appropriate metadata. And that data is probably consistent. So if you want to build a model around that versus looking through the EHR. I think the other comment around the EHR notes is that remember that although we're treating the EHR notes as raw data, it's actually not raw data. It's the raw documentation of what whoever the clinician is, and it's their inference and their recollection of that system. Now, things are changing. There's ambient listening and all of that's coming through that could potentially change what information we're capturing. But all the historical EHR data up until now is really the clinician's inference of what's happened and documented and filtered of what is relevant that's in the chart. And so I think that's just a point of context for people to realize that they're actually using this data as they train models.
But just the other point you raised, I think there's two that were pretty closely connected, garbage in, garbage out, using AI to help curate the data. Dan Marcus actually had a slide showing that they deliberately used AI to curate or quality control the data in his stack. And that's a well-accepted technique now over the last several years because the volume of the data is just so large and so complex that it's just impossible for humans to go through manually now and do enough of it. We can do it on a limited set for a few specific really critical variables like study description perhaps, but not for the vast amount. So we need AI to prepare the data to get it ready to properly train AI, so-called helper AI. Another thing about the garbage in, garbage out, I think both Carolyn and Dan alluded to this, but I think it's an important point. So talking about the quality of the data, it doesn't mean that it's necessarily held to a rigorous standard and we can prove that. It just means that we know something about it. So data that's blurry or has artifacts may still well be useful for what we need to do as long as we know that ahead of time. Because images will be collected with so-called standard of care, which means do whatever you normally do. And that's okay because as long as we know something about the quality of the data, then we can use that as the context for training and selecting data. And Dan mentioned that in his talk. But I would go a bit further. Even if we don't know anything about the quality of data, we should just simply say that. We say, look, we have no idea if anything about this data. You could be asking for a brain image, and you may well get a foot. That's an important thing. And bringing that back to the garbage in, garbage out, well-designed methods will be trained for this, or will, have safeguards, and that's part of the trustworthiness. That, there have to be guardrails built in, and in the early days, this didn't happen because, the people developing the algorithms would download, terabytes of data and just assume it was everything that they thought they were getting, but that may not be the case. I think, in general, though, the people working in this area are more sophisticated about that.
Along that lines, I think this is where we often, when you roll the algorithm out and then you run the AI model in the real world, and all of a sudden the model doesn't perform, everyone points to the model and says, the model's not working. But it may be that the quality of the data going in is now completely changed, and so why would you expect the model to perform the same way?
I think I totally agree. So I guess, put the model into the real world depends on your input data, right? So as Caroline pointed, if you there's from the EHR, there's a lot of things we don't know, and there's a lot of, garbage actually, whether I think maybe we need to build something in the middle. It's really not just release the model, you also release your pre-processing, either use AI or you have some solid pre-processing pipelines. But that pipelines also depends on your input data, right? Input data can change. If you switch your EMR from, let's say, Allscript to Epic, the format is completely different. And if you variation between different physicians, that could be different. So for image, maybe the different scanners have a different variations. So that's make this AI deployed to the clinic. It's very challenging.
We are running a little bit behind on the agenda. We will have 5 more minutes for question, and then we'll go on a break. So I'm going to ask my last question from the Slido. Is there a downside of using AI to create data set that will be used to train AI model? How do we ensure that bias and error is not being propagated? Probably question for
take a first stab at that. It sounds like inverse crime is the term that we use. Like you're using the AI. That's a great point. That's where quality control comes in, and making sure that you're not using the same AI to curate the data as you're going to train the data with. I mean, then that would be what we call an inverse crime. So I think there at least it would be attention to detail. And in general, they're just doing very different tasks. I refer back to Dan Marcus's talk at the end. When you looked up his technology stack, the questions at each level that were being answered were very different in the data being produced. So I think it's an important thing to be careful about, but it's also, I think, a manageable issue.
I think that's right, but maybe to generalize that, a belts and braces types of approach where you are using different models and different approaches at different stages is an important way to protect yourself from doing something stupid or something insidious in your approach that you hadn't considered. So using different models, doing some human in the loop steps, things like that, so you're not just fully dependent on some sort of autonomous AI, like building the whole thing, I think is really important.
Okay. Is that last thing or the speaker again? Take a break for.
Hi, everyone. Actually, we're going to take a slightly longer break, so we'll reconvene in about 20 minutes, around 4:40. Thank you. Hello, everyone. We're going to go ahead and get started in just a moment. We are actually going to change up the agenda slightly. I know that we have had such a wonderful day of discussions, but I know that it is, there's been a lot of content for us all to think about, and I want us to have fresh eyes for tomorrow as well. So we're going to change up this wrap-up session. Originally, we were going to have Everyone kind of present on the 3 various subfields, but instead, the planning committee has offered me quite a few high-level bullet points, and so I'm just going to summarize that. And since I think I had an introduction earlier, but I didn't fully introduce myself to you all, I am Daniel Mulro, and I am the staff director for this symposium. So it's been an honor to work with all of the planning committee members and all of you speakers, and it's been great to interact with the audience that's visiting. So, for closing remarks, as we close out today's discussion, let's take a moment to reflect on how we began and the key themes that have shaped our conversations. This morning, our first 2 talks set the stage for everything that followed. We started with a look at AI's transformative role in healthcare, where we saw how AI is not just supporting clinical decisions, but actively reshaping how we identify risk, diagnose disease, and improve operations at scale. David Rue's presentation underscored AI's ability to proactively detect health concerns, optimize workflows, and expand access to care. Themes that carried through our discussions on AI's role to radiation therapy, diagnostics, and public health. We then turned to the question of safe and responsible AI implementation, where Mike Tilken emphasized the need for structured governance, transparency, and oversight in AI-driven clinical environments. His focus on regulatory frameworks, federated learning for data privacy, and AI validation laid the foundation for our later conversations on AI readiness, ethical considerations, and ensuring human oversight in decision-making. Throughout the day, we saw these themes play out in diverse applications, from AI-enabled adaptive radiotherapy and diagnostic imaging to occupational safety and data readiness. Across these discussions, one message was clear. AI is a powerful tool, but its impact depends on how we use it. Just to recap a little bit more, we heard presentations that illustrated how AI is transforming cancer care through the treatment continuum, from diagnosis and data interpretation to treatment planning and delivery. We heard complementary perspectives on the future of medical imaging and AI, considering the maturation of devices, softwares, and processes, and promising AI image analytics for insights. The panel discussion from that session emphasized a number of challenges and gaps, particularly the need for more image pathology integration to bring biological understanding from medical imaging data. We heard a lively discussion on the importance of synthetic data and the wonders and challenges of using it, and that data standardization will be critical to scale up AI solution and enable data democratization, but recognize it is too idealistic to imagine a consortium with one set of standards. Finally, we listened to a great panel on data quality, curation, and management. They emphasized the importance of your source data and knowing the specific query that you're hoping to derive insight from the data set that you plan to use. And they emphasize the importance of training new researchers on how to think about the data and the data sets that they're working with. As we look ahead to tomorrow's case studies, I encourage you to consider a few key questions. How do we balance AI's predictive power with the need for human oversight in high-stakes decision-making? What are the risks of AI reinforcing biases, and how can we ensure diverse and representative data for training models? Where do we see the most immediate and practical applications of AI in our respective fields? And what are the barriers of implementation? These are the kind of questions that will drive tomorrow's discussions as we explore real-world case studies and move from theory to practice. Each of us comes from different backgrounds, and we each have questions about AI. I encourage you to bring those with you tomorrow and ask them. So with that, thank you all for your engagement today, and I look forward to the conversations ahead.